This is a morning session. We will start with peripheral vascular interventions, and I would like to announce Dr. Theodosius Bizdas, who will tell us something about vessel preparation for complex femoropopliteal lesions. Please, Theodosius.
Thank you very much. Thank you for the very kind invitation. Good morning to everybody. Okay, perfect. So the title of my presentation is Vessel Preparation for Complex FemPop Zones. So why we are talking about vessel preparation? Of course, the beginning of all this story was these publications about the severity of calcium and the long-term results in the FemPop area. So Okuno showed in the Journal of Endovascular Therapy that when we are increasing, when the calcium burden increases in the FemPop area, then the patency decreases, and despite the fact that we have changed multiple times the classification of calcium, always it was the same problem, that the amount of calcium affected directly the rate of the patency. So when we're doing an angioplasty for a calcified disease, we have an overstretch of the non-diseased tissue that may cause dissections, recoil, and sometimes due to the fact that we have a severe plaque there, we can have an excessive injury of the intima and media, and all of these things are leading to poor outcomes after the angioplasty. So in this context, we defined a few years ago the term vessel prep. Vessel prep is the way that we're going to have less dissections, better luminal gain, and a better plaque modification. By this way, we're going to have an increased drug uptake. When we are talking about drug-coated balloons, we're going to have less permanent scaffolds, less stents, and at the end, we're going to have an improved patency. So the new understanding of nowadays is that vessel prep is not a treatment strategy, is a method to increase the luminal gain, to change the compliance of the vessel wall, and finally to improve the outcomes of a definite treatment option. At the moment, we have a big amount of different vessel prep devices. The majority of them, they are under, let's say, investigation by means of creating evidence. But at the moment, the most well-investigated devices are the atherectomy devices, and from them, we're gonna see two devices. The one is the directional atherectomy. This is the HOC1 from Medtronic, and the orbital atherectomy, which is a completely different way of thinking. So looking at the directional atherectomy as a vessel prep tool, we have seen that compared to all the other devices like the Jetstream, which is a rotational atherectomy, or the laser atherectomy, this is the one device that causes the lowest rate of dissection postoperatively, from 0 to 5%. The directional atherectomy as a standalone therapy is not really successful, except of the definitive CA trial. That means a trial that we have really severely calcified lesions, where we could see that the bailout stenting was only 4%. This is an amazing outcome, but we still had a number of complications, which, in my opinion, the most important was the distal embolization, which is 2.3%. So what was the conclusion of this paper? It works very fine to remove the calcium, but always keep in mind you need the distal protection device. This is, in my opinion, the ideal case for atherectomy, eccentric, highly calcified lesions that there is no other way to remove the plaque. Any stent we're going to cause a recoil there, and even lithoplasty balloons, we will not create the outcomes that the directional atherectomy creates. Looking at the evidence, we have the data from the definitive AR trial, which showed that actually in lesion length that they are above 10 centimeter or severe calcium, we had a trend for better outcomes. However, the number of patients was too low in both groups in order to have statistically significant outcomes. Based on the results of the definitive AIR trial, Medtronic initiated the reality trial, where we are talking about long lesions and highly calcified lesions. You can appreciate here the study data. So we have a PAX 3 or 4 in 86%. We are talking about severe calcium calcium, we are talking about bilateral calcium in almost 70%, mean lesion length 18 centimeter with 39% occlusions. So if you look, we are talking more or less about our real world practice. And the primary patency in this case was, in my opinion, very encouraging, about 77% at 1 year with very few major adverse events. This is a case example of what reality trial included: severe calcium predilatation in order to have the ability to go up and down with the HOC1 device, and this is the final outcome. I mean, very few devices could succeed such a final vessel preparation. Looking now to the orbital atherectomy, the FEMPOP area, it didn't work very well compared to plus DCB compared to DCB, so it was not really, so it showed no statistically significant difference. On the other hand, orbital atherectomy seems to work very well for below the knee arteries, but not for FEMPOP arteries. And we have the direct trial, which compared directional versus orbital atherectomy, and we have seen a greater plaque volume reduction that was achieved following directional atherectomy compared to orbital atherectomy, and a greater percent stenosis reduction was achieved following directional atherectomy. Now, going to the second vessel prep tool, this is a scoring balloon. It is a vessel prep that everybody loves because it is not too complicated. You don't need any extra equipment. You're just inserting a balloon inside, and it does the job. It is assembly compliant nylon balloon. The most famous is at the moment from BD, the Ultra Score balloon. It goes up to 8 millimeter. It is compatible to 5 and 6 friends. The good thing is that it has an around 15 to 25 scoring force. That means these small nitinol wires or nitinol scoring elements, they are locked into the plaque, and due to the force that they are providing, you have a low dissection rate and a better lumen gain. And this has been proved by the paper from Hori, where actually showed that we had, compared to balloon angioplasty, much better outcomes, less flow limiting dissections. Same outcomes in the Panther registry, where they have done it in a severe calcified lesions, and you can see that the primary patency at 12 months by using scoring balloons and DCB was around 82%. Now, the last important vessel prep tool that it is very everyone loves when you're starting using this is the intravascular lithotripsy. This is a so-called shockwave balloon. The shockwave balloon actually creates and lumen gain through energy transfer, and by this way it can really breaks the plaque and create a very nice final outcome. There are some important tips and tricks that you have to know when you're using your IVL. Of course, you need an overlapping. The majority of the energy comes from the middle of the balloon. So all these things you need to know when you're starting using this device. However, looking at the data in the PAD3 trial showed that IVL versus POBA prior to DCB showed a better treatment effect regarding procedural success, and by this way it has a better outcome by means on luminal gain, recoil, and less dissection. This was the composite endpoint of procedural success. And looking completely at the data of the PAD3, we had 44% lower pressure to achieve better results, 75% reduction in provisional stent placement, 69% reduction for post-dilatation with IVL, and 77% reduction in flow-limiting dissections. In the Disrupt PAD3 randomized control trial, we show at 2 years a 74% primary patency compared to 56% with just PTA, and we are talking about severely calcified patient population, and you know that PTA doesn't work there. We have done our own study here by looking the addition of DCB, because until now we know only if IVL works, but we don't know if DCB improve the outcomes. And this was a single center study, single arm, retrospective analysis of prospectively collected data, and all comers were inside. What we have seen here was that we have a lot of diabetic patients, a lot of patients with chronic kidney disease, and the Rutherford classes were up to class 6. There was only one perforation, a peripheral embolization, and 2 flow-limiting dissections. And this is, as I said, it was FEMPOP long lesions. And what we have seen was that the primary patency at 12 months was 81%, 24 months 68%, and the same almost for the freedom from TLR. This is a classical case of severely calcified FEMPOP, where you were using the shockwave and then the impact DCB with a nice final outcome. So at the moment, we don't have data to compare directly IVL without DCB versus IVL plus DCB. What, however, we have to know is, regardless if we're going to use DCB or no DCB, the most important thing, we need vessel prep even before any kind of stent implantations like the Supera, which has been shown that before implantation needs always to have a very good vessel prep to create the space for it. So in conclusions, at the moment we don't have a commonly accepted definition regarding vessel prep. We have a lack of level 1 evidence regarding this. Vessel prep can be used to improve the outcomes of endovascular treatment in complex femoropopliteal lesions, and by this means I mean long CTOs, calcified disease, and no stenting zones. Thank you very much for your attention.
Thank you, Theodosius, for a very nice presentation. This is a complex area, femoropopliteal artery plus calcifications. That's really, really challenging. Are there any questions from the audience? Which of these devices do you prefer to use? Do you select it on a patient-based, on a lesion-based? How do you choose them?
I was afraid of this question. So at the moment, I'm trying to create my own algorithm, but it is, as I said, is my own algorithm. It is not based on evidence because we don't have any direct comparison trials. Due to the fact that atherectomy needs a lot of radiation, a lot of repeat angiographies, I don't like it at all for CKD patients with chronic kidney disease. So I prefer directional atherectomy for eccentric lesions and only that. I'm using for fibrotic lesions without calcification, I'm using scoring balloon because I don't see any really big advantage of using any other vessel prep there. The job will be done by the scoring balloon in a very nice way. And I'm using IVL for any other type of circumferential calcified lesion.
Thank you very much.
As simple as possible.
Thank you very much
Thank
for
you.
this
Thank you.
nice answer. Thank you.
You're welcome.
The next presentation will be by Dr. Saško Nikolov. He will be telling us about something about romantic rendezvous, peripheral pelvis card technique. Please.
Thank you. Thank you for the organizer for organizing this kind of meetings. It means a lot to everybody in the Balkans region. I have nothing to disclosure, so I will start immediately. It's a patient, a male, 68 years old, came with a pain in his calf and in his thigh on 100 meters walking. He knows about his peripheral disease since 2015, when he did a CT scan where we find the occlusion of the common iliac artery, superficial femoral artery, and some significant some stenosis on the iliac externa and femoral common artery. In the meantime, the patient had a myocardial infarction, 2015 stented CX obtusa, again second infarction in 2016 with RCA stenting and elective stenting in 2017. So the patient, we did the ultrasound now, we have posterolateral hypokinesia, duplex of the carotid arteries, 30-40% stenosis, duplex of the lower limbs, and we did the ankle brachial index where it was index 0.5, that means moderately abnormal. So the suggestion was to do another CT scan. In the CT scan, you can appreciate occlusion of the iliac common artery, occlusion of the iliac external femoral common artery, and occlusion of the superficial femoral artery. So these are some collaterals that you can see from the lumbar lateralis dextra that are not quite They're not quite large here at this point. And some another collaterals coming from the epigastrica superior, going down to the femoral profunda. So this is the collateral that was made from femoral profunda to the popliteal region. It's a quite good bypass, natural bypass grafting actually of the superficial artery. And this is the occlusion and the problem where the patient is having. So this is the distal cap of the occlusion. This is the proximal cap of the occlusion. And by Fontaine-Rutherford classification, the strategy was we call the consilium and vascular surgeon. But the patient strictly refused the vascular surgery, and the peripheral intervention strategy was to have a double approach access, anterograde by radial right artery and retrograde by femoral profunda. So this is the radial access when we continue through with a flexor 6 French down to the occluded region of iliac common artery. This is inside the flexor. I think it was Simon 125 centimeters 5 French. And this is actually both sides anterograde and the retrograde approach, so we can start the intervention. So we start the intervention anterogradely with the coronary CT wire with the balloon support on the wire, and the wire went to subintimally and didn't want to go any further, somewhere in the middle of the iliac external artery. And in the meantime, I didn't make a lot of graphics. It was on fluoro, so I didn't catch savings of the intervention. Because we stopped anterogradely, we continue retrogradely with another CTO coronary wire with a 40/40 balloon. So the wire went again subintimally somewhere near the iliac common artery. So at this point, I decided to make a simultaneous balloon inflation in the antero and the retrograde approach and try to disrupt the intima, dissect the intimal flap, so I can go into the real lumen. So this is after several attempts of predilatation. I finally take the wire into the right lumen to the introducer and make the externalization of the wire from the right hand and to the right eye. So at this moment, I changed the intervention from antero to retrograde approach, and we made the predilatation with 5056 balloon, again with another 50 by 120 centimeters balloon, and this was the result that we received after the predilatation. There is a huge dissection in the pelvic artery system, but dissection goes directly to the profunda. That was encouraging us that we can continue with the stenting. So we applied the first stent in the iliac common artery, then applied the second, the self-expandable 9056 stent in the external iliac artery and a balloon expandable in the femoral common artery. It was higher from the inguinal region, and make the post-dilatation with 80 by 56 for several times, and this was the final result of the iliac, of the pelvical arterial system. So we see that we have now pulsative flow to the profunda, and we have now resolved the problem because the FAS has a huge collateral by profunda. But this intervention lasts for 1 hour, 50 minutes, around 30 minutes radiation, 250 milliliters of contrast, 3 stents, several balloons, several wires, guiding catheters, introducer, etc. Is this all that as interventional radiologists, interventionalists, we can do for our patient with this kind of problem? This is just a debate that I'm starting it now. We know that the vein system has to take the blood from the arterial system back to the heart. So aorta gives the arterial blood to the lymph arteries through the arterioles, capillaries, and venules go from the superficial veins back to the deep veins and then back to the heart. But in ideal situation, what happens when we have insufficient dilated superficial veins like vena saphena magna and vena parva? In that case, we have increase in resistance in the venous system. That means retrograde increases the resistance in the venous, capillaries, arterioles, and then in the arterials. So in some kind of case, we have a low peripheral hypertension. That means increasing the atherosclerosis of the arteries, atherofibrosis, calcified lesions, and that means that this arteria, especially below the knee, have calcified subocclusion and occlusion lesions. And this is maybe the reason why a lot of cases where with a good preparation of the vessel, with a good the sizing of the stents or vascular bypass grafting, again, we have a better results as outcomes. So this is a patient, I will go shortly, a young man, 28 years old, ex-football player, came 3 years ago with occlusion, with a pain in the right leg. We made the ultrasound, there was occlusion of the FAS, so we made the CT scan and there was occlusion of the acute occlusion of the right FAS, CT occlusion of the left FAS, and CT occlusion of both tibial arteries of the both legs. So we managed to do POBA of the FAS and we achieved good result. TIMI3 without dissection, and we stopped there. But after 10 days, the patient came back with another severe pain in the leg, and we have to stent the FAS in the mid-segment. After 1 year, the patient came again with a severe pain in the right leg. There was occlusion in the proximal segment of the FAS. We made a preparation, we stent the FAS in the proximal segment, and there was instant restenosis into the mid part of the FAS, in the instant. After 6 months from this intervention, patient came again with a pain in the leg. There was occlusion in the femoral common artery. We stented. We offer, in the meantime, the patient, we offer surgical consultation, we offer genetic investigation to be done, but the patient refused to do it. And we speak about a patient that is actually working as a dispatcher 12 hours per day sitting in front of the computer. Before 6 months from today, the patient came again with a cold right leg with a severe pain. We made again the CT scan, and there was occlusion of the whole femoral common artery, superficial, profunda. There was no blood. There was some very, very tiny collaterals that goes down to the some region of the femoral region. We offered the patient that he has to go to surgery. He refused it. He strictly refuses to go for a cath lab intervention just to reopen maybe profunda so he can refuse it. And he left the hospital. He came after 1 month now with lost sensation of the foot, lost motorics of the finger of the foot. And at this time, in our institution, we continued with the Doppler of the arterial, and we do parallel Doppler of the superficial venous and deep venous system. So we did this Doppler, and we see that there was a dilated insufficient superficial veins. Saphena magna was around 7.58 millimeters with a severe grade of reflux. So I offered the patient, let's do sclerosation of the whole length of the vein, just to see what is going to happen, because we have already around 20 patients that were with the multiple vascular disease, surgical treatments and in the vascular treatments, and after the sclerosation of the whole length of Saphena magna, the outcome was better for the patient. So he accepted, because the reason was he will leave the institution in 1 hour, 2 hours, and we do sclerosation. So the sclerosation that we're doing is we do the ultrasound, the vena Saphena. This is not the actual patient. This is just a random case that I put for this presentation. You can appreciate the dilatation of Saphena magna. And this is one of the smallest Saphena magna that we have in our country. Trust me, 20 millimeters dilatation. We mark the femoral saphenous junction where we stop the flow. The second marker is where we comes with the catheter, so we start the diffusion of the cryonoacrylat, and the distal point is where we make the puncture. We make the puncture in the distal part of the vena Saphena magna, and we put the introducer, we put the catheter inside, guided by Doppler, on the second marker, so we start the diffusion of the cryoacrylat, and after the diffusion of cryoacrylat, we have around 60-second compression of the whole vena Saphena magna system. So this is the intravenotic sclerosation of the whole length of the vena Saphena magna. The patient, after 2 hours, have the symptomatic therapy, and his subjective cause was that he felt the warmth of the leg. He started to feel the foot, and this was all that we achieved up to now. After 3 months, he came, and this was the CT scan that we did after 3 months. The left one is before the sclerosation, and the right one is after 3 months of the sclerosation. You can appreciate a huge, tiny collaterals that are now shown in the femoral region. You can see the huge collaterals that are done in the lateral part of the femoral region. You can see the collaterals all over the leg. You can see below the knee collaterals that are there, and in the left, in the right leg. So the thing is, the intravenotic sclerosation of the superficial veins are there our new bailout system. This patient, after 3 months, he was walking 50 meters before the claudication came. After 3 months of the sclerosation, he can walk around 1 kilometer. Before I came to Sofia, I spoke with the patient, he can walk more than 1.5 kilometers per day before the claudication came in. He feels the warmth of the leg, the sensation, and the motoric of the case. We have up to now around, in the 4-month follow, 30 patients that were with the CTO peripheral artery disease, multiple surgical treatments, multiple in the vascular system, and all patients have a peak systolic velocity raising up after the sclerosation. Walking distance from 15 to 5 kilometers. One of the patients is 11 times surgery, bypass surgery of the leg, and 5 years he couldn't walk more than 100 meters. Now he can walk 5 kilometers after intravenotic sclerosation. So, always provide the best solution for the patient using dual approaches for the CTO cases, mixing skills of the interventional cardiologists, radiologists, surgeons, vascular surgeons, phlebologists to provide much better ideas and much better result of the patient. And we always should treat the occlusion, treat the patient, not the occlusion of the system. This is my born city Štip. I hope that this is my hospital, that in the next period we will be organizers like this in Sofia. So I will invite you to become my guests here. Thank you for all.
Thank you very much for the nice presentation. Of course, pathology is difficult, and excluding venous pathology is always important. So yes, think also about the veins, yes.
Very interesting, how to say, mind about the problem of arterial disease and combined venous pathology. The problem is that in many cases we don't have venous insufficiency, and this cannot influence any way the arterial problem. And in my opinion, in many cases, probably the conservative treatment is the thing that's doing the job.
No,
how can you say that this,
yeah, but
the venous reflux management is the reason for improvement?
We have a patient, in those 30 patients that we have for 3 months follow-up, patient that were done surgery 3, 4, 5 years ago, stenting 3, 4, 5 years ago, and the distance of walking, the subjective findings were that were actually restricted in distance walking, restricted in the warmth of the leg. And after the sclerosation, the peak velocity of the collaterals that we had, it was tripled after 2 hours of the intervention. This was done 5 months ago in a patient with 11 surgery of the leg, and he couldn't walk at all. He came for endovascular treatment, and there was really, really hard to do it because he has some tiny collaterals. And after the treatment, he started walking. And this is the reason why we start following the venosis, superficial venosis system of all patients that have a CTO peripheral disease, symptomatic. And actually, they were done several surgical or endovascular treatments. So, of course, not every patient has the superficial insufficiency, but most of them have. If you follow them, you will see that most of the patients have venosis insufficiency.
Okay.
Any other questions from the audience? Okay, next presentation will be critical limb ischemia, indications, procedure, and follow-up.
So thank you for the introduction. I would like to thank organizers for nice invitations to this summit. There are many things in medicine we still don't know, and it's fascinating after 10, 20, 30 years. being in medicine, there are still some new things you can find. Today, I will limit myself mostly to the things we already know. In mine institutions, we are doing about 1,500 procedures, vascular procedures per year, and about 500 of them are critical limb ischemia. You see that the survival of patients with critical limb ischemia is really poor comparing to claudicants. And the problem is not only the survival, but also the costs. PTA, of course, is the cheapest. There is amputation that costs about 4 times that. Plus, you have to count also the rehabilitation costs, which are not negligible. These patients with critical limb ischemia are mostly diabetic, mostly smokers, and mostly elderly. So this is a fragile people we are dealing with. And after the knee amputation, 2 years after, 30% of these patients mostly is dead. So it's not only saving legs, but it's also saving lives. These are 15 years old data. However, there is a huge mortality and huge morbidity in these patients. What are the indications to treat? It has to be chronic rest pain or ulceration, mostly lasting more than 6 months. We have to decide, as a colleague before said, we have to determine, is it arterial or it is venous cause? And sometimes these are combined lesions, so you have to think also about the veins. If we are thinking about imaging, ultrasound is excellent. However, in very calcified lesions, as we saw before, that is difficult to say are they patent or not. And that's also a problem of CTA. MRI here is much better because you don't see the calcifications. However, accessibility to MR machines is they are much less accessible. Integrate DSA after a clinical examination is a good method. If you have palpable femoral and popliteal pulse, then the problem is below the knee, and that's how you do the diagnostics. You do the diagnostics, and immediately you proceed to treatment. We are treating the patients, not the images. So we are not treating stenosis. We are treating stenosis that impair patient's life. We have to have individual evaluation of the patient and, of course, of the lesion, as Dr. Bizda said at the beginning. In critical limb ischemia, we are more aggressive than in claudicants because here there is not much to lose in these patients. Of course, we had to exclude acute things. Acute changes are treated completely differently. What is important, we have to correct the inflow and the outflow. Iliacs are rarely caused of critical limb ischemia. If you have a palpable femoral pulse, then it's surely not iliacs that are cause of critical limb ischemia. Often below the knees arteries are affected and they are quite difficult to treat. And of course, you have to achieve recanalization and adequate hemodynamics. Intraluminal, subintimal, it's not really important. We are aiming for the goal of recanalization. The procedure is done mostly by ultrasound guidance. We puncture the artery and we try it from antegrade first. Sometimes, if it's not successful or if it's not feasible, then we do transpopliteal or transpedal. Transpedal we do sometimes also if we want to make a good outflow for the bypass. If we do femoropopliteal bypass, then we can puncture antegrade popliteal artery, correct the below the knee arteries, and then the survival of the bypass will be better. We mostly use 4 French. We are trying to avoid stents and stent grafts. You have today stents you can place also on 4 French. This is a mostly low profile technique 014, 018. 018 gives you much better support than 0.14. And of course, below the inguinal ligament, we also place 5,000 units of heparins. We consider drug-coated balloons, we consider re-entry devices, we consider lithotripsy, whatever is possible to establish the recanalization. So this is one relatively young patient, 60-year-old male. You see he has occluded, on the left we are looking, occluded complete superficial femoral artery, and there is also problem below the knee. Also, there is no outflow there. This patient has a pale white foot and he faces amputation. And this is the angio we did. We confirmed completely occluded superficial femoral artery. There is a problem also below the knees. There are no arteries coming down to the foot. So this is a really poor situation. And in this patient, we don't have much to lose. So we try to recanalize, and during the recanalization, you can also do rupture. This is mostly not problematic below the knee. You don't have to fear of that. If you can recanalize this vessel, then it will occlude. It's not really problematic. I remember once or twice in whole my career, I had to put stent graft below the knee. And this is results after we were able to recanalize the whole superficial femoral artery, and you see there is dissection in popliteal segment. However, the flow is good, and we achieved one vessel outflow down to the foot, and this is enough for wound to heal and not to hurt this patient. We checked him 14 days after PTA. There was palpable popliteal pulse, and the wound started to heal. The third finger was black. This had to be amputated. So probably this patient would lose his leg if we would not do that. This is a similar case, a bit older patient. We tried to recanalize this antegrade. We were not successful. You see there are no runoff vessels below the knee. You see down we entered here, and we recanalized the whole vessel, and you see how good the outflow on the foot is. And now you have given the patient the possibility to heal the wounds. What about the follow-up? Follow-up in critical limb ischemia is extremely simple. It's clinical. You have to follow up the patient. If the wound heals, then it's okay. If it does not heal, then some imaging may be added, or you can try to check other solutions. So a few take-home messages. The goal in critical limb ischemia is recanalization, and it's meant to avoid major amputation and, as you have seen, also death of this patient. You have to correct inflow and outflow. Endovascular approach is minimally invasive. You can do it on 4 French. There are new kits on the block, lithotripsy, integrated balloons into the sheets, into guiding catheters. There are many new options that will improve survival of these patients. And of course, the follow-up has to be clinical. You have to treat the patient. And thank you very much.
Excellent presentation. It's open for questions, discussions, any comments from the audience? Okay, thank you very much. Next presentation will be transradial approach for peripheral vascular interventions.
Thank you. Okay. Dear panelists, dear colleagues, I will speak about transradial access for peripheral vascular interventions. I'm interventional cardiologist. I work in Burgas. This is our experience, 7 hospitals in 6 Bulgarian cities are part of Bulgarian Cardiac Institute, and in this hospital we perform more than 2,000 PTA every year. This is teamwork, vascular surgeons, interventional cardiologists, radiologists. We need equipment for doing these interventions, materials, and I will start with radio access presentation. So, peripheral vascular interventions are commonly performed via the femoral artery, preferred for vascular surgeons, and radio approach is favorite access site for interventional cardiologists for coronary interventions. The goal of this presentation is to make radio access popular for peripheral vascular interventions. And this is a challenge for our colleagues, vascular surgeons, endovascular surgeons, who will perform the first below-the-knee intervention from radio access in Bulgaria. As I know, no one did it until now. And this access site from the leg, femoral, distal femoral, and also popliteal. From above, from the arm, we have radial, ulnar, brachial, and axial access. This historical remark, first radial access was performed in 1989, and first transradial coronary intervention in 1992. So why radial access is ideal? So major advantage in terms of bleeding complications. We have results from REVOL trial, improved quality of life, patient preference, time-sparing hemostasis, early discharge, and cost-effective. So the complications are very rare with radial access. In my practice, trans-radial access is approach of choice for peripheral vascular interventions of subclavian artery, right carotid in type 3 arch, left carotid in bovine arch, renal arteries, visceral arteries, iliacs, mostly stenosis, and some common femoral and even some simple lesion of superficial artery. Transradial carotid stenting, as I mentioned, in type 3 arch, we prefer a right radial approach, and in bovine arch also for left carotid stenting. I will show you a case different from this. This is type 3 arch, and in this case we perform carotid stenting of left carotid artery with deep loop retrograde cannulation technique. You can see the wire coming down to the aortic valve and going up to the left carotid artery. We put the 6 French introducer, and we finish this procedure, transradial stenting of left carotid artery successfully. We put stent, this is a final result. Subclavian artery stenting, very simple procedure. If we know the anatomy before we start the procedure, we have CT angiography of this patient before that. From left radial access, 6 French, pre-dilatation, implantation of the stent, and you can see the final result. This is 5 minutes procedure. Transradial directly. For renal arteries, it's also very good access, renal stenting. In this case, we have truncus celiacus post-traumatic pseudoaneurysm. Also, we perform this case transradial with cover stents. Cover stent. This is angiography and implantation of the stent in the truncus, and final result. And my favorite thing is iliac stenting from a radial approach. Also very easy, very fast. Some vascular surgeons said that this is very easy to go crossover or retrograde in 5 minutes, in 10 minutes, but also in this case, this was very easy procedure done transradial. And in the future, I think that in Bulgaria we still don't have these devices, but we can go from radio approach to the foot with long sheets, long balloons, long wires. This is sublime radial access guide sheet and sublime balloon catheters. So with these devices we can perform almost everything. In conclusion, radial access is safer than femoral. Training curve for transradial access is after 20 cases, the success rate is higher than 95%. So I encourage vascular surgeons and endovascular specialists to use radial artery for access. Transradial access can be used for treatment of almost all arterial beds if we have proper materials and tools, and we need more tools and experience in transradial access for peripheral vascular interventions. Thank you for your attention. So,
Thank you very much.
I don't know how many of you use this approach, but it's useful.
Any questions to
Yes,
the presenters?
in our CAT lab, we're using regular radial approach for
Yes,
carotid.
but you're also interventional
Yes,
cardiologist.
As interventional cardiologists, our set mind is put that we have to use the radial access or lunar access. And did you try the distal radial access?
Yes, yes, we tried.
It's much easier and much less occlusion of the radial
I
arteries.
think that in these peripheral vascular interventions, better is left radial approach. Yes.
Left, right, yeah, because of the curve, of course.
Yes, because of the curve.
But
and
even
to avoid manipulation in the arch.
yes, regularly for CTO occlusion of the FES, popliteal region, iliac arteries, regularly we use the tibial and radial access. So
Yes,
we
radial
actually,
to flush.
no. We start anterograde with glide wire is 300 centimeters, so you can go directly externalization.
Yes, yes.
And even now with the, I think, Biotronic, Pulsar T3 has the length of 170 shafts, so you can directly stent it through the right radial access. It's less invasive for the patient. He can walk up and walk out of the CAD lab.
Okay.
Perfect.
Thank you.
Any other comments?
Perhaps we are using brachial and axillary access for many years. As colleague said well, visceral arteries are much easier treated from above. I don't see really, if there is no bilateral disease, the mean of treating it from above femoral or iliac arteries. However, sometimes you need a relatively large sheet to put a stent grafts, sometimes 7, 8, and then radial might be a bit small. So brachial and axillar are also quite good.
Of course. We have slender introducers. Actually, it's outside 7, inside 6, outside 6, inside 7 French, so you can put as a slender introducer, so you can put everything.
Okay. Thank you.
Thank you very much. Are we ready with the live case?
Keep the padding there.
Hello, can you hear us?
Yes.
We can hear you, we can't see you.
Oh, Nice. So, good morning. We are at the National Heart Hospital with my friend Theo Bizdas, and we shall perform a live case for a long SFA occlusion. Can we put the slides? So, we have a 64 years old male, Rutherford 4, rest pain in the left foot, ABI 0.3, he has arterial hypertension, ex-smoker, and he has below the knee amputation on the right leg because of peripheral artery disease. So we've done some work while your presentations are going. So we have a 6 French long sheet fortress, 45 centimeters from the contralateral leg. And can we play the angio? The next. This is the CT. Второто. And this is the angio. We have a short stump of the SFA, very good deep femoral artery. The next one. And this is the reconstitution.
We don't see the
first slide we didn't see.
The first angio.
Only the CT
Yes,
on the screen up to now.
We
Just a second.
were seeing this angio now.
Now, do you see it?
The second one.
Not yet.
We see just the CT angio.
Okay.
Now,
Yes.
It's okay.
is it okay? It's okay. So this is the angio, a short stump of the SFA. Next one. And this is the reconstitution.
Okay.
So, Theo.
So, first of all, thank you very much, Madeline, for inviting us. This is a nice case for of a CTO, of a long CTO. Nowadays, Biotronic has released their new product. It's called Oscar. It's a combination of both support catheter, seat, and balloon in one device. So we will try this device for the first time now. So someone, if you can show my hands, please. So I see, you cannot see it yet. You will see a device. Please show my hands. Can you see my hands at the moment?
Yes.
Yes.
Okay, perfect. So you see this device. This device comes into a 6 French outer sheath. That means it goes through a 6 French sheath inside. It is a long sheath. You have different lengths, and it is dedicated for an 018 and 014 platform. Today, due to the fact that we are in the femoropopliteal axis, we're gonna use the 018 wire. You can see here we have a white and a blue button. The white button is the button that actually you can control the sheath. By this way, by pushing up and down, you can do angio in flight. So that means during the procedure. And then you have this support catheter. This is, let's say, the hard part. By this way, you're gonna push further the sheath. The support catheter. The support catheter in the front is very aggressive, and it is dedicated to have intraluminal course of the wire. And you have here the blue button, which is actually a button that allows to insert after the recanalization the balloon catheter, and you can close it or open it. If you have any back bleeding, you can close it. If you want to remove up and down, you have to open it. So during the procedure, I will explain you more and more which are the potential advantages of these devices. And we have also a Command 18 wire, and we are actually in the front of the stump. So we're gonna do a small angio just to be sure that we are inside the stump. We have not done anything yet. Here you can see I can do very nicely from my hands, I can do very nicely the angio. And now the most important thing is that by this combination of sheath and support catheter, you are increasing let's say, the weight of your wire. So by this Command 18 now, you're gonna create, by this way, if you're gonna put at a very proximal part of the sheath, you're gonna create it like an Astato 20. So you are increasing the proximal weight of the wire. So here you are. So I'm just pushing inside in order to penetrate it. Sometimes it is much better to get it through without the wire inside to give support. And by this support, it doesn't mean that you're gonna go intraluminal, but it is a nice support catheter to get inside. So you need first to penetrate the proximal cap, and then after penetrating it, we're using the 018. Sometimes you need to rotate it. The patient is moving a little bit his legs. So this is the hardest part. I'm going a little bit back. So you see here, I'm going without the wire inside, just to penetrate it. It is a hard. So this is the seat. It gives now more support. I'm bringing also the 6 friends. So you see that we have at the moment more or less 2 seats and 1 support catheter. I'm going a little bit back. So it is hard to penetrate it. We want to stay intraluminal. That is the most important thing. So let's do an angio to see where we are. So we have to give more power inside. Very hard lesion. Okay, we had few centimeters. Okay, we have penetrated it. We don't know, of course, if we are in subintimal or intraluminal space. Now I'm just trying to push it. Can you keep it here, Natalie, a little bit on this side, the seat? Come from this side. Here, keep it against. So now I'm going further down. Okay, we have this loop here. There. Okay, now we are down. So it was very, very hard steep. Now let's see where we're going. So we will see if the seat can follow. It's of course a very small lumen, it cannot follow. Keep the wire. Okay. I'm going with the seat. It goes now very smoothly. Now where I'm gonna go to the end of the seat, to the end of the lesion, I'm gonna change a little bit the morphology of my wire. I'm going to get again a straight wire. So it was very, very hard, the proximal cap. Very nice. Very nice. So let's see now what will happen from above. Keep this one. Okay, yes. Please. It's okay. It's okay. So the seat goes very nicely together. It's amazing. So let's go further. Keep the wire. Okay. The support catheter, it's really very, very good in order to go through the lesion. And keep in mind, it's a long, long lesion. So when you are not able to go with a wire, I will go back with my wire, and I can use it so slowly, solely, without the use of the wire, just to penetrate further. Here it seems to have a difficult part. Let's try it a little bit, go back again. Here we have to go subintimal. There is no other way, or maybe we are intraluminal. We will see now. So keep the wire.
Yes.
Okay, we are through. Let's go further. So this is a nice thing with the Oscar. Here it was a small branch. I think we are into this branch. We will check it in a few minutes. So I'll try to push my seat further. I'm not able to do this. Okay. So here I'm gonna do a little bit a subintimal space in order to go through. Keep the way.
Yes. No way.
Okay, it went through. Here is difficult. Let's go a little bit back. No, again. So in this case, where you see that the wire doesn't go anywhere, it is very similar to a support catheter. First trick is to go by rotating always the wire, just to find a better channel, like here, but here it seems that it stops. In this case, you have here with the Oscar a nice support from above, from the sheath, and you can still further advance your support catheter. Let's check where we are. It is our sheath. The sheath is in place here. Everything is fine. Just not remove the sheath, and then keep the wire. Keep the wire, Natalie.
Yes.
Okay, and then I'm pushing further. Perfect. We have won some few millimeters. So very, very, very hard. It's getting a little bit better. Okay. Now, let's see where we are.
You want with the rotator?
I think we are in a good position here. Probably we are intraluminal. I mean, we are back in the true lumen. There is no intraluminal. Yes. Probably yes. We will check it right now. So I think we have advanced the wire, but we have to check that it is fine. By this way, we are not able to do it through the lesion. So in this case, we're going to remove the support catheter because it has no length anymore to get through the lesion. Can you keep the sheath? And we're going to bring the balloon.
Okay.
Keep here the sheath. I'm going to remove the support. Come from this side. Any question until now?
Just
Open it, yeah. Sorry. So now we're going to remove it. We have the O18 in place.
no.
We don't want to do any angio from inside the lesion because this is gonna keep contrast in the subintimal space and it doesn't look very well. Okay, so here we are. Now we're gonna bring the dedicated balloon. So this device comes with a 5, 4, or 6 millimeter balloon. Give us please the balloon.
Are you holding the
Yes,
wire?
I'm holding it. So open it. The balloon, it has, sorry, you can show, yes, the support catheter. Nadlin will show it.
This is the rotator. It has a metal tip, stainless steel, in front of it. So it's very, very powerful to penetrate with it.
Water.
This is the rotator. Now we are changing for the balloon.
Sorry, Dr. Bises, do you make the activation of the hydrophilic layer of the balloon, if it's biotronic, maybe a couple of minutes in a sleeve before you use it?
Due to the fact that you have at the moment the support catheter inside, you don't need it, but you can do it, of course. This is a nice trick, yes, of course. But at the moment, we were able to get with the sheath up to the middle of the lesion, so we don't need it at all. But we will see now. It is a very nice balloon. Believe me, it is different like the previous balloons because it has a very nice, let's say, profile and way of inflation and deflation. So you're going to see that we're going to have a nice advancement. The wire is there. So the nice thing is that you're not losing now your support catheter from here. you can get with a balloon, with a dedicated balloon inside. And now we're gonna go through.
Не мърдай.
Keep the wire, please.
Yes.
So you have now all the support that you need. Let's see, where is our balloon?
Dr. Bizdas,
Here you see the markers. Yeah, please.
you gave some heparin probably to the patient?
Yes, 5,000 units.
Yes. Because
Okay, here you see, now we're gonna see the first marker. This balloon has a total length of 200 millimeters. So the first marker is at 0 point, then it will come a second marker. This is actually 60 millimeter far away, so that means this first distance is 60 millimeter, and then you have another one. This is 120 millimeter, and as I said, this is a 200 millimeter balloon. But now, the marker of the seat, that means up to that level, the balloon, 2 millimeter of the balloons are inside this seat. So you're gonna have an opening of 180 millimeter. And by this way, you can always define which is gonna be the right length for your device. So by this way, also, if you're not able to get with the seat inside, by the trick of inflation and deflation, you're gonna have the seat further down. Now, let's see where we are. It looks good. Let me try to bring the seat further down if it's possible. Otherwise, we'll inflate and deflate. The seat is coming down. Difficult, but it's okay. Nice, nice. It's up to here. Let's go further down. We have want some few millimeters. Okay, let's open the seat, the balloon here. Yeah.
Inflator.
Yeah.
will you check perhaps before if you are in the lumen, now you have balloon down?
Yes, the point is that we are still into the lesion, so it doesn't make sense to remove the wire at that moment. So we need around 40 millimeters further to reach the bone, and then to do the angio. This is a small, let's say, a disadvantage that if you are not able to go with a seat through the whole lesion, you may lose a little bit on the length, but an alternative could be to use a little bit bigger seat, instead of 6, to use a 7 French to do the angio. Let's see now. Okay.
Theo, Ivo speaking.
Yes.
Ivo Petrov speaking. Because of that, we are using quite a lot roadmap. So
Yeah,
the road
makes sense.
in such a situation, the roadmap is extremely useful because it's giving you notion always where you are.
Absolutely, I totally agree. Okay, the patient has a little bit of pain yet. This is a 5 millimeter. Now you see that the seat is getting nicely down. You don't need to keep the wire there, you just need to bring the seat down.
You're using, Theo, the deflating balloon as a
Yes,
support.
as a support cover,
Yeah.
exactly. This is something that we know it from the aortic stuff. In order to get into the branches, keep the wire.
Okay.
So, and then I'm going further down with my balloon. Now I have it there, and now we're gonna do the angio. So you can remove the wire.
Do you have contrast mesh?
Yeah, this is.
Wow, Theo, look at that.
Yeah, it is. It's a hard thing. So let's do an angio to see where we are. Okay, we are fine. And let's see here, all 3 vessels, just to be sure that we don't gonna have any problem. Let's do an angio.
Yeah, it's okay.
All 3 vessels inside. So by this way, now we're gonna do a further inflation.
I think
We need a new one,
Yeah.
yeah. So very nice performance of the Oscar. As I said, sometimes if you're not able to get through, we are doing also sometimes when we have difficulties to go with the wire further, we are using as a support catheter a small 018 balloon, and we have to do a small inflation. Sometimes if you're not really very familiar with the device and you need some kind of learning curve, You can also use the 4 millimeter device, or the device that has a 4 millimeter balloon, to create less trauma into the vessel. But when you're going to start with this, using this device, you will see that you have never seen such a support catheter with this kind of strength. It's crazy. Because they have used as a proximal tip for people from the coronaries, maybe they know it. It is the same proximal tip like the Corsair support catheter from Asahi. Very, very aggressive, ideal for this kind of CTOs. And of course, you are taking a one wire. This is, for example, the Command 18. And by this way, despite that this is not a CTO wire, you create more or less, or you are making, by this way, a CTO wire without the need of 2 or 3 different wires. Can you remove the S? Yes. So now we're going to do the next angioplasty. Okay. So maybe he has pain, the patient is a 5 millimeter. We're going to open nicely.
Има ли болка?
As I said, this is 180 millimeter.
He has
Pain.
yeah, pain.
And now the next step is going to be to use a DCB after doing a first angio to see what happens. So if we see a lot of flow limiting dissections, there are 2 options there, either to perform a DCB, a bare metal stent, or directly a drug-eluting stent. There is a discussion about this, what is the ideal treatment. As I said, can you keep the seat here?
Yes.
So I'm going back without changing the catheter and the length, I mean, of the balloon. So by this way, it is also a little bit of time effective, the whole thing here, because you don't need to change multiple times the seats.
Release.
You don't need to change multiple times the seats and the support catheters and everything. The balloon opens and deflates very quickly. So now we are at 8 atmospheres with a 5 millimeter balloon.
What is the rated burst pressure of the balloon? This is a heavily calcified lesion, and sometimes you need high atmospheres. What is the RBP?
I have no idea.
12.
Well, Nadine checks now and will tell us.
So 12 is quite fine. 8 sometimes it's not enough, but 12 is quite high. So
Yeah, totally
this
agree.
is really good.
But it's subintimal, so
Yeah, but it's very calcified. So
Okay. So can you show the previous angio to see where it starts, the deep femoral?
Yeah. Може ли да пуснете първото ангио?
I think we need some few centimeters to go above, but we will check now where exactly is the, okay, we are almost there.
At the lower part of the...
At the lower part. Okay, it's where we are now. Yeah, we are there.
we-
Okay, good. So now we're gonna open it. Do you have a 6 millimeter DCB?
Yes.
Okay, we can open a long one. Okay, let's see now how it is the deflation. Quick time, nicely, perfect. So, and then you don't need any more the sieve, because now we're gonna go through the DCB. The DCB is a little bit bigger, so in this case, you need to do it through the sieve. Let me get a little bit deeper. Okay, it stays there. We will not try it further. Okay, can you keep the seat?
Yes.
So now, as a unit, I'm gonna remove everything, keeping the wire in place. We still have the seat from Biotronic, the Fortress seat, the 6 strands in place, and we're gonna do the first angio to see what kind of disaster we have done. Keep the wire?
Yes.
But I hope that everything is fine. So again, can you show the picture? Before. So this is, here you are. This is, can you see my fingers?
yes.
So this is the end of the sieve, and here this is the marker, and by this way you can have a different size of balloons depending on how big or small is your lesion. So very nice. You can directly measure with the markers the length of the DCB, the length of the stent that you want, everything in one device. So we are returning it back. Let's do an angio to see what we have done. Always the angio for when you have the proximal stab involved in a LAO or RAO fashion, depending on which side you are. Now we are on the left deep femoral. That means we're going LAO. Okay,
Nice.
very nice opening. You see some flow limiting dissections. Let me check a little bit the
Yeah, proximally probably there is still some stenosis, but it will
we
not
will
be the
treat
problem.
them accordingly. Let's do it again. Yeah, so there we're gonna use the DCB. Probably this was the difficult proximal cap that we had to penetrate. If you remember, we had some difficulties to begin.
Yes.
And let's sit down now. Contrast. Good, thank you. I'm going back. So now the next step, as I said, is to see the DCB. I'm starting always from below to the proximal part. So this is the level, at the level of the bone, we're gonna start. You see there is an eccentric lesion there. We're gonna cover it. And we will not cover this nice branch that it is important as a collateral. And we will start right now.
The flow is quite good.
Yeah.
Instead, no matter of the section. So, yeah.
We will see what happened after the DCB. I don't think that we're gonna avoid stent, but we will see. It's okay.
Yeah, it might look better because diameter will be bigger, and perhaps with prolonged dilatation, the flow will be good.
So this is the proximal marker. We're gonna start around here. So it is what? How long is this?
150.
150. That's nice. So let's start. We're gonna give at least 1.5 minutes. Still, we are still using the DCB. The current data after the meta-analysis actually showed that we still do not have any concern about death after DCB. So we are still fan of this. At the moment, there is a lot of discussion between sirolimus and paclitaxel eluting balloons. We are using both, but we are using sirolimus just to collect data. The first thing, I mean, in the framework of studies, but for the standard treatment, we are using paclitaxel-coated devices.
One good thing of the study of DCBs and that was that the prices went down, so now they are more accessible, and it's good. You will probably cover the whole length of the SFA with drug-coated balloons.
Yes, this is absolutely the next one, 150. Yes, absolutely, and always I'm trying to do an overlapping at the level of the proximal and distal marker. In order to have medication in all over the length of the entire length of the artery, and then we're gonna decide if we're gonna do a full metal jacket or a spot stenting. It is a very, very interesting discussion. This, in my opinion, I don't like spot stenting because if you don't have IVUS, you never know if you are covering the right lesion. On the other hand, if you have IVUS, you think that everything is a big disaster inside because you see everywhere some small membranes and you think, oh, it is a dissection. So at the moment, I'm not convinced of the spot stenting strategy. I'm more convinced from the full metal jacket by trying to save at least the P1, P2 segment in case that in an occlusion to make a FEMPOP1 bypass if it doesn't work. So this is my personal strategy.
And Theo, what about the common femoral? Do you put the stent protruding a little or just keeping outside below the bifurcation?
I'm not having a problem to use a bare metal stent a little bit above, just to be sure that it will cover very nicely the proximal part of the SFA. To cover completely the profunda, I don't like it. But at the moment, I don't like stents in the common femoral artery. because you're covering completely the deep femoral. I'm trying to treat lesions of the CFA if you have concomitant lesions with other devices like shockwave. Yes, please. Like shockwave, like scoring balloon, like directional atherectomy. So I have to accept that even though I'm a vascular surgeon, I'm trying to do more endovascular stuff in the CFA. I don't see really a big disadvantage for the patients in the current results that we have. We have TECO trial, we have our single center studies, and our personal experience. Okay, then you are.
Can you go to what?
Yes,
Absolutely. I will confirm we have the same experience without any concern about covering even the part of the common femoral. It's not dramatic. And by the way, in most of the cases, I don't know what is your experience, even with stent occlusion, in the most of the cases, the profunda stays open through the mesh, through the struts. So it's not a dramatic situation.
Exactly, exactly. So important is always to cover nicely the proximal part of the SFA, because this is where actually the main problems are happening, in the very proximal part, because the majority of the people, they are very careful not to overlap the deep femoral artery, or at least half of the origin. And then the second thing is happening at the level of the Hunter channel or at the P1 segment.
What do you think about preventing large flow limiting dissection, about using like a chocolate balloon that is making more predictable opening along the lesion to prevent dissection?
Well, you have the chocolate registry, which actually showed really amazing results, but these were very small lesions. So in such a kind of lesion where actually nobody knows if you are intraluminar or subintimal, because you're getting outside into the true lumen, but you never know the right course of the wire, I don't think that will make a really big change. I mean, the balloon that actually I feel very comfortable is the scoring balloon, because you have this kind of nitinol wires that really gets into the plaque and opens nicely the vessel. But it's difficult to say. So in my opinion, sorry for this, he has a little bit pain because we are opening now the vessel. We are only at 8 atmospheres. So what I personally do is, today we have used the Oscar and we have used a 5 millimeter. We can also do it with a 4 millimeter, as I said before, because
injured.
Okay, so even if we are at 4 millimeters and you don't have any dissections, yes, then try to use chocolate. It makes sense. But if you are in 4 millimeter and you have full of dissections, no device will save the situation in that case. This is for me the most important, let's say, criteria. What happens with a very small balloon?
Which stent would be your choice? Supera or another long stent?
Whatever you want. I mean, I don't see, and I have not seen evidence that the one device is better than the other. I like Supera in really calcified lesions where you really need this power to open it, because no other stent has this kind of power to open this kind of lesions. For any other lesions like this one, where we don't have this, you can define it as, let's say, moderate calcifications based on the CT scan mostly. I will use whatever you want here. Important is the vessel prep and the coating. This is, as I said, my personal opinion.
About the dissections, Dr. Bizas, what about long inflation and slow deflation on 50 seconds, deflation 2 atmospheres less?
That is a good point. However, I'm always thinking the same thing in this case. If I was the patient and I had this kind of dissections that you have seen at 5 millimeter, and you're doing this kind of 15 millimeter prolonged dilatation, would you leave it without stent if it was your leg? Because the point is, you have to wait, let's say 15 minutes, 20 minutes to repeat again the angio. Do you still have this dissection? So it is difficult to decide.
Neve,
I mean, even if I have a very flow limiting dissection at the very beginning of my angioplasty, and after the DCB, I don't have it, it is difficult to say, okay, now it's treated the dissection. It is, you know, fixed on the wall. You never know what will happen.
Yeah, the data about the coronary diseases that we are now I think it was some follow-up study with the DCB, not leaving nothing behind actually. And we're going back to the point where the scaffold should be avoided. And that's why even small dissection after 6 months IVUS, the results are significantly better.
It's okay.
In the coronary vessels, I'm talking.
Yeah.
But SFA probably is even more problematic than coronary. These are long changes, and so this is difficult.
And slow flow. And slow flow.
Completely different, and movements and everything. So SFA is really, really difficult. However, I think we have to have a goal of the good flow. If you have a good flow, even if there is a dissection, you can leave it. If it's fast, the flow, I would leave it. You can always come back, and you can always put a stent. When you put a stent, you have a stent, and many times it occludes.
Yeah, we should considering the SFA and the coronary vessel like bodybuilders and regular guys.
Yeah.
Huge amount of intima media.
You have only 80.
I would suggest, because we have the picture also outside, we have the coffee break now. In fact, we have eaten the coffee break already. So if you don't mind, we can start coffee break, and we are going to watch you in the lobby, and you will explain what is your progress and what you have done.
Yes.
Do you agree?
Problem.
Great.
Yes, absolutely. Thank you very much for your
When we
attention.
come back, Ivo?
See, in 10 minutes. So
Okay, 10 minutes of coffee
10
break.
minutes coffee break, and we are going to watch them in the lobby.
Пак ще има болка, Иван. Приготви се. It's okay. 8.
Go 10.
Има ли? По-търпима. Търпима ли е? Добре.
It's okay.
Yeah, absolutely. The Oscar.
I have never used it. It was my first time. For my first time was not bad. You are lucky.
That's the
You're
job.
fucking lucky. Nice. The point is always you're losing on length, so you cannot get outside. That was the problem. So I couldn't push the seat inside.
It's above, yeah.
Okay.
Meanwhile, the pulsar can go through the sheet of the Oscar.
I know.
But you have the pulsar only 120.
Okay.
And the sheet is 108.
Okay, I
so,
understand.
so stands up to 10 centimeters.
Okay. Can you open a 150 balloon, just normal balloon? Right. you bought these things here, this blue? Have you ordered it from internet?
No, we
here?
have a shop here.
Really?
Yeah,
They're so cool.
about the Cherokee.
Cherokee. This is a
Cherokee.
Cherokee.
This is the Cherokee. Do you like it?
Yes, I like it because it's a silk.
Yeah. Yeah.
Nice. Let's see.
Let's see now.
Can you put the
overlay.
The overlay?
На предното. Да. Последното, което направихме. Да. Да. Ай, това.
So now we should map and smart mask.
Yes, and the smart map.
Yeah.
Okay, here.
Nice. Do you want to make another or this is okay?
No, I will put it where I think it's fine. I think
Here, yeah.
here it's gonna be fine. We have to cover this dissection.
Okay.
And now you can remove it. I remove it. Okay.
Yeah, absolutely.
Absolutely, that's good.
And good overlap. So
Yeah. So come from here
Okay.
and give a little contrast.
Okay.
Just to be very, very precise. Give me a second.
Tell me when.
Okay. Do it. Okay. Give a little bit an engine. Okay. So by this way, we're
Let
gonna
me contrast.
cover a little bit.
In the common.
We need a little bit down,
Okay.
if it's possible. Okay. I'm
Yeah.
going. I will tell you. Give contrast. Give contrast. Okay. Stay there.
A little jump.
Yeah. Giving contrast. Give contrast.
Let me contrast. Just a moment.
Yeah. Okay. I remove it.
Yes.
Peo and Nedo,
Yes.
we are back. We are back. All the audience is back from the coffee break, and there are two questions. What is your progress? And the second one, Professor Nikolov, how is your intention to do your lecture? From National Heart Hospital, or you are going to come here?
From the National Heart Hospital, yeah.
Okay, so after finishing the case, it's your turn to give your lecture.
Okay, thank
Please
you.
tell us
So,
and show us.
What we have done is that we have checked multiple times the angio. We have seen some dissection membranes coming up to the P1 segment. So we decided to go for a full metal jacket. Here you can see the stent starting almost at the P1 segment. This is where it starts. Here.
What stent did you use?
Pulsar T3. And now that we were very careful with the, just a moment. We were very careful with the proximal part of the SFA. So I'm going in a magnification. We have stented up to the level of the SFA. You can see there a small recoil. We're gonna dilate it. I'm gonna do an angio to see where we are now. And now the next step is to dilate the whole stent in order to open it nicely. Sorry, don't move.
Не мърдай.
So this is where we are, very precisely up to the level of the deep femoral. And now we're gonna open nicely in order to treat also this small dissection membrane. I didn't cover it because it is in the flow direction. And with a balloon, it will be nicely open. And you see that we have a very nice flow in the SFA. This is just to mention it. We went with a 6 millimeter balloons up to the very proximal SFA. The last stent, it is a 780 millimeter. Because it was a big,
Yeah, it's okay.
big
From
artery.
below?
Where we are? Here we are. Where is the other side?
Dr. Vitsas, I'm curious,
down?
can we
Okay.
see a picture after the depth predilatation?
Yes.
Just curiosity.
Yes, of course. Please go back to show it. So the picture, please, the previous one, the angio. Go back. Another one, back. This. It's series 20 says. Okay, perfect.
Da.
Yeah.
This one. This is the first picture. Да, next. Не, преди стентовете. Назад, назад. О, чакай.
Here you are.
Yeah.
Yeah.
Още назад.
So we couldn't avoid the stent at that level.
Yeah.
Назад. This is the picture.
This is a picture, you see some recoils. It looks good in the middle of the SFA, but in the spot stenting would be too risky for me. And show the last one, the P1 segment.
Предното дай, предната снимка. Предната.
Here you are.
Тази върня.
And this is how it looks like at the P1 segment. So we wanted to have a better position of the vessel, of the membranes. So now we are going for a little bit aggressive dilatation. It may hurt a little bit the patient. And here we leave it for 2 minutes. So, or 1 minute, let's say. Now we open nicely the stent. You see, we are using maximum of 1 stent overlapping. And then we're gonna do it for the whole procedure, for the whole stent up to the P1 segment. Any question until now? Would you have done something else?
Excellent. Great job. You did great job, definitely.
Thank you. So let's do now the angio to release Nadlin for his presentation. So what we're using is we have done a 6 millimeter balloon, and we are repeating with a 6 millimeter balloon. We are going
it's a
1-to-1.
Male patient, it's absolutely natural. 6 millimeter is absolutely fine. Are you going to cover also the ostium of the SFA and
We will see. We will see. Of the PFA, you mean? Yeah. We will see right now. So we're gonna do a nice ballooning of the whole. So here you are. Okay, let's do it again.
Много е напълнен фото.
So he's gonna have pain.
Малко стисни зъби за малко. And there is still
I'm at the 18 atmospheres at the moment in order to open it.
Сега ще спре.
So always we are too aggressive with this kind of ballooning in order to have a good final outcome. And then,
I hold it.
Yeah, it needs a little bit deflation.
Let me. We have too much contrast media inside.
Just a moment. So keep the wire, please.
Okay.
So here you are. Okay, so we're going up to that level. Yes. Perfect. And then we're gonna do the final. So inform him that he's gonna have pain.
Пак ще има болка. Малко изтърпи. И привършваме.
Sorry. So this is the punishment for smoking.
Готово.
So now we're going to have the final angio. As I said, this is a 6 millimeter, 150 millimeter balloon. And we still left, let's say, more or less the distal P1 to P2 free from any stenting in case that something goes wrong and we need any kind of bypass procedure.
Statistically, the main reason for the atherosclerotic increasing is the stress. And statistically, every stressed people smoke a lot of cigarettes. So again...
So that means the majority of us should smoke. So
the majority of the interventionalists are stressed smokers.
Okay. So let's see now the final angio. Give me a second to go up.
Привършвам.
Okay, here you are. Good. No, now, angio, okay. Please tell him.
Само не мърдай, моля те.
Perfect, thank you. I think it looks good.
Absolutely.
Yeah, excellent flow.
Okay, let's see the final of this here. So the deep femoral is coming later than the SFA. That is a good thing.
Should we check the trifurcation?
Yes, absolutely. Let me give a little bit water to bring the contrast away.
And we are planning to close the lesion from the sheet with a closure device.
Which one?
Angio-seal.
6 French.
Excellent. We have a dedicated session this afternoon about closure devices, plug-based and suture-based.
Yeah.
Okay,
We will use a
vessel.
plug-based.
Okay,
Не
don't
мърдайте,
move.
не мърдай. Сега последна снимка. И си готов.
Let's see the foot.
Should we...
Yes, yes, I'm gonna do it.
Since the flow was good up to now, probably also the foot will be fine. But yeah,
Yeah.
Yes,
let's
I
check.
think so.
It's a brisk fall, so
Don't move.
не мърдайте. The
He moved a little bit.
Yeah, the
but-
dorsal is okay.
I think he needs a little bit nitro here, but I think it's fine.
Yeah.
Dr. Nedelin, maybe you can do a venosis Doppler after it of the Saphena magna.
Sashko. Yeah, yes, I can.
Give me this thing here.
Or you
We're gonna
can
do
do
a
clinical examination and see that there are no varixes.
No, we're not talking about insufficiency reflexes.
Yo, what do you
60% of the population has the insufficiency problem. So it's a huge number.
Yeah.
Не мърдайте. Не мърдай, не мърдай.
He moves a little bit.
Yeah.
Actually, we should see. Here you see.
Yeah.
Okay. You see the dorsal pedal
Dorsal.
artery. It's okay. Good. So, due to the flow, I think if everything is fine, I'm gonna check a little bit again the trifurcation here, just to be sure that everything is fine. Here you are. Okay. It doesn't seem that we have any kind of embolization. Can you do angio?
Yeah. Are you ready?
Okay. Yes. Oh no. The middle. Yeah.
Nosotros estamos aquí.
Yeah. It's good.
Absolutely good.
No.
Okay, it's fine. Good. Okay.
Okay.
So, guys, thank you very much.
Thank you for the presentation.
Thank
it
you.
was a nice case.
Thank you, guys. See you later.
Great job.
Thank you.
Bye-bye.
I remove.
Nedo, are you ready to give the presentation?
Next. But perhaps
Okay.
if
We're
we
going
can
to
Small
change.
change. Okay.
Next presentation will be not all stenosis are created equal, when to treat endo and when open.
Dear colleagues, dear chairman, I am glad that I have the opportunity to present a few interesting cases that we encountered during our last year of practice. This is case-based presentation, so I'll go just straight to the point. A couple of months ago, we met a very young, 31 years old male patient who presented with typical claudication, very long claudication, roughly a kilometer. And naturally, as he's 31 years old, he has no comorbidities, he's taking no medication, he is a very active football player. Normally, he has perfect BMI. He is not a smoker, he's not abusing any substances, and naturally, we don't take these kind of patients very seriously when they come to the cabinet and start complaining of claudication at the age of 31. But once we performed the thorough examination, we realized that he has very weak popliteal pulses and absent pedal pulsations with relatively low ankle brachial index. So we performed an ultrasound examination and we realized that the popliteal arteries were a little bit dilated with partial thrombosis on the left side with chronic total occlusion of all of the 3 tibial vessels. That was confirmed by the CT angiography. And here are the axial imaging. With the help of our radiologists, they helped us realize that not only are the popliteal arteries a little bit dilated, this is by no chance popliteal aneurysm, it's roughly 12 millimeters in diameter, but they saw something wrong with the insertion of the muscles, and they said that the position of the popliteal artery and here the gastrocnemius muscles are not in the right place. So the diagnosis popliteal entrapment syndrome was suspected, and they recommended that we do an MRI imaging just to confirm the diagnosis. As you can see on the left side, this is the usual position of both gastrocnemius muscles, and on the right side you can see here's the MRI image of our patient. As you can appreciate, the medial head of the gastrocnemial muscle attaches with an aberrant connection. So the popliteal artery goes beneath this muscle. Again, a normal image. Usually, both popliteal veins and the popliteal artery runs in the lateral side, and here are the attachment places of the gastrocnemial muscles. Here, this is our patient. As you can appreciate, the gastrocnemial muscles attaches aberrantly here, and the popliteal artery is pushed medially. We know there are several types of popliteal entrapment syndrome. The first picture shows the normal anatomy. On the second picture, we can see the normal attachment of the gastrocnemial muscles, but the popliteal artery runs outside. And in our case, we had this combination of pathology where the gastrocnemial muscles attaches laterally and the popliteal artery runs beneath these gastrocnemial muscles. So what are the current recommendations regarding this condition? It's obvious we have to treat it, even though it might be asymptomatic. And the treatment principle is very simple. We should release the artery by performing myomectomy. What is very important not to forget is that endovascular treatment is completely ineffective and is associated with a very high risk of reocclusion. So it was very difficult to make the decision-making process, but due to the fact that there's a chronic distal embolization of all of the tibial vessels and it practically cannot get worse, he has a relatively compensated hemodynamic with claudication of roughly 1 kilometer. Unfortunately, he has no great saphenous vein, or the size of the great saphenous vein was around less than 2 millimeters, let's say. And most importantly, the patient strictly refused any kind of operation, although we strictly recommended to perform a bypass surgery. So at this point, we decided to postpone the operation on the left leg, and we scheduled an appointment for myomectomy on the right leg with the hope that we might evade surgery at this point. The patient said that he has many other consultations and a lot of physicians has promised to put stents into this occluded artery. But you can easily appreciate that's another patient who had popliteal entrapment syndrome, and he received at first one stent, the stent broke, occluded, so another stent was implanted, and you can easily see the result of putting a stent into a popliteal occlusion. Here, the stent is not only crushed, it's absolutely destroyed. So, why did the stent fracture? I think that's pretty obvious. And what is the solution? The solution is simple. You can always perform a bypass surgery, avoid this compression. So until this day, the patient is working really fine. The second case is similar in appearance, but totally different in diagnosis. We had a 51-year-old female nurse who presented with claudication in the right lower extremity for a year. She was treated unsuccessfully with cilostazol and clopidogrel for a year. She has no previous medical history, no medication, and upon examination we find weak popliteal pulse and absent distal pulse. We jumped straight to angiography, and that's what we observed. We observed very high-grade stenosis of the P2 segment of the popliteal artery, as you can see on the axial images as well. But at this point, this occlusion this stenosis seems very unusual, so we decided to abort the procedure at this point, not put any stents, and we discussed the case with our radiology team. They advised us to perform an MRI image because the first idea when we see a young patient, because 50 years old is young for our diseases, to dig in, to find if there's some entrapment or some other cause, some other etiology that causes the stenosis, and we perform an MRI imaging. As you can see, they absolutely excluded the popliteal entrapment syndrome. They say everything is all right, but they found this formation on the backside of the artery, and presumably this very enlarged genicular branch of the popliteal artery. When we performed a duplex ultrasound, we saw there's some kind of cystic formation on the backside of the popliteal artery. And what is interesting is that a second-year radiology resident during her night shift, when she started looking at the exams that were performed during the day, she discovered this case and she started digging it in the literature. So she proposed that this might be a case of popliteal adventitial cystic disease, which is a very rare condition that mostly involves the popliteal artery, and mostly healthy patients are affected. So the etiology is not completely known, but we suspect a ganglion theory where synovial fluid from the knee joint escapes through this genicular branch and forms the cystic formation on the backside of the artery, which causes this stenosis. The treatment options are different, but they all lead to high rate of recurrence. Based on all of the exams we have performed so far, we decided to perform a surgical intervention. We performed a posterior cut of the popliteal artery, and you can see this gigantic genicular branch. And once we decided to cut open the adventitial layer of the popliteal artery, we evacuated a jelly-like substance that formed this cystic formation. This is how the jelly-like substance looks like after you evacuate it from the artery. So we didn't perform a real arteriotomy of the popliteal artery, just opened the adventitial layer, and due to the fact that etiology is absolutely unknown, there is a high risk of recurrence, we decided to leave the artery as it is. We didn't see any synthetic patch, venous patch, or anything, because this is basically a healthy artery. And you can see some great results on the 6-month follow-up scan. There is no residual stenosis. And you can easily appreciate that if we have decided to put a stent or do a balloon angioplasty, the results would have been disastrous. Another interesting case of a 55-year-old patient who had a stroke a year ago, no previous medical history, no coronary artery disease, no peripheral artery disease. He's not a smoker, no comorbidities, doesn't take any medications of all, and have no signs of atherosclerosis. He was referred to us from our angiologist, who appreciated a high-grade stenosis of the internal carotid artery. So we usually send those patients to perform a CT scan, and that's what we saw from the CT scan. There's a high suspicion of total occlusion at the ostium of the internal carotid artery. So we have to settle the score between ultrasound and CT to see if this is a real occlusion or a very high-grade stenosis. And once we performed the angio, we saw that there is still some blood flow through the artery. That's when the diagnosis carotid web was proposed. You can see a striking similarity between this picture and this picture. So this is not a typical atherosclerotic lesion. All of the arteries are absolutely healthy. We have just a small fibrous web. These fibrous webs may vary in size. In our case, we have a huge fibrous web that almost occluded the carotid artery. Can you help me change the slides? Okay. So basically, there's a large registry called Mr. Clean Registry that says that only 2% of all carotid lesions are due to this carotid web. Mostly younger patients, healthy females, and it's important to treat them because 1 of 6 patients develop a recurrent stroke within the first 2 years despite best medical treatment. These webs, why they are dangerous? Because they form this thrombosis because of stasis of blood behind this web. So the etiology of the stroke is distal migration of the thrombus. And we should very strictly discuss the indications for surgery. It's absolutely mandatory to intervene, whether to put a stent or perform an open surgery. In our case, we decided to perform open surgery strictly out of curiosity to see how this carotid web looks like. Here is the final result. So what do all these cases have in common? We have young age of patient, no risk factors, no significant atherosclerosis, unlike most of our patients that has advanced age, multiple risk factors, and generalized atherosclerosis. And what can we do if we decide to help those young individuals with no atherosclerosis and vascular lesions? We should start thinking outside of the box. That's for sure. Last slides. We should treat the patient, not the stenosis that was mentioned earlier, and teamwork is mandatory in these cases. All of these cases were solved with the help of our radiology colleagues and angiologists. As physicians, we are always treated that whenever we hear a hoof beat, we're always thinking of horses, not zebras. But if all we're looking for is horses, we will miss a lot of zebras. Thank you for your attention.
Thank you very much for interesting presentations. We also always have to think out of the box, especially there are many data you need, and if the data don't fit, then, as you said, you should look outside the box. Thank you.
And I'm not sure about the TEA versus stent of the web. I think it's because we are not treating atherosclerotic artery actually here. And if we put a stent, even double mesh stent like Rosesaver, after 1 month, 3 months, we don't know, does this stent are going to compress this kind of dysplasia of the artery actually. And we don't know if this particular problem will be a new thrombotic event for coming out. So for me, TIA, for this kind of web patients are maybe with a better outcome in a long term, as an interventionalist.
That was exactly our way.
This is my thinking.
We were not sure if there's a fresh thrombus beneath this web, so if we decide to stent, which is maybe an option, we should have put a protection device and covered double layer mesh stent and so on. So open surgery is, I believe, the right way to go.
But we have good results in webs also otherwise with stents. Mostly it does not come back and the result is quite good. So I think it's a good alternative.
Okay.
We did it out of curiosity. I said we just wanted to see how the carotid web really looked like.
You didn't believe the radiologist.
Yes.
Any further questions? So thank you. And then we go to Dr. Nicolo if he's ready. He will be presenting the presentation from the hospital as we understood.
Hello, can you hear me?
Yes.
Yes. Yeah. First, thank you. And I want to update our patient has palpable pulses on dorsalis pelvis, so it's okay. My presentation is about first experience with a novel multifunctional catheter for peripheral vascular interventions, and you saw this catheter in action. This is the Oscar. The Oscar is one solution, cross adjust restore. So I'll skip this animation because you saw it in live case. The main advantages. So we have 3 main parts of this catheter, but the main advantage is that you can reduce your stock by 83%. So the 3 main parts are the support catheter, the first one, the dilatator, and the PTA balloon. We have 4 French device that runs on the 014 platform and 6 French device that runs on 018 platform. So the support catheter, it's very rigid, it's very flexible. and strong. As you can see at the front of the catheter, you have this metal tip that prevents the catheter from bursting when you inflate the balloon. And of course, the seal lock, the tip control, and the flush port. The good thing is that you have a very, you can flush through the catheter and the dilatator just by this tip control. So the dilatator, you can see that it's olive shape. At the front of the dilatator, we have a stainless steel. So when you push, there is no damage to the dilatator itself. As you can see with some, we know that in some hard cases, our usual support catheters can damage the front, and we can use it again. So the pushability, there are three configurations. As you can see, the first configuration is when the dilatator is withdrawn in the support catheter, and you have the biggest pushability by this combination from all support catheters on the market. But if you use only the dilatator, and especially in the long extension, then the pushability is below other competitors, but it's very flexible, only the dilatator. But the combination support catheter and dilatator is the best on the market. And the third thing is the balloon. You saw it. We have 3 markers. So we have 6 centimeters between the markers, and this is very easy to see what kind of stent, which length of the stent you can use by only measuring with this balloon. So the usable length is, as Theo said, 18 centimeters. From 20, you can choose from 20 to 180 millimeters. You can use this balloon. So only where it is needed. And as you can see, if you want to have all the balloons on all the diameters and all the lengths, you should get 65 pieces. But if you have the Oscar, you only need 11 units. The results from the it was first cleared in USA by FDA, so you see how many people use it. And the main advantages are that all these physicians, they get 86% overall crossing success, and almost no need for CTOR escalation. So the Oscar offers improved efficiency, reduced procedural time, reduced device exchange, reduced contrast media. And I want to show you some of our cases. The first case, we have a Rutherford 3 patient, and you can see the angio now. This is a collateral. The occlusion is maybe 10 centimeters in length. So you see the typical configuration, the dilatator and the support catheter after it. You can check with the wire where you're going. Now, if you need more support, you just put the support catheter close to the dilatator and you get more support. You can inject, as you can see here, and unfortunately, it's subintimal, but the Oscar has no guilt for that. That's the operator. So we have a CTO guide wire escalation here. You can see the Stato 30. It was very easy to penetrate in the real lumen. Then you can pass with the dilatator. It's some kind of vessel preparation. And the support catheter following. You can inject to be sure, like that. And begin treatment. You can see the markers. For now, we are using the 12 centimeters of the balloon. And then for the proximal part of the SFA, we use the same balloon for predilatation. And this is the final angio, only with DCB. The second case, you can see occlusion of the popliteal, 17 centimeters in length. So again, the Oscar is advancing. Sometimes it's very difficult, but with the help of the whoop, you can advance. Unfortunately, we cannot re-enter in the Truman, so retrograde access, ATA proximal part, I use that, it's my favorite. I cannot say why, but it's very easy to just a moment. I have a problem with the presentation, sorry. Yes. This is, of course, we have to use Supera just to show you the result after the PTA. As you can see, very bad result. So we used a Supera stent at that place. And this is the final angio with the Supera. So the third case, it's a little bit outside IFU, but you can use the Oscar in the iliacs too. You can see occlusion of common iliac and external iliac arteries. So with the Oscar, you see here the Oscar, you see the dilatator and the support catheter. It was very easy to get through this lesion. Of course, the dilatation with the balloon, we used the whole length of the balloon, 18 centimeters, to predilatate. This is the angio after the dilatation, very extremely awful. But after implantation of 2 stents, 3 stents, you can see the final angio. So you can use Oscar in the iliacs too. And the final case, BTK case, as you can see in the left, occlusion of popliteal and below the knee arteries. This is the angio. This is what we have below the knee, only one interosseal artery. So we, just a moment. Sorry for the interruption. Below the knee, so the next. If you are too aggressive with the Oscar, here we have extravasation. I was too aggressive with the Oscar, but no help to get antegrade. So we switched to retrograde puncture. This is retrograde puncture of the interosseal artery. Luckily, you can see it very nicely, only from the fluoroscopy. No need for contrast injection. So we puncture the interosseal and put a guide wire there. And it was relatively easy from below to recanalize. You can see the two wires. So the balloon of the Oscar after some dilatations. This is 2.5. And we close the puncture site of the interosseal by inflating a balloon inside, and we just checked to see what's the situation in the foot. As you can see, this is the interosseal is the only artery. So after the dilatation of the whole segment, this is what we get. I didn't want to put a stent there, so we make a long inflation with 4 millimeter and 3 millimeter balloon, and this is the final angio, patent interosseal artery with nice diameter, and this is the foot. and the patient has no rest pain. So, the Oscar, one solution, multiple functions. You saw it in live, no compromise. Lesion-specific angioplasty with length-adjustable balloon and user-adjustable guide wire support for accessing and crossing the lesion. With that, I thank you for your attention.
Dr. Nedelin,
Yeah.
Oscar is a great device for anterograde approach for the CT occlusion to puncture the proximal cap. But did you try to go retrograde and puncture the distal cap? It's much softer and probably you would have a better result going into the true lumen immediately.
With the Oscar?
With the Oscar, yeah.
Yeah, I didn't do that. Sorry, it's first experience. So we are doing our cases only from antegrade, yeah, and not retrograde.
Retrograde.
Okay.
Okay.
If there is no more there are no more questions. Thank you for your attention.
Thank you very much for the presentations. Thanks to the panelists. There is a satellite symposium, as I see, and Dr. Petrov will guide. Thank you.
Thank you.
Great case, very nice discussion. Thank you very much, all of you, panelists, moderators, of course, the operators. Thank you once again. So we are starting the symposium about complex atherosclerotic disease and precising the antiplatelet therapy. And this is a very, very important topic, choosing antiplatelet therapy in patients with multifocal atherosclerosis. It's my pleasure to give the floor to Dr. Stankov. Professor Stankov will speak about escalation of antiplatelet therapy with prasugrel-based strategy.
Thank you, Professor Petrov. Escalation of antiplatelet therapy. We still looking for the best balance with antiplatelet therapy because we want to reduce the risk of the serious event in this patient and the bleeding. We have in the time so much trials we see for the last 30 years, and we have the trial he want to change the strategy to prolong double antiplatelet therapy, but with prolonged antiplatelet therapy we upper the risk from the bleeding, and we don't know what is the best, and for that it's necessary to look at in the all trials and for one patient to do best solution of the antiplatelet therapy. Why is necessary the antiplatelet therapy? In the patient with PCR, we see here the antiplatelet therapy reduced thrombus in the plaque, in the ruptured plaque, reduce the peri-procedure damage of the plaque and distal embolization, side branch occlusion, and it's necessary in the patient with stent implantation for the reduce the thrombosis of the stent. The risk factors for the antiplatelet for the modifiable and non-modifiable factors affecting of the level on the treatment platelet reactivity is the same to the risk factors to the atherosclerosis. Double antiplatelet therapy, like I say, it's necessary, but the balance is very important. And when we reduce the risk of the thrombosis, we going higher risk for the bleeding. And for that, we must do escalate or de-escalate of the antiplate therapy in the patient. Escalation of the antiplate therapy, it's going from the clopidogrel to the ticagrelor or prasugrel, and de-escalation, it's to change the ticagrelor and prasugrel to the clopidogrel, further reduce the risk of the bleeding. How to switch? In the patient with acute coronary syndrome, we use the biggest dose, 180 milligram ticagrelor or 60 milligram prasugrel. For the patient with planning escalate, we going for the 90 milligram ticagrelor or 10 milligram of prasugrel. To reduce of the risk of the events in the time, it's the must risk period is the first 3 months of the after stent implantation for the stent thrombosis, for the plaque ruptures and thrombosis of the artery. It's the same in the first 3 months. With the new generation of the stent, the risk of the thrombosis, it's only on the first month. The prevention of the stroke and other peripheral ischemic events in the same on the bigger in the first 3 months. And of course, the bleeding, it's the must frequently in the first 3 months of the antiplate, on the start of the antiplate therapy. But we see here that all time the risk of the bleeding with antiplate therapy, it's continuous the same in the after 3 months. Why and how to know why it's the necessary escalation of the antiplate therapy. Escalation is necessary in all patients with acute coronary syndrome and in the patient with complex PCI procedure. What is the complex PCI? PCI in the multivessel procedure, more of 3 stents, more of 3 lesions, or total stent light, more of 16 millimeter. We have head-to-head comparison of the prasugrelor and ticagrelor in this patient. We see the patient with prasugrel in the complex PCI, it's with little events, death, myocardial infarction, or stroke, but with patient with non-complex PCI, this difference is huge in the group of the prasugrel. For the complex PCI and bleeding, the ticagrelor patient have little percent of the bleeding in the group of ticagrelor, but not significant. ISA react compression head-to-head prasugrelor and ticagrelor to risk of ischemic events, combination of myocardial infarction, stroke, and death in the first year after randomization was significantly low with prasugrelor compared to ticagrelor. We can see on the table. Benefit of prasugrelor in reduction of the ischemic event, it's not associated with increased risk of the bleeding, no significant difference with 2 groups for the bleeding, but we have benefits for the events of serious events. we can see here we have different in the death, myocardial infarction, but not different in the stroke events in these two groups. Post hoc analysis. The post hoc analysis included all patients with acute coronary syndrome treated with PCI and randomized to either ticagrelor or prasugrel in the ISA React 5 trial. Complex PCI was deadlined, and the last one of the flowing multivessel PCI, more of 3 stent implanted, I say, more of 3 lesion or total stent light, more of 16 millimeter. The primary efficacy on the endpoint, we compatible to all case of death, myocardial infarction, and the comparate the bleeding. The result in all more of 3,000 patients treated with PCI in ISAR, we analyze it and let us see a result in the subgroup of patients with different with diabetes and non-diabetes patient. Here it's interesting, the ticagrelor in the group of the patient with diabetes, it's with better result, but in group with non-diabetic patient, the prasugrel, it's have significant different with events. Death, myocardial infarction, stroke. The patient with non-diabetic patient, the benefits of prasugrel is higher. What is situation with the patient with kidney disease and glomerular filtration? We have different significant difference in the two medicaments. In the patient with low AGFR, only in this group. In the other group, no significant difference in these two medications. The prasugrel in the group of the patient with low AGFR, it's significant better. What happened with the bleeding? The bleeding in these two groups, it's no significant difference with all of the group with low, normal, and medium AGFR. The benefit of prasugrel therapy over ticagrelor-based therapy observed in ISA React 5 allows a play to the subgroup of patients with end-stage acute coronary syndrome undergoing invasive therapy. We see here the number of 91 patients with end-stage and 20 patients with unstable angina, and 60 patients with end-stage in the group of prasugrel. On the conclusion, polydata from the multiple clinical trials supported prasugrel-based strategy over ticagrelor in acute coronary syndrome patient undergoing PCI. Prasugrel was tolerated ticagrelor with a lower rate of discontinuation of 20 months after PCI. The benefit of prasugrel is reducing ischemic events, but not associated with any increased risk of bleeding. Prasugrel is superior to ticagrelor in reducing ischemic events, regardless of AGFR values. Thank you.
Thank you, Dr. Stankov. From the audience, questions or comments?
Yes, Ivo, thank you very much.
Dr. Alvarez.
Congratulations for your lecture. But I'm worried about because in our daily practice we have too many diabetic patients. I know the superiority of prasugrel in many settings of our intervention, but what happened with diabetic patient? Is better to do ticagrelor or prasugrel? What do you think based on the clinical evidence?
Yeah, in fact, there are some data regarding some benefit from the ticagrelor utilization, and but we need probably more data to be absolutely convinced. And in fact, it's not in the guidelines as a firm indication to switch to ticagrelor in diabetics. You are absolutely right. At least 30% of our patients are diabetics. Yeah, it's a worldwide pandemic, the diabetic pandemic, and it's a huge problem. For me, the biggest prevention is the utilization of proven drug-eluting stent. In fact, this is that give really the change of the prognosis. Probably this is the most important strategy. And I would say that this is the oldest question in the medicine, the balance between benefit and risk. Risk-benefit balance is very difficult in the medicine. Professor Stankov mentioned that many of the patients that have a high bleeding risk, they share the same risk factors with the patient with high ischemic risk. And also we know that the score system, precise, DAP, CHADS-VASc, and HAS-BLED, they have the same components. And the CHADS-VASc and the HAS-BLED, they have overlapping half of the components. So it means that it's quite difficult to separate patients with only ischemic risk from the patients with only hemorrhagic risk. In fact, there is overlapping. So the patients that are with ischemic risk, unfortunately, they have also bleeding risk. And of course, it's quite difficult, and it's modern approach, the so-called tailored approach or individualized approach. And the clinical scenario from patient to patient varies, and it's quite difficult to have strict guideline, this group, this strategy, the other group, this strategy. In many cases, we have to change. Last week we had like experimental patient, unfortunately a patient with atrial fibrillation and vitamin K antagonist, and he received 4 stents in a non-acute coronary syndrome, just elective procedure. He had received 4 stents, 2 in the right coronary and 1 in the LAD. Our colleagues from another hospital, they forgot to prescribe for him the clopidogrel that was in the discharge document. There was clopidogrel plus vitamin K antagonist, but not on the paper, in the prescribing paper. And he stopped. In fact, he didn't start the clopidogrel, and he missed two times the vitamin K antagonist. And what he did? Thrombosis of all the 4 stents. And he came in a catastrophic situation. Of course, we opened the right coronary and the LAD, but unfortunately, he had aneurysm already formed. So it's, in fact, for the interventional patients, it's crucial to pay attention to that, because we know that the stent is a foreign body, and it doesn't matter it's a drug-eluting or it's a bare metal, it's a foreign body. And our body, our blood is trying to cover it with platelets. So we have to pay very much attention. It looks like, it sounds like stupid, but this stupid mistake can cause the death of a patient. Sashko.
I hope that the patients are the same Macedonian, Bulgarian, Serbian. They're all healthy, and they don't like to take a lot of pills. And the main thing about the prasugrel is once per day, and the ticagrelor is twice per day. So this is the advantage of the prasugrel from that kind of point of view, to convince the patient that he has to take the drugs.
We are right. The compliance is very, very important, and this, of course, once per day is a good factor to increase the compliance. Okay, could I have my presentation? It's about the opposite scenario. So Professor Stankov has elucidated the scenario in which we have a high ischemic risk patient with risk intervention, and this is the escalation from the good old clopidogrel that is in fact a PY12 inhibitor since a long time ago, more than 15 years ago. There are huge subset of data regarding the clopidogrel. And we, in this situation, ischemic situation and acute coronary syndrome situation, we are escalating the treatment. What about the high bleeding risk patients and a scenario, clinical scenario in which we have to de-escalate, so to reduce the power of the antiplatelet treatment to less potent treatment in order to avoid bleeding. In fact, the administration of a less intensive antithrombotic therapy after a short course of standard DAB has shown to reduce bleeding without any trade-off in ischemic events in stable patients or stabilized. So patients that used to be unstable but are already stabilized between 1 and 3 months after the acute coronary syndrome. And we know very well that there is a trend even to 1 month double antiplatelet and going to single antiplatelet. There are in fact 2 stents nowadays with this indication, and this is another topic. But I have mentioned already that in fact to choose between high bleeding and high ischemic risk for which patient it's quite difficult. One of the scenarios is exactly that I have mentioned already. So let's say to enforce the antiplatelet therapy for 1 to 3 months, and after the stabilization, the patient, and especially patients with high bleeding risk, elderly patients with history of bleeding, gastrointestinal problem, recent surgery, and so on. This is the situation, this is the scenario in which we need de-escalation. So the de-escalation is maintaining double antiplatelet, The de-escalation is to switch from prasugrel and ticagrelor to switch to clopidogrel. You saw in the presentation of Professor Stankov that the de-escalation, there are several, in fact, algorithms, the so-called unguided or guided. The guided de-escalation is to utilize the platelet aggregation laboratory test and also the genetic test. And after having the antiplatelet activity going down, to switch to clopidogrel with loading dose. Unguided is what he has shown. The unguided, just to wait 24 hours to have a gap between the previous taking prasugrel or ticagrelor and to have a loading dose of 600 milligrams. These are the 2 scenarios in case we need already the de-escalation. This schematic is the algorithm since 2018 in the European Society of Cardiology guideline. When we have concerns about the bleeding risk prevailing, we need de-escalation on the right part of the panel. And this is in fact the most often, the most frequent scenario in which we have to de-escalate. And it's even more difficult and more complex in patients that also have atrial fibrillation. In atrial fibrillation, for a long period of time, the only antiplatelet that was allowed to be in combining with anticoagulation with clopidogrel. And in fact, this is the most utilized medication nowadays still, is to add to the anticoagulant only clopidogrel and not prasugrel or ticagrelor, because the bleeding risk when we combine anticoagulation, it doesn't matter vitamin K or direct or oral anticoagulant to ticagrelor and prasugrel, the bleeding risk is even increased much more. And this is again the schematic about making the balance between bleeding and ischemic risk. And this is very important. It's more than obvious. It's more than obvious that nowadays the prasugrel and ticagrelor are in fact treatment of choice for acute coronary syndrome, and it's out of the question. But after the first month, and pay attention to have a real clinical and laboratory data that we have already a stabilized patient. So a patient with normal inflammation status, normalization of the troponin, no clinical events, so a real stabilization and high bleeding risk. In this situation, we have in fact the indication to de-escalate de-escalate the therapy. And what is the rationale? Like in other situations in the clinical practice, during the acute situation, we have the prevalence. We have to pay attention more to the ischemic risk because it's life-threatening, the ischemic risk. But after that, we can allow ourselves to pay attention more to the bleeding risk, again, in interest of the patient, to reduce his clinical risk, let's say. So, the factors associated with increased bleeding risk, I mentioned already part of them. This is the need for anticoagulation, the aging population, frailty, anemia with hemoglobin less than 110, chronic renal failure, low body weight, mainly for women, hospitalization for bleeding in the previous several months, previous stroke or intracranial bleeding, and already utilization of non-steroid anti-inflammation medication, oral anticoagulation, or even the previous utilization of anticoagulants. And these are the de-escalation strategies, and we can, after the third month especially, we can in fact choose in our practice when we switch to one antiplatelet only. In our practice, at least, in most of the cases, we stay with clopidogrel only. And in case we have to switch to anticoagulant plus one antiplatelet, we stay with clopidogrel because it's not an acid. There are several trials starting from old OWEST trial. In fact, the aspirin has a high gastrointestinal bleeding risk, and because of that, we are following these rules. And in most of the cases, when we need only one antiplatelet and anticoagulant to stay in the therapy, we are using not aspirin, but we are using clopidogrel because it's not acid, and the risk for the gastrointestinal system is lower. And I mentioned already that we have the two options in case we have a good laboratory on site. We have to perform the so-called guided approach, so to wait until the antiplatelet activity going down and to making loading dose of clopidogrel. Otherwise, in case we don't have such an option, we have to wait just 24 hours from the previous take of the prasugrel or ticagrelor. And yeah, this is what I have. And this graphic is showing what I have mentioned several times. So many of the patients have ischemic risk factors and bleeding risk factors, and 1/3 of them, they are participating both into the high bleeding risk scores and into the high ischemic risk scores. And because of that, we have to weigh the risk ischemic toward the bleeding risk and to choose the right risk. Which one is bigger? The thrombosis risk is bigger or the bleeding risk is bigger? In case we have just a scenario, in case we have long lesion, calcific lesion, underexpanded stent, acute coronary syndrome, we have the thrombotic risk higher. So we have to pay attention, and similar to our patient that I have mentioned, we have to give good antithrombotic therapy. In case the thrombotic risk is not so high and we have elderly population, patients with history of bleeding, with recent surgery, with low hemoglobin, in this situation we have to pay attention to bleeding risk, and we have to de-escalate to clopidogrel, and in most of the cases remove the aspirin in case we have anticoagulant. The TALOS AMI study, in fact, was one of the trials checking, in fact, these strategies. TALOS AMI is coming from ticagrelor versus clopidogrel in stabilized patients. I mentioned already for stabilized patients. By the way, you know that even in the guideline, even for acute coronary syndrome, the clopidogrel is not removed. It's alternative of ticagrelor and prasugrel even in the guideline, but on a higher dose. One of the strategies can be to give double dose of clopidogrel in high ischemic risk in case we don't have on-site ticagrelor or prasugrel. And this is the situation. In fact, the subgroup analysis of the primary endpoint in the pre-specified subgroups didn't show any big difference, but in fact, comparing to the control group, the clopidogrel didn't show worse result compared to the ticagrelor in stabilized patients. And because of that, it's absolutely advocated in patients that are already stabilized between the first and the third month after the acute situation. We can, without any problem, switch to clopidogrel to make the de-escalation. And I mentioned already that in most of the cases, we have to weigh bleeding and thrombotic risk in any single patients. Also the topic, the single center topic, that is timing of platelet inhibition after acute coronary syndrome trial, used an unguided de-escalation approach. And what was the result? The benefit of switching dual antiplatelet therapy after acute coronary syndrome. The topic randomized study have shown that is a switched double antiplatelet is superior to an unchanged double antiplatelet. So independently, if we have or we don't have a laboratory on site, it's better to remove the bleeding risk with the unguided treatment, so it's not so dangerous to make the simple 24 hours gap and to load the patients with clopidogrel. And regarding the short-term double antiplatelet, I mentioned already that several stents, BioFreedom and the Onyx, we were part, my team was part of the Onyx 1 trial. And I remember that after 6 months of participation in the trial, in fact, it was allowed, even from the beginning, to switch directly to single antiplatelet. It was amendment. It was an amendment to the team that in high bleeding risk patients, it's also allowed to switch directly to single antiplatelet and even not to start with double antiplatelet. And it's rare, it's infrequent, but in some patients, when we are implanting Onyx stent, we know very well that the endothelialization of the Onyx stent is very fast. It's about 40 days. After 40 days, the Onyx is endothelized. So in this situation, we can stay on single antiplatelet, and in case the bleeding risk is high, we prefer this to be clopidogrel and not aspirin. And this graphic is very nice. You see the interaction between the possible strategies, short DAPT, single antiplatelet, triple therapy, what kind of patients we have. So the scenarios are multiple. And because of that, after the clinical risk is going down, after not less than 1 month, between 1 and 3 months, we have based on the trials, we can advocate the de-escalation of the therapy without any significant risk, without increasing the thrombotic risk of the patients. Having in mind that, in fact, in the beginning of the P2Y12 history, the clopidogrel was this one that we had the biggest experience regarding antiplatelets. And this is also a graphic showing that even premature discontinuation of initial double antiplatelet, like I mentioned, for example, in the Onyx trial, mentioning again, there are only several stents with this indication. In this situation, we can allow ourselves, like leaders free. It was for the biofreedom stent, and after that the Onyx one that we have participated, there is a special sub-analysis of Onyx 1 showing and no any concern regarding short and extremely short double antiplatelet, switching directly to a single antiplatelet regime. This is regarding the Onyx that we have experience. We didn't have, by the way, no one in our group of patients. We were third recruiting team in the world. In the Onyx one, we didn't have no one thrombosis of the Onyx stent in our particular national group. And definitely this is, you see the early switch after the first month to PY12 and what are the results. There was no any concern regarding both regarding bleeding or thrombosis. Yeah, this is in fact, these are the summary and the conclusions by the Onyx one. This was the first trial comparing DS versus, in fact, one stent compared to the other. And the Resolute Onyx had improved angiographic outcomes and greater device success post-PCI without any risk of short DAPT. Okay, these are the conclusion, and the implications were very high. I mentioned several times that in nowadays practices we have it's very important that in fact in nowadays practice we have on-site the tailored approach for every patient. For these that are with high ischemic risk, we have the possibility to choose from several medication and several regimes. And for the other patients that they have a high bleeding risk, we have also a good scenario. It was like that in the past. In the past, we had only two options: aspirin, antiplatelet, vitamin K antagonist, and that's all. And now we have many possibilities because of the technology, because of the new stents, because of the short DAPT allowed by these new stents, and we have several different possibilities regarding the antiplatelet and antithrombotic medication. And because of that, the guideline is so complex, because now we have many possibilities that can be tailored, that can be individualized for any single patient in the clinical practice. So the de-escalation is one of the reasonable possibility in the patients with high bleeding risk after the time that is allowed in order to stabilize the patient. And of course, we can choose now between the between the medication that is with a lower collateral effects. For example, all of us, we know that the ticagrelor is fantastic medication, but not a neglectable proportion of the patients, they have dyspnea. And in case a patient have a dyspnea, we can switch without any problem to single or double dose of clopidogrel. So it's more or less tailored de-escalation in such a situation. And this is the situation. In fact, the newer P2Y12 increase and complications increase, so the bleeding risk is increasing, and we have the possibility to go back to the good old clopidogrel without, like shown into the trials, without increasing the ischemic risk, and very important, with decreasing the bleeding risk. And our population is definitely aging population, so the majority of them, they have high bleeding risk. And thank you very much for your attention. Comments or questions regarding the topic? We can speak all day long about this. Yeah. Thank you. Thank you once again. Thank you, activists. Teva now. But because activists is very much related to Bulgaria, because one of the main facility of the Teva is in Bulgaria, because of that we are sticked. And thank you for the support for Balkan endovascular course. In fact, this is the biggest supportive company for the endovascular course, so thank you once again. So I will ask Dr. Martinov to come to podium and to lead, to moderate the next several presentations. Dr. Martinov.
Dear colleagues, as always, Professor Petrov is very busy, and I try to be his avatar, not so successful. I'm giving the floor to Dr. Dobrichkov for the next presentation. He's not here. Okay, I'll start with my presentation. I'll be one-man show, obviously. Okay, as a part of emergency hospital, this is one emergency topic for thrombus complications, peripheral thrombus complications. This is acute limb ischemia. Sorry. Okay. Some history. Thrombolysis is dated by at least 60 years ago. Interesting fact is Fogarty catheter is introduced after first attempt, but after unsuccessful attempts, the surgery has become a leading factor and leading procedure for peripheral thrombosis. And after a while, after 90s, there's a big revolution in techniques for catheter-based and revolytic procedures. Acute limb ischemia is a situation, the problem is above 2 weeks, and that's why there's not enough time to generate collaterals. That's why it's urgent situation, and thrombus should be removed fastly with fast and aggressive therapy. And nowadays, the endovascular treatment is comparable to classical surgical removal with Fogarty and other procedure techniques. This technique is on the guidelines. The catheter-based and catheter-directed thrombolysis are considered as alternative to surgery, as I mentioned. This is in the guidelines. The two drugs are like urokinase and RTPA are approved. And with interventionalists, I started when the surgery was only one option, and things that we were dreaming at this time are reality now. This comparison between techniques, sometimes the thrombolysis, local thrombolysis is better in patients with a lot of comorbidities, and in that case the thrombolysis is better to avoid general anesthesia in older patients and a lot of comorbidities. This is the best option. And the fact that with this technique we are dissolving the thrombus, there's better consequences in the small vessels. We are dissolving the clot, not removing it. That's why the better outcome is due to that fact. In our institution, we are using Craig-McNamara catheter with a lot of holes, different lengths of this part. We are using Actilise or RTPA agent, and with different dosages, but we are sticking to the low dose regimen because our patients have a lot of comorbidities. Sometimes they are very short after operation, any kind of operation. That's why we are using low dose regimens for 24 hours with small bolus dose. This is comparison between those regimens. There's a lot of variants, but they are faster, other with high doses and high dose maintaining dose, but the results are almost the same with a little more hemorrhagic complications. The most of complications are bleeding, especially on the side of puncture. This is the main problem. And distal embolization, which causes a lot of pain, but in the long period of 24 hours, a lot of distal embolization are lysed by the drug, and we have very few cases with which are with old thrombosis, which are go to the amputation. This is our cases through the years. You see, especially this peak in the COVID time, 2021 year. We have a lot of experience, and we are performing a lot of procedures outside the leg procedures, in mesenteric, and you will see sometimes in the upper extremities and so on. Mechanical and thrombectomy, we are using angiojet especially, This is one of the forward cases, thrombosis of popliteal distal femoral and popliteal artery segment with Ingujet. This is the first pass, and the final result, you see in the first pass a little restoration of the flow, and at the end you see some parts of the popliteal artery with dissection. That's why we often stent at the end of the procedure, stent these segments, but this segment is not stented because the dissection is retrograde. Thrombus aspiration, there's a lot of devices, single hole devices like penumbra. I saw here penumbra or Aspirex, a lot of systems which are with different kinds of thrombus degradation, like in Angiojet there's a saline injection in the thrombus and then aspiration. And these are the comparison with with different techniques, pharmacomechanical or pharmacological thrombolysis. There's maybe better to aspirate at the end of the day. Angiojet thrombectomy. This is I told you about the principle. We have a lot of catheters from 2 mm to 20 mm, different catheters for different vascular parts. There is our initial experience when we started with the Angiojet. We compare thrombolysis patients and Angiojet patients, and you see that the results are comparable about the pain, about the relief of pain, amputation, surgery. You see the double in the thrombolysis part, the double number of hematomas, and a lot of PTA, as I mentioned you before, a lot of PTA in the Angiojet group. This is one case, and I'm at the end of the presentation. This is one case, very recent, which is published in 2 journals. This is a 70-year-old woman, which has thrombosis of upper right hand and right leg. We performed on the settings of atrial fibrillation and anticoagulation with edoxaban. That's why the thrombolysis is impossible. You see the thrombosis of right axillary and brachial artery. It's a little bit slow, but you see the distal brachial artery, the second thrombosis, and thrombus in proximal femoral and distal. Very complicated situation. This is the endless procedure with a lot of aspiration in 2 vessels, and the final result with 1 catheter, aspiration with 1 catheter in the right hand and right leg. Trust me, the proximal brachial is because the movie is not working. You see the distal radial artery patent and femoral and popliteal. The patient was alive with hand and leg after 30 days, and with these Doppler images with pulse on the patent sites at the end of the procedure. Thank you for your attention.
Thank you. Very, very impressive number of patients dealt with fibrinolysis and angiojet. Congratulations. In most of the times, the most important thing, in my opinion, is the time you have to resolve the acute ischemia and in the degree of the ischemia. If the fibrinolysis can, if the ischemia is not so pronounced, you can use fibrinolysis. If you don't have time, you should use mechanical thrombectomy or surgery and so on.
Yeah, it's good to have all options.
To have many options, right?
They are comparable and they're helping each other in bailout situation especially. And you're right that we have a lot of patients which are coming very late, and every option is not so effective.
Okay.
Okay, I'm sorry.
Thank you.
Now I'm giving floor to Dr. Dobrichkov for his presentation.
Thank you, Dr. Martinov, for your great presentation. It was a smooth transition to my presentation. So, dear moderators, colleagues, it's a pleasure for me to be here today. Oh, yeah, here are my slides. So today I'm going to talk about the rheolytic thrombectomy in patients with acute and subacute limb ischemia. Here are my potential disclosures. So the acute or subacute, more than 14 days limb ischemia is one of the most common emergencies, peripheral emergencies, which the vascular specialists face in a daily practice. So the target therapy should be restoring the blood flow, of course. And as a vascular surgeon, the first thing which is coming in my mind is, of course, the open thrombectomy with the good old Fogarty catheter. It's fast, it's cheap, it's easy to perform. It could be done even with local anesthesia for a plain thrombectomy. So it looks like the perfect thrombectomy option. But is it really so? Because in the endovascular era, we are facing new type of lesions, for example, the instant thrombosis, acute instant thrombosis. So in such cases, doing an open thrombectomy is not really good. While the contemporary lesions require contemporary solutions, contemporary treatment. So here comes the endovascular treatment, which is less invasive, but also it shows comparable results to the open surgery. And in some lesions like instant thrombosis, for example, the catheter-directed fibrinolysis with or without manual aspiration, thrombus aspiration, shows better results compared to the open surgery. But is it the catheter thrombolysis good enough? Actually, the answer is no. So the fibrinolysis, it's not always effective enough, because sometimes, as Dr. Nikolov mentioned during the discussion, when we have acute limb ischemia, time really matters. And it's a two-stage procedure, because first we have to either implant the Fontaine catheter and inject the tissue plasminogen activator, leave the patient on lysis for 24 hours. After that, check, dilate, and so on. So also it's not very effective for subacute lesions when they're a bit older, and of course the bleeding risk is higher, so it's not very suitable for high-risk patients. In those cases, the percutaneous thrombectomy might be the better option, and when there are no contraindications for fibrinolysis, the pharmacomechanical thrombectomy could be performed. So here on that heavy slide, you can see all the different types of thrombectomy, endovascular thrombectomy devices. But today we're going to talk only about the rheolytic ones, like the angiojet or JETI. So the angiojet uses saline jets which are streaming backwards from the catheter tip backwards with half of the speed of the sound. So that causes destruction of the thrombus first, and second, with that high velocity streams, they are causing negative pressure, so that leads to aspiration of the thrombus back to the machine. Together with the power pulse or power spray option, which injects TPA deep into the thrombus, the results are even better. So here you can see all the peripheral catheters for the angiojet system, but we are going to concentrate only on those three, the Solent family. Solent Dista, of course, that's the smallest one. It's for the small diameter vessels below the knee. Solent Omni and Proxy, they're for bigger vessels, bigger than 3 millimeter in diameter, and they're basically the same catheter but with different length of the sheet. As you can see, the possible complications after percutaneous thrombectomy are very similar to every percutaneous procedure, except the hemolysis. So the saline streams, the saline jet streams, causing hemolysis during the destruction of the thrombus, and that leads to hemoglobinuria, which leads directly to tubular dysfunction, sometimes to tubular necrosis and acute renal failure. So I'm going to share with you our small experience with angiojet catheters. The first case is quite simple case. It's 81 years old male with arrhythmia, with chronic kidney disease, and presenting with a short distance claudication for 1 week. But that patient had history for longer claudication, so we weren't really sure if it's about embolism or acute thrombosis. Because I'm not sure that it's good seen, but first we started with CO2 angio, and after that we enhanced the angio with a little bit of diluted contrast to have more information about the lesion. So we saw pretty short occlusion of P3 and the trunk. So in that case, we didn't use the power pulse. We started straight with the thrombectomy. First, the P2 segment to ensure that at least one artery will be open, and after that, a secondary thrombectomy of the trunk. The distal runoff shows some subtotal and total occlusions of anterior and posterior tibial arteries. So after plain ballooning, the results were quite sufficient. That patient was discharged with palpable pulses on both pedal arteries, and the total thrombectomy time was 170 seconds, which was quite short. The second case is a bit more complicated. It's 63 years old female with many interventions. So first she underwent partial sampientimo, partial intraluminal FEMPOP total recanalization. After that, she underwent many reinterventions for restenosis. The last one was 5 months ago. And after that, she appeared in the department with critical limb ischemia for a couple of days. The interesting is, unfortunately, I'm not sure it's seen good enough. The contralateral common femoral artery was covered with superior stent, but despite that, we decided to go crossover from there. On the angio, you can see total fresh occlusion of the femoral-popliteal segment. So after power pulse and injection of 20 milligram TPA and waiting, of course, 20 minutes, the real thrombectomy started. So after, I think, 270 seconds of thrombectomy, the midterm runoff doesn't show really good results. So we did another session of thrombectomy, now with much better results, but as you can see, some residual stenosis, which were treated with balloons. Before ballooning, we exchanged the O35 wires with O14 filter wire for distal protection. Of course, it's not really good seen on the slides, but the filter wire is placed in the tibial perineal trunk. For that subtotal stenosis at P3, we used 5x20 cutting balloon, and we stented the subintimal part of the SFA. So this is the final angio, really good results, palpable pulse of both pedal artery, but we overexceeded the thrombectomy time a lot, which which led to increase of the creatinine levels on the day after the procedure, and hopefully, thankfully, the creatinine levels went back to normal in the next few days. The last case, it's about a 74-year-old male patient who underwent a total subintimal FEMPOP recanalization, both retrograde and antegrade, and the whole area was stented with approximately 45 centimeters of implanted stents. So during the first procedure, he had partial in-stent thrombosis, so he was treated with fibrinolysis but discharged with distal palpable pulses. 8 months later, he was admitted with short-distance claudication for 10 days to 2 weeks. We decided to go to do a crossover percutaneous thrombectomy. Here are the initial angiograms. So after 20 milligram power pulse injection of TPA, yes, okay. We did 1 session of thrombectomy. You can see subtotal stenosis and patent below the knee arteries. We treated the artery with drug-coated balloons, and the final results are quite good. The total thrombectomy time was 320 seconds, and patient was discharged with palpable pulses on both pedal arteries. So, what can I share with you from our quite short experience with angiojet system? So, it's not very common to have distal embolization during the real thrombectomy because you're moving the catheter from distal to proximal. So, of course, they happen. Distal embolization do happen, but not that often. So it's better to use O35 wire or even stiff wire to have more stability because shaft of the catheter is very rigid. So it's better to have a more stable system. But on the other side, right before the ballooning, it's better to switch to a filter wire because there are still remaining microthrombi between the stenosis. The risk of distal embolization right after or during the dilation is really high. Always use power pulse when there are no contraindication for fibrinolysis because the results are much better. Always wait 20 minutes after the power pulse just to have enough time to dissolve the thrombus before trying to remove it. It's good to keep in mind that the Solent, Omni and Proxy have suction volume of 60 milliliters per minute, so it's really easy to keep in mind how much time and how many milliliters of thrombectomy the interventionalist performed. And something what I've found by my own, because of the shaft of the catheter is translucent, and you can see when it's not used, and you can see the metal core of the catheter. So while you're doing a thrombectomy and you're in the thrombus, you see dark blood, the dark red blood like venous blood. But when you're out of the thrombus and the vessel is totally clear, you see a reddish translucent fluid, but you can see the metal core of the catheter. So, another take-home note, never exceed the maximum thrombectomy time, because over-exceeding the thrombectomy time always leads to hemolysis. Hemolysis leads to hemoglobinuria, and that leads directly to kidney impairment. So if there is no other option, like the patient from the second case, you have long occlusion, big arteries, and you have to do another session, make sure that you have enough time between the separate sessions. The patient must be always good hydrated before, during, and after the procedure. And adding sodium bicarbonate to the saline solutions lowers a lot the risk of tubular necrosis and kidney failure. Even in low-risk patients, the post-op fluid balance and renal function should be checked up and followed up in the upcoming days. Hemoglobin decrease on the day after or the upcoming days post-procedural means usually hemolysis, not always bleeding. So sometimes we start searching for occult bleeding, but usually it's due to the hemolysis. It's very common to local and distal vasospasm to be observed, so intra-arterial vasodilators work really good, and local pain, just focal where the tip of the catheter is, means that we overexceeded treated time in that particular area. So we always should communicate with the patient and ask if he or she has any discomfort, in particular in the treated area. So if I have to summarize everything in one sentence, I would like to say that rheolytic thrombectomy for acute and subacute limb ischemia is a reliable method for one-stage revascularization with good technical success. It's less invasive than the open thrombectomy and with lower bleeding risk and blood loss than the fibrinolysis and aspiration. Also, it shows good long-term results for limb salvage. So, thank you for your attention. This is part of the references I've used. Thank you. Oh, any questions or comments? Okay, thank you.
No, thank you. It's a pleasure for me to hear that this type of procedure is working, and now we should try to resolve the reimbursement status of this procedure.
This is the main problem, yes, you're right.
Because you see, we are different centers with very similar results, very good results, very fast. In some situation when you have problems with the thrombolysis, as I mentioned, recent surgery, this is the only option. Or in my case, when this woman was on anticoagulant treatment now, and the thrombolysis is not in place. That's why, congratulations once again. And now, Professor Stankov, maybe you?
Hello to everyone, my name is Dr. Strihil Vasilev. I will present the next presentation.
Okay.
Yes. No, the endovascular treatment of vein grafts, peripheral vein grafts. Yes. So as we all know, for patients who have chronic limb ischemia and infrapopliteal occlusive disease, distal bypass with autologous vein graft is recommended and being used. However, these vein grafts can develop a clinical stenosis because of most commonly intimal hyperplasia. And so the distal bypass secondary patency rate is around 70% at 5 years. How we can manage this? In the management of these failing grafts, surgical revascularization is the standard procedure. However, the technique requires additional autologous veins and carry the risk of complication associated with reoperation. So in these patients, endovascular treatment is a possible option, and because it's minimally invasive, and even though there is no clear guidelines, we can perform it, and there is quite a few cases and studies which present its feasibility and safety. Here is one study where they retrospectively studied 94 patients treated endovascularly for failing distal bypass grafts, and they defined the vein graft as if there is evidence for significant stenosis, they decided to treat it, and it was defined as a failure of the vein bypass. So the mean time interval between the prior initial bypass and the endovascular treatment was 7 months. And as you can see, the primary patency is 41% and 1 year. Endovascular treatment should be the first priority for patients with failing vein peripheral bypass, which have focal stenosis of 2 centimeters, and if the bypass is at least 3 months of the initial bypass surgery. Here another study. You can see that the wounds healing rate is pretty good, and at 12 months, 80% of the patients are with healed wounds. Of course, here is another study showing the efficacy, but now I want to show you our experience in our cardiovascular center. For the last 5 years, we have 33 patients with occluded peripheral bypass. We have revascularized successfully 28 of them, and in 100%, the dilatation of the distal native artery treatment for stenosis or occlusion is done also. This is pretty important because if there is a reocclusion of the bypass, we have a distal native artery which is already recanalized. Distal protection is another important part, and we have used it in 70% of the patient. The results, acute right thrombosis we have only in 25% of the patients, but that is not that big of a problem because we have stented the native artery also. Secondary intervention in the 3 months post the initial interventions is in 12 of the 28 patients. And the patency at 6 months, as you can see, 70%. More of 2 procedures for 1 year in the follow-up was in 30% of the patient. Here is a clinical case. You can see the integrate approach and the diagnostic angio. After that, the crossing of the wire distal in the native peroneal artery and the placement of the distal protection. This is one of the most important parts, the distal protection placement. And after that, pre-dilatation with a balloon and after pre-dilatation. This is removing of the distal protection after the stent implantation, and also the result after the implantation of the stent. You can see. After that, as I already said, we did a balloon dilatation of the native artery in order to have a good outflow of the blood. And you can see the final result for the tibial artery. And we have a perfect distal restoration of the blood. Here the distal anastomosis. And the final, the bypass. And as a conclusion, a primary balloon angioplasty for failing lower extremity bypass is a feasible and acceptable and safety method for patients. in the majority of them, if they have a short lesion and the bypass is within 6 months of the operation, the endovascular treatment should be one of the possible mechanisms that we should always think of it. And as you can see, there are pretty good results if we follow the stenting of the native, recanalization of the bypass, and also following up the patients after that. Thank you.
Questions? Comments from the surgeons?
I think saline grafts are failing surgical bypasses are mandatory to be to be maintained by so-called secondary patency. It is difficult for us to diagnose, to find those failing grafts because patients are not so compliable to therapy and follow-up. So congratulations to your center for excellent follow-up. So you can pick and diagnose such patients.
Yes, thank you.
Thank you. And now,
are we ready for the case?
Yeah, hello?
Hello?
Can you hear us?
Yes.
So greetings from again from the National Heart Hospital. We are starting our next case, case 2. Next slide. Next slide, please.
Give us a second. Doesn't work?
I don't know. Something is.
There are a few words left. We will show the end.
Okay, we'll show you the angio. Can you play the angio? The first one. Yeah, it's a 64 years old lady with Rutherford 4, minor 5 minor tissue loss and rest pain, CLTI patient. We have occlusion of distal part of the SFA. Next. And the whole popliteal artery. This is the reconstitution. As you can see, we have high bifurcation of the ATA, and we are going to recanalize that. We've done some work. Dr. Bizdas put 90 centimeters 5 French fortress from contralateral side to the occlusion, and we're ready.
Thank you, Madeline. So what we have done until now is we have punctured from the right side, going crossover to the left side. We have used the 590 just to have enough pushability. We are here at that level. Now we have a Command 18 wire and the Navicross catheter. Carnelian support catheter, and now we will try to go from undergrade to canalize it. It's going to be tough because it is very small vessels with a lot of collaterals, and in case that we are not able to get inside or to have difficulties to get outside, we're going to do a retrograde puncture of dorsal pedal artery. So now I'm showing you where I am. I am at that level here, so I'm trying to get here inside with the cornelian. So this is the first part of the occlusion. We have to be very careful here because it is a very small artery. So this is the reason why I have always, through the 5 friends, my contrast to check always where I'm going. A lot of rotation here. It seems that it goes to the right direction.
A bit
Again,
of a
support.
technical problem. Please hold on for a minute.
Okay.
I'm sorry to interrupt you, but we don't see your pictures.
Yes, sir.
So your plan is to recanalize the occlusion with the Carnelian catheter and the wire, right?
So can you hear us now and see us?
We can hear you perfectly, but we can't see what you're doing.
Okay, so as I said again, you can see now in your screen the tip of at the upper part of the screen, you can see the 5-friend seat. Then it comes a small marker. This is the marker of the Carnelian support catheter, and then we have the VA18 catheter. So now we are rotating a lot, a little bit of contrast. So I'm giving a little of contrast to see that I am in the right lesion. Can you change the contrast? So always what we are doing is we are supporting every step with our Cornelian catheter. Be careful with the wire. So be careful with that. Okay. So now I'm going further. Here is important to avoid any kind of loop. So very slow movements, very small artery. You see, I'm trying always to follow it. Again, a little bit contrast agent. You see that we are in the right position. Everything seems good. And going further. So a lot of rotation, you see. Here it went. Okay, that's good. You're going to the one or to the other direction. Now you see that it has a little bit of a lazy S form, the wire, so never in this very difficult situation where you want to avoid to go subintimally, always support your wire with your support catheter. Keep the wire without loop and always rotate, 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 rotate. Again, it is relatively good. Yeah, we will do an angio again. I'm going a little bit with a support catheter. It's a little bit difficult to advance him, but the Carnelian performs a nice job. So it has very, very small tibial arteries to puncture retrograde. So if we are able to avoid them, to avoid this maneuver, it would be nice. So let's see where we are. It's not bad. So we're very closely to get inside the artery. So this is gonna be tricky, but okay, it goes a little bit away from the artery. Let's see. I'm going with the Carnelian further inside. Okay. Now we are very closely here. I'm going back and again. So I think
You're in the 88.
I'm in the 88, that's right. We will see now. But even if I am here, I have difficulties to get inside. This is probably the distal cap. Let's see where we are, Enzio. Okay, we are in the 88, that's good. Now we have to go to the, it's a little bit higher. So let's go a little bit further inside. This is difficult, okay, that's good. Okay, now let's do an angio from here. Can you, to see where we are? Can you? I have a back bleeding from my catheter. That is a very good sign. Always check if you have back bleeding in order to avoid contrast without reason at that level. No, it looks really good. So now the question is, we are intraluminal, what we can do. In this case, I would suggest to go with a very small balloon, a 3 millimeter balloon, to do a small pre-dilatation. And then after that, we're going to perform, due to the fact that we have only fibrotic tissue. If we have a good result with the 3 millimeter, we may use a chocolate balloon. Otherwise, here it is. I don't want to go into the anterior, sorry, I don't want to go into the anterior tibial artery, so I will do a small, I create a small curve to my V18. Give me a needle. This one. So in this case, we are creating a small, can you see my hand? So you're taking a needle and you're creating a small curve. Otherwise, all the command 18 wires, they have this small needle here where you can really create this maneuver, can do this maneuver to make this form in your, exactly. So, and here, sorry, and here you can get inside. So, of course, you can park the wire inside your arteriotibial artery. I will try to go to the P3. If not possible, I will not lose any time further. Here you are. Yes. Okay, now it's much better. Good. I remove. Remove further. Okay. So let me check where we are. We are fine. Okay, now let's do a smaller zoom and let's do the first angioplasty. Here is our seat. Perfect. Any question until now?
Everything is going very smoothly in your hands.
We are lucky, just lucky. So, okay, good. Yeah. So now you see, I don't like all these kind of lesions because you may end up again with a full metal jacket here, despite the fact that you don't have any kind of calcium, because this is a really bad PAD with very small vessels, a lot of fibrotic tissue. So let's check now how it's going to be the outcome with a 3 millimeter balloon.
3 by 120.
Okay. Is someone else that would do something else? Would choose, for example, a 4 or a 5 millimeter balloon? Yeah. Right? It's a one. It's a long one. Okay, let's start here. Let me check where I am. You see that I'm giving very small shots of contrast. Try to be as precise as possible with your treatment. Okay. In order to avoid any problem. So we want, this is 120, I think.
120, yeah.
20. This is important to see then how long is the lesion. It is around 150 probably, or even more. Let's see. Okay, now we are doing the dilatation. Okay, thank you. Let me check. I will try to go up to the distal part first, just to be sure that we were able then to come back. Okay. It is difficult, but we're gonna do it. Let's get inside. Wow, very difficult. Up the wire. Okay. Here you are. Okay, good. Let's start there. Maybe she has paid.
Може да има болка, ще кажете веднага, ако се получи болка.
Okay, nice, very nice. Very nice diameter, 6, go to 8, it's okay. Good, okay. So this is enough just to create a channel. It will not make vessel prep, this kind of balloon. And now we're gonna repeat the same up to the upper part. Let's have it deflated. Yes, okay. So I put the marker at the distal part of the screen to avoid, to have a nice overlapping, and here comes the other marker. Okay. Here is nice. You see the stenosis there. A little bit 8. Okay. Contrast, I have it. Okay, you can. So we're going back now with the balloon and to see the first angio. Okay. Do you want to remove? Yes. Just sure. Okay. Okay. So now we're gonna try to have as much as possible from the lesion. To do the first angio to see what we have done. Okay, I have it. Very nice. So very nice outcome. So nicely open. There are some points of recoils, maybe dissections, we will see. Let's check where it ends, not to lose the wire. Okay, give me some contrast. Let's do the 3.5. Yeah. Okay, I mean, Nadlin has a very nice idea of using here a chocolate balloon. And based on our previous discussion, this is an ideal case because we see no really severe dissections. We see that there is a mismatch of the lesion diameter that we have achieved with the balloon and the distal part of the P2 segment. So I think we need a little bit more on diameter on this vessel. And to have a safe, let's say, opening, we're going to use this chocolate balloon in order to have the outcome that we want. This is a 3.5 to 120, probably? 120. Yes, 120. After the chocolate balloon, we're going to see what happened, and maybe we're going to use a 4 millimeter DCP if the angiographic outcomes allows it to us.
We should switch it to 040.
040, okay. Give me the carnelian. So we have to switch on 040. Give us a few seconds for this. So based on the need of chocolate balloon, alternatively here we could use also a scoring balloon, also very nice treatment strategy. And someone could also use an atherectomy device here if he had access, based on the fact that we are almost in the whole case intraabdominal. So we can use a rotational Phoenix or Jetstream. Jetstream is too aggressive into my hands. In case that you need a rotational atherectomy, I would suggest Phoenix from Philips.
Any questions?
Okay, I have a question. How do you decide usually what diameter of the balloon should you use? Is it based on the upper and distal part, the opposite artery on the CT, or echo examination? Because we know from some IVO studies that usually the diameter of the vessel is a little bit bigger than commonly applied balloons.
It's okay. Not tell your opinion about this, I will do mine.
What is your personal strategy? How to decide what balloon to use?
If you have, for example, if you have a CT, you can decide from the CT. But most of the cases, it's up to the experience of the operator. For the SFA, it's usually 4, 5, and 6. So for the popliteo, it's maybe 4 here. It will be okay.
More or less the same. We are trying a little bit to use also the ultrasound directly in case that we don't have a CT scan. But to be honest, in the majority of the cases, we are very aggressive. So almost 5 to 6 for males and 4 to 5 for females. But if you are not sure, it is not it's not a big deal to take the ultrasound and to measure the healthy P1 or the proximal SFA.
Yeah, not IVUS.
External.
EVUS, exactly.
EVUS.
I mean, IVUS is it's a moment that there is a big discussion about the need of IVUS. The point is that even if you're trying to use IVUS, as I said, you're gonna see a lot about recoils. You're gonna see a very nice expansion of your stent, but I don't think that IVUS will change a lot of my strategy at the moment in this case, because even if I see a small dissection, it is very difficult, as I said, to the IVUS to understand if it is flow limiting or not. Everything in IVUS looks like a big disaster, like that you have done really a bad job in your treatment. So at the moment, the current algorithms and guidelines and the way of interpretation does not convince me to start using such an expensive technology. I'd love this technology, for example, to understand if this is a thrombus. I would love to see this technology in case that, for example, you want to use a directional atherectomy and you want to see if your wire is in a subintimal or intraluminal space to avoid any injury of the vessel. But in the current case, just to measure the right artery or to see if we have dissection, I don't think that we have a great advantage. This is, however, my poor opinion.
And one more thing, dear colleagues, the chocolate balloon, for those of you that don't know it, it's a balloon with a cage of nitinol wires. So the intention here is to have a uniform inflation and pressure on the vessel wall.
So you're going slowly, probably?
Yes.
Let me show you where you're going. Okay. This is in magnification. Okay, let's start. Okay, we will leave it for a few, go to 8. We're gonna leave it for a few seconds just to do the job. You see how it looks like? It is not like a normal balloon. You see the cages in this nice picture. And we're gonna leave it for a few seconds there to have a nice result. Do you have any experience with chocolate in your daily practice?
No, in daily no.
Daily.
But it is reimbursed in Bulgaria, so
okay, that's good. I think this is also a nice case where you can say that a bypass first approach would not be the ideal, in my opinion, here, because also the proximal SFA is suffering a little bit. I don't know, would you think that bypass surgery would be good here?
I don't think so. My first intention would be endovascular.
Guys, what is your opinion?
And the panel?
I would vote for endovascular as well.
Yeah. So this is the balloon, it's coming down, and let's go up. Okay, let's do another one. Here we go. Okay, sorry. Slowly, we're going up to 8 atmospheres.
Има ли болка?
You see again, very nice. It's amazing. The picture is very nice.
Yeah.
Okay. A nice, important trick here was that we have used the long seat. So this provides you a unique stability to do this. We could use also here the Oscar seat. It could be also a nice solution. But due to the fact that we wanted to start with a 3 millimeter, the support of the cornelian plus the seat. So it was the reason why we did not use Oscar was that Nadlin had the total right. We wanted to start with a smaller balloon, and so far I know it starts from 4 millimeter, the Oscar. The 3? From June, okay.
For the BTK from
That's good. We don't have it available. That's great. Not bad.
Yet.
So now it's time of truth. If this thing works or not. Okay, do you want to remove?
Yes.
One back. Reduce. Okay, perfect. Run fast. Here you are. So let's see now. So Cornelia has done a good job, Command 18 as well. Now let's see the chocolate, and then let's have a final decision about the speed. Okay, leave this piece. Okay, time of truth. Wow, very nice.
Yeah.
So I think we have a very nice flow there. Let's see a little bit further down. I don't see any kind of contrast staying at the vessel. I don't think also that at that moment, we need any kind of stent here. So my suggestion would be to go for a 4 millimeter DCB, just to have, you see that we are reaching slowly the diameter of the P2 segment.
Yes.
Okay, let's go for a 4 millimeter DCB. Everybody is happy there?
Some other suggestions? Can we show the chocolate? Can you zoom? This is the cage.
Yes, perfect.
Okay. Точно така, ние сме там работим. Да. Да. Точно така, госпожо. Парене, да. Това е контраст. Leg flow, 4 by 150.
Okay. So let's see what happens now.
Theo, if there were bigger dissections and you needed to stand it, what should be your choice in this
That
situation?
was exactly my thought at the moment. So yes, I would go here because I don't like small superas. I have very bad experience with 5.5. I will go for just normal bare metal stent. Pulsar is a good idea. Live stent from BD is a good idea. So devices that they have this kind of flexibility. So Pulsar probably would be a good idea here. All right, and all right. Okay, let's start. Do you agree? Would you suggest something else? Sorry, yes. Would you suggest something else?
I also like very much Pulsar for it low profile and thin struts and good flexibility, and it's doing very good job in this region, I think.
I think what we are missing is a study where you're going to show that with a very good vessel prep and then with good uptake of the medication, at the end the stent doesn't play
big role.
Doesn't play an important role. This is where I think that we are going to end up, because I have never seen in my daily practice big disadvantages of the old Everflex from EV3 and Medtronic. I have not seen big differences using, for example, Pulsar and live stent. This was really important, the different thin struts and all stuff, when we did not have the meaning of vessel prep and DCB. So, however, the future will show where we're going, the right direction.
You are using paclitaxel DCB or sirolimus DCB?
Paclitaxel.
Paclitaxel, leg fold.
So we need a small DCB. So this was 150.
Yes.
It needs 1 minute and 30 seconds. Let's have the next one.
Maybe 20 centimeters of push.
Yes, it's more or less 20 centimeters, yes. So I would be very, very happy if we avoid here the stent in this young lady. Yeah. The tissue loss is at the level of the Achilles heel. So we will see then if we have also enough blood on that level. So the indication was absolute right here. You can go any bigger. Sorry, you can take longer.
1 minute. 30 seconds. Okay.
I mean, you can take longer DCT if you don't have. Important.
We want to, because we have different balloons,
No
we
problem.
want to continue with paclitaxel or sirolimus.
Paclitaxel, if it's possible.
Paclitaxel.
Not to change the balloons. If you don't have it, we're going to use sirolimus. Okay, I cannot open it at all. So, Nadlin has the power and the breakfast, exactly. So, now let's see the last part now. Here you are. Okay, let's do the final. Do the angio then. Where, do we have it? Let's go. Okay, I have it. So, everything is still fine. We're going to do the last DCB. Give me this one here. Okay. Yeah. 60. Okay, it's okay. So, it goes through fence.
Fine.
Okay, let's
Okay,
get final.
so-
Let's do an angio to see where we are and what we have done. Very nice, very nice. Don't see this kind of, you see like small clouds, like dissections. The vessel is really, really nice. We can open now the very proximal part with the hope that we're gonna do any kind of dissection, and I think that's all for today.
We'll need one go up.
Yes.
We'll wait.
So let's see the distal part.
Yeah.
What we have here. Very nice. Wow, 3 vessels. We couldn't see these vessels before.
Yeah. The flow was very slow. Да, нормално е, госпожо. Напълно нормално. Nice.
Nice, very nice. Perfect. Okay, that's great.
Да.
So,
Сега ще.
last part, and then we are ready. If you want, because this is a boring part now to do the angioplasty.
To wait for the PTA.
Yeah, you can go for a presentation, then we can come back with the final outcome, whatever you want.
Okay, we'll take a break. It's lunchtime.
Okay, perfect.
And see you soon.
Yes.
For the result. Thank you.
Thank you very much. Thank you.
You need some water. From time to time.
давайте включвайте залата. Docent Nikov, Professor Nikov, do you hear us? We are ready to take a look at the result that you are going to show. We are together with Dr. Nikov here, Mitko, and I myself, Ivo. So, listening to you.
Can you hear me?
Yes, we hear you very well.
Okay. Do you see the angiograph?
Yes, we see a good SFA with even some branches.
This is before where you left. This is before DCB of the proximal part. So we used another one, 4x120 paclitaxel coated balloon for 3 minutes. Next one. And this is the final angio. As you can see, very good proximal part, the distal part. Next one. This is below the knee, all 3 vessels.
Impressive.
And the last one. And here we have the dorsalis peris. Oh, previous one. Yeah, the dorsalis peris and the posterior tibial artery. So in that case, I think this lady benefits from the DCBs. We will follow her up to see if that SFA and popliteal work. And maybe if we have a reocclusion, then we should implant the stent. But in this particular case, I think that leave nothing behind is okay.
I think
and the result is good.
Everybody is extremely happy with this result, so there is no space for any further optimization.
Yeah. So thank you.
Excellent.
Thank you.
Excellent.
So
I'm ready.
you can present now your experience with
Sorry about the
thermography.
Some changes in the program, but yeah, this is the problem of many conferences, and you know, we have parallel sessions in 2 rooms. So okay, I will speak about interesting concept. Let's say it's the application of thermography for different applications, but mainly for vascular disease. Regarding the peripheral vascular disease, we know very well that this is one of the biggest indicators for generalized atherosclerosis and a strong predictor of future myocardial infarction and stroke. We know very well that the patients with, the people with peripheral vascular disease die in 75% not from the gangrene or amputation, they die from stroke and MI. So it's very important to detect, to diagnose the peripheral vascular disease on time, because this is one of the biggest predictor of worst clinical outcomes in the future. And screening for peripheral artery disease is even in the guideline of the cardiology. So in our cardiology, European Society of Cardiology guideline, there is a screening for peripheral vascular disease. So we need a good method for to detect peripheral vascular disease. For example, one of the methods is ankle brachial index measurement. Unfortunately, especially in diabetic population, the huge calcification of the arteries is giving the results that are not true, so that are no reliable result of ankle brachial index. So in around 40% of the population, the result is not the right one. The classical screening is palpation. Do you think palpation is a good screening method? No, because even if a physician, for example, is a diabetic, his tactile sensation is not good, so he cannot do very good palpation. So, and more than obvious, we need better than palpation and better and readily than ankle brachial index, to be non-invasive, to be quick, to be reliable. What could be? It could be a very old idea. In the 60s of the last century, the thermography was proposed to be utilized in the medicine. Unfortunately, the technology was not that advanced. In fact, the idea is coming from Hippocrates. You see, almost 2,000 years ago, Hippocrates has left this message for us. Should one part of the body, temperature, be colder or hotter than the other part, disease is present in this part. So the idea to measure the temperature of the different part of the bodies is coming from Hippocrates. So since the 1940s, many things happened. The technology evolved. The artificial intelligence is among our society. So, and among the other applications in astronomy and technology, techniques, construction, the idea of application of thermography, for example, for breast cancer, is since several decades ago, even in the guideline, in the American guideline, is mentioned, the thermography is mentioned as a method of detection of breast cancer. Regarding the vascular pathology, there are several publications during the last 20 years regarding the possibility, the role of thermography for detection of vascular pathology before and after the intervention in diabetic population, because we know that diabetic population, at least 20% of the diabetics, they have vascular disease. And for diabetologists, it's very important what is the situation of peripheral vascular perfusion of the extremities. And this publication is showing that the concordance of ankle brachial index and thermography is quite good. So it's a comparison between ABI and thermography, showing not only where is a vascular problem, but also where it's possible to have infection problem, like shown in the picture. So in case on the baseline picture, we have a lack of perfusion, so low temperature, and all of a sudden a particular place is with high temperature. It's more than obvious, it's logic that is infection, temperature, on the place of lack of perfusion. So, and how we can use it nowadays, thanks to a very intelligent, I would say, artificial intelligence-based application, we can analyze the thermographic pictures in order to have more reliable data. So it's very simple. Just taking this small thermal camera that is in fact applied on the smartphone, we are taking a picture, and in a second, in fact, the artificial intelligence program is analyzing the data and giving us the result. The result, we have gathered more than 1,000 patients now with thermography screening for different kinds of pathology with very high sensitivity and specificity, reaching 90% in some of the territories. For example, this patient, what do you guess is? This patient is a Leriche syndrome patient. You see lack of perfusion on his lower legs. I'm going back in order to compare these blue extremities, lower legs blue. So blue, it means lower temperature, and it means lack of perfusion. And this patient had such a confirmation of our suspicion. So the suspicion of full lack of perfusion. And this is, for example, critical limb ischemia on the right foot before and after the intervention. So after endovascular recanalization and intervention, in just 1 minute, we have confirmation of the improved perfusion. It's a case report, a young patient with aortic dissection, type B, on with extreme compression of the true lumen, like shown on the right upper corner of the picture. the guy received the usual way of treatment. So this is our strategy to implant a stent graft plus prolongation with bare stent in order to centralize the flow into the true lumen, and on such a way to compress the false lumen, to isolate the false lumen, and to depressurize the false lumen in order to prevent growing of the false lumen. So everything nice, excellent. During the night, what happened? And we have closed the access, the vascular access. We have closed with a manta closure device. So very nice. But during the night, after the intervention, the guy complained of left leg pain and even full lack of sensation of the left leg. And during the night, there was no vascular surgeon or angiologist in the hospital, and the physician on duty took a thermographic picture. And on this thermographic picture, it was shown that. So the left leg is lacking perfusion. So what we have found? We have found closure, totally closure on the place of the manta. You see the marker, the metal marker of the manta, and 1 centimeter below the metal marker of the manta, we had complete closure on the level of the manta. It's possible that in fact, the manta plug was between the false and the true lumen, and with the manta and the plug there, it's possible to cross and to close the vessel. We crossed with coronary wire. We implanted a stent on the level of the occlusion, and it was recanalized with excellent result and fully restored flow. And this is the result. The thermographic result is showing absolutely symmetric restoration of the flow both on the left leg like in the right. So this is an extremely interesting case. You are going to realize that. So in this gentleman on the left panel, it's a stenosis of the internal carotid and subtotal stenosis of the external carotid. So the external carotid is supplying the face. And what we have here on the left side, we have very big asymmetry of the thermographic picture on the right side because of the external is almost totally occluded, and also some lack of perfusion on the level of the internal carotid territory. And this is before the intervention on the left side and after the intervention on the right side. You see that the symmetric picture is restored. Even more, there is some hyperperfusion on the right panel. There is some hyperperfusion on the level of the external carotid. You see the red color is some kind of hyperperfusion. So concluding, we need these new gadgets, new distal remote control of pressure, of heart rate, ECG, and also why not thermography? So the thermography is one of the methods that with the application of artificial intelligence would be probably in the future one of the handy tools in the daily practice to show vascular pathology presence or absence. And thank you very much for your attention. In case we have enough time in the afternoon, we are going to have one more lecture, how the guys did the artificial intelligence application. It's very interesting. Okay. Some questions or comments? Professor Bizdas is also involved. And yeah, take the microphone. Dr. Alvarez will share.
Yes, I think it's a very useful thermography because in our healthcare system, for example, when a patient consults us about rest pain, cardiologists indicate an echo, but the reimbursement of the echo is 10 days after or 1 month after. Then it's too practical. I don't know if necessary artificial intelligence, because it's so interactive, the images.
Absolutely.
I became so impressive, and I hope to do a good trial with you, a B-center trial for the next year.
The system is only for the iPhone, or can be used with another?
Nowadays is this particular camera. It's a very small FLIR 2 camera. This is the model FLIR 2 camera. It's in fact compatible with iPhone. But in the future, the guys that created the application, will probably make an interconnector between the FLIR camera and also Samsung or other Microsoft phones.
Yes, because in Argentina, probably in Bulgaria too, it's easy to have another system than
another
iPhone.
smartphone, not iPhone. Yeah, okay. Yeah, we have this in mind.
And what do you think about carotid lesion? These thermography images could give the information of the is a significant lesion or not in terms of hemodynamic?
Yes, we have gathered several patients with even stroke, and even in stroke, there are promising results. There are very promising results of acute lack of perfusion, because in this situation there is a huge difference between perfused and non-perfused, and it's very, very clear.
And what about the utility in venous intervention, for example, in DVT?
We didn't check, but we saw several patients with, for example, varicose veins, and they are like a picture from a painter. It's impressive. I can guess in the afternoon, Georgi will show this data, the guy from Kelvin Health. He will come probably at around 3 p.m. for the symposium.
Probably in carotids, the problem is that in the great majority of the cases, the problem is not flow restriction, no obstruction of the flow, it's distal embolization or local thrombosis, and then this will be a limitation for thermography.
We'll need probably better resolution in the future, and I can guess with both technology and artificial intelligence, this resolution will improve, and we can show even small vessels. Hopefully. Yeah, this is the idea. Okay, thank you.
So we have one presentation left from the previous session. Dr. Martinov will present transcollateral recanalization of peripheral vascular pathology.
Dear colleagues, I try to show you some bizarre way of procedure. This is our center. We are at least 9 days to 10 years experience with more than 2,000 procedures, leg procedures. About the problem for chronic liquid ischemia is growing in the world with increasing the age, with diabetes, and this is one of the negligible problems in Bulgaria, maybe in the world, but it's a very serious condition. Something about the prognosis. This condition is linked with invalidization and high mortality. Especially CLTI, you see the symptoms and very poor prognosis. That's why this is the situation with no revascularization and the situation with revascularization. You see the difference, almost twice bigger healing and at the end and saving lives. That's why we should open the everything with every method we know. And to open the arteries to the problematic zone with ulcers, with critic ischemia. That's why this is one additional way to recognize unrecognizable in antegrade approach arteries through collaterals. This is the some of main points. Antegrade access is a preferable access for transcollateral recognition, at least for the length of the devices, because in contralateral approach, sometimes they are very short in some situations. You should have big experience, including coronary experience with coronary CTOs for cardiologists, but and unsuccessful antegrade and retrograde attempt, one feeding vessel when it's risky for retrograde puncture, and some obstacles on the site of retrograde puncture, potential retrograde puncture, like ulcers, bandages, and everything. In our center we have a lot of patients with only with bandages on the site of puncture, potential site of puncture. And here are the examples. The patient with disease but not so diseased femoral artery. Everything is below the knee with critical limb ischemia. Patent from the beginning to the end only peroneal artery with some disease, and occluded two arteries which are leading to the plantar loop. Only one big collateral from peroneal to posterior tibial artery. Here is the picture. Here's the picture. I don't see anything. This collateral, which is normal connection with the peroneal and posterior artery. In case of critical limb ischemia, it's mandatory to open one of the anterior or posterior arteries, and there was a. This is our protocol. We are using all 18 wires and all 18 catheters for antegrade approach, and for retrograde we are using, common for our center, coronary all 14 wires and catheters. This is carnelia here. Okay, these are the sites of communication. This is in our case, and for opening one of the arteries, we are using plantar loop. It's a rare situation. For the techniques, we are using this technique for marking the artery, because we have a big segment of artery which are not visible. No calcium, nothing, and a lot of collaterals. That's why we are using as a roadmap retrograde wire, and here we have clear target where to go with anterior with antegrade wire. This is the final connection with these two lumens. This is the one way. This is the unsuccessful. You see here unsuccessful penetration of distal lumen. We are using one collateral from above. We are connecting vessels. We are connecting two lumens. It's subintimal tracking. In rare cases, you can perform classical card technique to open to connect the two lumens, proximal and distal, and you see the successful penetration and down to the loop. And this is anti-grade. This is third case, and this is anti-grade attempt unsuccessful. You see the wire is out, but again through the connection branch we are up with the 014 wire, and this is rendezvous technique. When we are connecting, we are targeting the anti-grade catheter with the retro wire. This is the very good example where they are pointing in the same site, and then after maybe a lot of attempts, we are in the catheter, and then the system is to pull from below and to push above, and then whole system goes down, and it was relatively easy to pass in the distal part of the popliteal artery. You see the wire here. There's balloons. Final result, you see the posterior artery and the loop with very good visualization. Here's the comparison before and after. A lot of peripheral small vessels. We have in our center modality to visualize the before and after. This is in our machine diffusion software, which is like in previous lecture, electronic way to visualize the improvement of blood flow. And these are the take-home messages. Thank you for your attention. And if you have questions.
Thank you, Dr. Martinov. Impressive cases. Any comments or questions? Do you have to use a bigger sheet in case you are doing this?
Yeah, it's good to have bigger because you have two devices in one sheet. Sometimes you understand in the worst way. When you are in the procedure, you don't have some space in the sheet. That's why when you are in this situation, you should be at least 6 French sheet to have enough space for devices, because sometimes you can. That's why with this technique, rendezvous technique, we postpone some externalization of the wires. We are putting the wire in the microcatheter and all the system goes down, and then we are proceeding with the normal way of doing the procedure. Okay. We are not externalizing wires.
Thank you.
Thank you.
So it's better to proceed with the next session.
Frank, Dr. Criado. Come on. No, no. You will bother it. No, no. Please. Are you sure that we are to come? That we are? Yeah. I want a very cold water. We want dim lights.
Yeah, I can forward it to you.
Should we start? Can I have my slides, please? It's a great honor to be here in front of you. Thank you.
Let me say something. Dr. Petrov is in the cath lab preparing the patient for the live demonstration. Then Frank and me and Jack will try to moderate this session.
I think we can do it.
Maybe.
Просим сохранять спокойствие. Achtung, Feueralarm. Bitte verlassen Sie unverzüglich das Gebäude. Benutzen Sie dazu die Notausgänge. Bitte folgen Sie den Instruktionen des Personals. Bitte versuchen Sie, Ruhe zu bewahren.
This is probably the second.
Внимание, пожар. Моля незабавно да напуснете сградата, като използвате маркираните изходи. Изпълнявайте инструкциите на персонала. Моля, запазете спокойствие. Attention, incendie. Nous vous prions d'évacuer immédiatement le bâtiment en utilisant les sorties marquées. Suivez les instructions du personnel. Gardez votre sang-froid. Attention, fire alarm. Please use marked exits to leave the building immediately. Follow the instructions of the authorized personnel. Please remain calm. Внимание, пожар. Просим вас покинуть здание, используя обозначенные пожарные выходы. Выполняйте инструкции персонала. Просим сохранять спокойствие. Achtung, Feueralarm. Bitte verlassen Sie unverzüglich das Gebäude. Benutzen Sie dazu den Notausgänge. Bitte folgen Sie den Instruktionen des Personals. Bitte versuchen Sie, Ruhe zu bewahren.
What we do?
Is it real?
Внимание, пожар. Моля незабавно да напуснете сградата, като използвате маркираните изходи. Изпълнявайте инструкциите на персонала. Моля, запазете спокойствие. Attention, incendie. Nous vous prions d'évacuer immédiatement le bâtiment en utilisant les sorties marquées. Suivez les instructions du personnel. Gardez votre sang-froid. Attention, fire alarm. Please use marked exits to leave the building immediately. Follow the instructions of the authorized personnel. Please remain calm. Внимание, пожар. Просим вас покинуть здание, используя обозначенные пожарные выходы. Выполняйте инструкции персонала. Просим сохранять спокойствие.
Success, the same situation, but I was sleeping, and I run through this escalator.
It's just a mistake of the technology. It's a mistake of the technology, so go on.
Sorry about interrupting, but somebody spoke in a room. Yeah, I'm a smoker. Maybe one of you. So you stay, I go. Jack, were you smoking? No. No? Sure?
Sure. I need the smoke to come down now. Okay. Should we go?
Okay. We wait for Ivo. No, Ivo will go to the task lab. But tell us what to do.
Everything is fine. I will bring back the rest of the...
Don't smoke in the room, please. You will talk about modify stem graph?
Yes.
Okay.
Can we have the presentation, physician-modified stand graft on the screen, please?
Can you reset the minuter?
Yeah.
Can you reset the clock? The clock.
The clock and
we will give you. Okay, it's okay
But
now. And this
is not my
The presentation is not this.
This is the presentation. Physician modified stand grafts.
Don't start the clock. It's not beginning.
Okay. The purpose of this presentation is to present our initial experience with physician-modified stand grafts in endovascular treatment of complex abdominal aortic aneurysms. What is complex AAA? These are aneurysms that involve the renal or mesenteric arteries and extend up to the level of the celiac axis or diaphragmatic hiatus. Here included are the short neck infrarenal, juxtarenal aneurysm, pararenal, which go to the level of the SMA, paravisceral, when the aneurysm is extended to the celiac trunk, and the extended thoracoabdominal aortic aneurysm as well. The treatment options in these cases are, as always, open or endovascular, and as recommended in the guidelines, the decision should be based on the patient overall condition, the specific anatomy, the availability of the grafts, the team experience, and also the patient preference. Open repair is a good option with high risk in the post-operative period for mortality and morbidity, but it's most of the times a better option for young and fit patients. If we're talking of endovascular repair in these patients, the preferred strategy should be with the fenestrated grafts, which are recommended. They have less invasiveness compared to surgery, reduced morbidity, morbidity and mortality, but they have high cost and need some time for manufacturing. Parallel grafts are a viable alternative if fenestrated grafts are not accessible. They are good for emergent situations, and there are some concerns about the gutters and the end leaks. So this is one of our cases with juxtarenal aneurysm with 1 year follow-up, treated with double chimney EVAR with very good result, decrease of the aneurysm and no endoleaks. Another similar case with Crawford 5 thoracoabdominal, in which we had to do something, and we used sandwich technique for preserving the superior mesenteric artery. There were some gutters and endoleaks initially, but after several months, the patient is okay. What to do in cases that patient is high risk for open repair, we don't have access to fever like it is in Bulgaria up to now, and the patient is unsuitable for CHIVAR. So maybe to create fenestrated graft. This is what we did several times in last year. We need back table, as you see, ophthalmic electrocautery, and some carriage. This is a case of 73-year-old male with 68 mm symptomatic pararenal abdominal aortic aneurysm with end-stage renal disease, but still with a liter for 24 hours diuresis. Operated in the past for peritonitis. Not a good candidate for surgery. You can see that the aneurysm is extended to the level of the superior mesenteric artery. So we decided to perform fenestrated graft with 2 fenestrations for superior mesenteric artery and one of the renal arteries, which was bigger. The other one was too small, and the kidney was a lot very small and sclerotic. So we unsheath the graft, do fenestrations with the cautery, and after that suture a wire around the hole, and a wire which is O14 radio pack part of the wire, and after that it is important also to do some reduction of the diameter of the release graft, which is which can be done with reducing wire in a specific technique well described in the literature. So the last step is to resheath the wire, the graft in the delivery sheet, and it's ready for implantation. What we did in this specific case, as we don't have fusion and so on, we used 2 wires from below, from the left groin, to cannulate the left renal and the superior mesenteric artery, and in this way to orient the partially released graft towards the orifices of the target arteries. After that, this is the cannulation of the left renal, also the 2 protected stent grafts I cover in the target vessels, and this is some intraoperative, not very good pictures, but this is, I don't know why this is, okay. The final result is good with patent grafts and good isolation of the aneurysm. The other case is of a 74-year-old male with 55 millimeters juxtarenal aneurysm. The right kidney is sclerotic, and there is only 1 renal artery, big, about 7.5 millimeters, left renal artery. We had to, in order to achieve good sealing, to go to the level of the superior mesenteric artery. We did 1 fenestration, and yeah, again, we have a wire to better align the fenestration, which is well visible in this case. The endurant graft is released to the level of the contralateral limb. After that, we cannulate the limb and the fenestration and the kidney. As you can see, put a sheet with the help of a balloon, and you can see a little pop of the graft. This is the releasing of the reducing wire. Now the graft is almost fully opened, also the bridging stent, and this is the final result. With this initial experience with 2 cases, one Sunday evening, I received a call from a colleague from Heart and Brain Hospital in Pleven, who asked for advice and help with the contained rupture of a patient with pararenal aneurysm. You can see there that the healthy zone of the aorta is above the level of the superior mesenteric artery. So we did some measurements by ourselves and take the risk to operate this patient. It is also a quite kinked aorta. We did 3 fenestration, one big one for the superior mesenteric artery, which we planned not to stent, and 2 small fenestration for the renal arteries, which were covered with B grafts. And this is the final result. The patient is okay, and this is the CT scan at 2 months postoperatively. In conclusion, endovascular treatment with fenestrated graft is preferred in complex AAAs. Physician-modified stent graft is a viable option when custom-made devices are not available because of emergency or because of financial issues, and in case parallel grafts are also not suitable. The technique makes it possible to expand the application to available normal grafts and to adapt it to a specific patient's anatomy. Thank you for your attention.
Any questions or comments from the audience, from the panelists?
Yeah, the last case that you showed,
yes.
You elected not to stent the SMA. Why was that?
Well, we could stent it. There was small dissection in the SMA itself. The artery had a very, very big hole, orifice. And probably if we had put a stent, we should use about 12 millimeters and proceed with stenting of the dissection distally. We see no reason to stent it because the diseased part of the artery is on the back side and this is on the front side. Like in the home-end fenestration made for the arch, for dissections, I think in this case, there was a good sealing on the front side of the aorta, and with the 2 stent grafts for the renals, this served more or less like scallop, but
Sir, did you see any difference between the several commercially available stent grafts? What was your decision in the selection for the stent graft that you put in the renal and so on? Is there any difference between the stent graft?
You mean the bridging stents?
Yeah.
Yeah, if we look at the literature, there are differences. Big Graft Plus is preferred for fenestrations, as I remember. But in our case, it was a question of availability. So we used.
It's not a question of price, I guess.
Yes, it is also a question of price.
Ah, tell us more. You don't want to speak of price?
Sorry?
You don't want to speak of price? No, you don't want.
The next presentation is pre-recorded. It will be about the non-A, non-B aortic dissection, options for endovascular and hybrid repair. The presenter is Dr. Ana Maria Botero, and we will have the record conference. This one.
Yes, I think we skip this one and we will perform with this one, but other time slot.
This one now?
No, it's other time slot. Skip this one and the next speaker, because we don't have this one.
The next speaker will be this one, but this Ivo Petrov is there at the Cal Lab. You are in communication with Ivo Petrov? Dr. Alvarez, you have a question? Where is Dr. Petrov?
Yes, this is a question for Frank related to the last presentation. In juxtarenal aneurysm, in your daily practice, what do you prefer to do? Fenestrated or a T-branch, for example?
Well, I mean, I think each case is different, you know. That's an easy thing to say, but it's true. Each anatomy is different, and our team, you know, uses a combination of solutions depending on the patient. We started with Chi-bar and standard E-bar, I must say, a few years ago. But it seems like those complex anatomies, you have to do more than just standard E-bar. So Chi-bar, I think fenestrated is probably the superior solution in the majority of cases, because that's where you really can achieve durability by landing on a more or less normal aorta above the renal arteries, between the renals and the SMA, occasionally even higher than that. So fenestrated, I think, is the way to go in most complex cases.
Any news about Dr. Petrov?
I think we should start directly with the live case. We should start directly with the live case. No good.
Excuse me. The
¿Cuál? Esta. Bueno, pero dice que sí. It seems that we're going to skip a couple of things on the program and go to the next presentation as soon as he gives me the green light to proceed with a remote presentation from the US.
Urania?
Yeah, but I'm not ready yet.
She's online. She's live. So we can stop. It's better to let her present. Because she's waiting. As usual.
I'm still holding my breath. So it seems that we are ready for Dr. Provenza. Dr. Provenza, hello. I can see you. Are you ready?
Yes. Good
Oh,
morning.
we can hear you
Good
perfectly.
afternoon.
So, Dr. Urania Provenza, a noted cardiothoracic and endovascular surgeon from the United States. is going to present on open and endovascular solutions for aortic arch repair, current landscape. Go ahead, please.
Thank you. First of all, I would like to thank Ivo for this kind invitation, as well as to salute my esteemed moderator, Dr. Palma Shaw, who is the new president of the International Society of Endovascular Specialists, as well as my other co-moderators, Victor Costance, Jacques Pisquet, and Frank Riado. So the talk is about the open and endo solutions for aortic arch repair, the current landscape. This is my disclosures. A few things regarding ECMO Arch Society. We do have ECMO 9 ECMO chapters across ECMO 5 continents, and we're very, very pleased to support various meetings. Can you see my screen, please? Yes. And we're very glad to support.
Can you go ahead with your presentation, your slides? Okay.
Yes.
Okay, now it's okay.
Yes. So everything that we're going to talk about is off a multi-label, and we're going to discuss and there's not currently any FDA arch endograft in the United States. So the question is, why do we care? We care because the endovascular technology offers minimally invasive alternatives to the aortic pathologies, and is especially important for patients unfit for an open ECMO repair when there is multiple redos or elderly patients or very frail patients. And this is a different ECMO pathologist, and how we can do various ECMO open repairs by changing ECMO 1 head vessels or reimplanting and repairing ECMO all the 4 ECMO head vessels, or just ECMO part of this, or and we can do it by a complete arch repair with the elephant trunk, or without what we call the elephant trunk. Now, when we talk about the open arch repair by itself, it actually underwent evolution, and we can see here what we mean by that is that early on we used to do femoral aortic cannulation, but axillary cannulation and nominate is how, or directive and aortic is how we proceed with open arch repair to establish arterial inflow. Regarding the brain protection, we used to have profound hypothermia, retrograde cerebral perfusion, but nowadays we use moderate hypothermia, usually between 24 to 26 or 28 degrees Celsius, and we provide bilateral antegrade cerebral perfusion. And with regards to the technique, we used to do the island technique, we still do it, but we try to use what we call the Y graft by placing the anastomosis a little more proximal to help us with the repair. With regards to the cannulation strategies, here is the anominate or the axillary cannulation, and we have actually talked about this a few years ago when we described our techniques, how we provide arterial inflow during the aortic arch operation. So the repair can be extended into the hemiarch with the brief periods of hypothermic circulatory arrest, when the repair extends to include the lesser curvature of the aortic arch. And this is just a schematic representation at how we do it by providing antegrade cerebral perfusion, temperature down to 24 degrees. And then we place a second cannula to provide bilateral into the left common carotid to provide a bilateral antegrade cerebral perfusion. In case that we have, in case that the entire aortic arch is involved, then we proceed with a total arch aortic replacement. Again, with regards to the technique can be island ECMO technique, where all the head vessels are implanted as islands, or two of the head vessels, the left common carotid and the anominate, and then we have already done subclavian and carotid bypass before. Or we proceed with what we call the Y graft as a double Y graft or as a trifurcated graft, depends how many head vessels we're going to replace. Now, the endo repairs, hybrid or endo, is very important to, I think I want to give credit to the person that did this many years ago when things were not available to us, and that was Nikolai Volodos. Did the first hybrid procedure in a 41-year-old female with a pseudoaneurysm anastomotic from a prior correctation repair. That was actually published in 1991. At the time, Dr. Volodos, he used a two-part delivery system with two fixating elements at its end to deliver the device. Dr. Volodos did, I had actually the honor to meet him during Dr. Dietrich's symposium in 2013, and he did actually present his long-term follow-up at a time that was 21 years and 8 months. And it was a great tribute to Dr. Volodos by Dr. Dietrich and Ivantsev at the Journal of Endovascular Therapy at the time. Now, another a few years after Nikolai Volodos' presentation in 1991, we had in circulation another article from Inouye and colleagues where he evaluated the technical feasibility of the endovascular branch stent grafts in 15 patients. Now, regarding the current landscape, the current landscape is actually a changing landscape where we have multiple hybrid procedures. We have alternative approaches using different grafts, fenestrated, as well as fenestrated branch endografts. This is various configuration where we use the hybrid techniques. And these exanatomic bypasses is when we use off-the-shelf devices in high-risk patients when the branch and the fenestrated grafts are not available. And as I mentioned, are not available in the United States as FDA-approved devices yet. This is early on, quite a few years when I was in Houston, where we had 29 patients. We look at the hybrid techniques in zone 0 in high-risk patients. We had 6.9% mortality, major stroke 3.5, 6.9 spinal cord ischemia. That was a patient, actually, that was a fascinating case, a patient that had the methylcrelate plate, which from a sternal reconstruction, and that plate was impeding the anominate artery and caused this pseudoaneurysm, as you can see here. And in this case, what we did as an inflow, we used the descending thoracic aorta to create a bypass into the subclavian artery. Then we did carotid bypass, and then we placed an endograft across the arch, and that was the CT follow-up on that particular patient. This is another procedure with, again, subclavian carotid bypass, and then again carotid, and followed by the stent graft, and then a second stent graft due to proximal endo leak. That was we try to see what are really. It's very difficult to really compare open repair with an endo repair or a hybrid, because these two patients populations are most of the time quite different. So quite a few years ago, we tried to compare them by using the propensity match score. And what we found though was that we didn't really find significant difference between the open or the endo or the hybrid repairs in our patient population. Again, when we did the propensity match score. But I do think that the reason that we didn't maybe find the differences because of the limited, even though it was like a large number of patients, still were not a very, very large number. You can see that the total neurologic event for the hybrid group was actually higher. As you can see, traditional was 8% versus the hybrid 17%. That was I had the honor to be a guest editor for 2 consecutive issues from the Annals of Cardiothoracic Surgery, where we talk about anal where thoracic endovascular solutions, part 1 and part 2, and we can see here from the Methodist group, where they talked about the parallel grafts and the how we can proceed with the arch repair. Now, the advantage of using these grafts that we call them chimney, periscope, or sandwich is because we use existing technology that we are familiar with, especially from the thoracoabdominal literature. This is what is approved currently in the United States. This is a single branch endograft. This is the Gore branch TBE graft that can be used in various configurations for zone 0, 1, and 2. This is, again, one of our patients that had a symptomatic type 3B aortic dissection in May 2022. Then post-op, he had, during the follow-up, some proximal endoleak. And this is where the TB graft, the branch endograft, was actually very handy to us and very useful at the time. And we place the branch TB graft, the proximal, and to solve the endoleak. This is another patient that had prior open repair, also prior TVAR. He had this arch aneurysm. And then on this one, we did exanatomic bypass, plus we added also the ascending graft because we've been at the time part of a trial. This is some other branch endografts that are available in 2023, but again, as part of trials or in other places, but they're not FDA approved. This is the Nexus endograft, the Castor branch endograft. The relay, again, the relay and the Nexus are part are in trials in the United States. And then in other parts of the world, we have the Cook branch endograft and the Inui and the Castor. So this is the US feasibility trial using the branch endograft, and that was for zone 2. That they had 22 patients, great results, no mortality, no stroke. Again, the important thing here, as you can see from the authors of the manuscript, these cases were done again for zone 2 and were done in excellent centers. This is from Germany, from Chilibaris and colleagues. A few years ago in Journal of Vascular Surgery was presented where he had a branch endograft as well as fenestrated grafts for the total arch. And we can see actually here the fluoroscopy time for the branch endograft is actually more, as well as the procedure time. So the fenestrated were actually much, much faster. This is another one of that focus issues where this is from the University of Toronto group where they talk about the Nexus endograft. I think at the time they had the largest experience. Again, in the United States, currently they're under trial, where the Nexus is actually a modular ECMO device with the main module to cover the arch and the proximal descending aorta, and then the proximal module to deploy into the ascending ECMO aorta. And then the two modules are connected via interlocking latch ECMO mechanism. And this is an interesting ECMO category where the patient had a prior type 1 aortic ECMO dissection. Now the arch is dilated, and these people potentially can be a category to use the branch of the endovascular repair to fix the arch. As a conclusion, the placement of the aortic arch, so there's no question that has undergone significant ECMO change and is undergoing actually current ECMO changes, both in the open ECMO arena, but as well as in the endovascular ECMO arena. We're changing the protection ECMO strategies, the temperature management ECMO as well. The emerging technology, endovascular technology is offering new treatment ECMO options. We have various devices coming down ECMO the pipeline. I do strongly believe that knowing the open options as well as the end options is extremely important to offer the patient ECMO a very specific ECMO approach. Thank you for this opportunity, and Ivo, thank you, and hopefully next year we'll be there in person. Thank you.
Thank you, Dr. Urania. Have you something to say, Jacques?
Rania, your talk was excellent as always, and I'm very glad to see you online. I couldn't be with you in Houston because I was in China with Dr. Shang, but I think very deep to you, and I like very much our society, International Society of Endovascular Specialists, from which you are the president. Thank you, Rania.
Yeah, thank you. Thank you for the opportunity. And also thank Frank was there. He gave an absolutely outstanding talk during the luncheon. And we miss you. We miss Donald Reed, Victor Costanze, and the others. But again, I'm very glad to have Palma. As you know, Palma So is going to be the new president of the International Society. And I know that he's going to have an outstanding presidency over the next 10 years. 2 years.
Well, thank you very much, Urania. We appreciate your talk. So we'll move on with the program. Have a good day.
Thank you.
Now we will have a pre-recorded conference. Dr. Ana Maria Botero will speak about spinal cord protection for complex endovascular aortic repair, why and how.
Hi, how are you? My name is Ana Maria Botero. I'm going to talk to you about spinal cord protection for complex endovascular aortic repair. I want to thank everyone for letting me be here, even if I cannot do it physically. I have no disclosures for this talk. Spinal cord injury during endovascular repair is a very troublesome complication. Its incidence is from 5 to 30% for Crawford to thoracic abdominal aneurysm, and it has decreased to 6.3%, maybe and mostly because of endovascular repair. We think, or we know about this in open surgery because of cross-clamp time and the reimplantation of the arteries on open surgery. So we've been diminishing that percentage. Nowadays, in endovascular TEVAR, there's an incidence of 1 to 10%, and in EVAR is less than 0.25%. So it's been going down through new techniques and advances in vascular surgery. Spinal cord ischemia can be developed for many mechanisms. One of the most important is coverage or exclusion of the intercostal arteries because of the thoracic prosthesis. We thought initially that this was the major event that happened, but nowadays we know that you have to cover at least 2 major territories for that to be truth, because there are many additional pathways for the medulla to be irrigated, okay? So there has to be a limitation in the outflow as well with increased venous pressure. Also, there was theory that embolization was not a major thing, but nowadays we know that catheter embolization and manipulation of the aorta is a big mechanism of ischemia. Also, hypotension during surgery, because it causes an environment in which those cells can no longer function. Previous procedures where we disconnect those pathways that are not the common ones are also reasons why we become ischemic. This is an article published in 2014 that talks about temporary sac perfusion. It is actually the non-completion of the Bridges stent when you do BVAR. It causes an incomplete sac thrombosis, and that in that way you get to perfuse the spinal cord from the lumbar and intercostals. Mainly, you leave a celiac axis open, but you can also do it by accessory renal artery, an inferior mesenteric that is not diseased, or if you have a bifurcated graft, you can do it leaving the iliac contralateral limb open. Contraindications, yes, you have. Dissection of the superior mesenteric artery, patient with nephrectomy, or GFR less than 30. Completion has to be done within 4 weeks to make sure that there's no risk of rupture, which is 3%, and that you can do this as soon as possible. And here you can see that it is feasible. It causes a reduction in spinal cord ischemia when you do BVAR, but you have to do other measures. The early recovery is faster, so if you have a risk of rupture, keep it short. And if the patient doesn't develop symptoms of spinal cord ischemia, then you could do a balloon occlusion, and then if nothing else happens, you can complete your procedure. The percentage of paraplegia at 30 days of discharge has a significant reduction with this measure. So staging is one of the best known strategies to lower a spinal cord injury. And the main thing is that it works with collateral network, especially in patients that have a Crawford 2 extension. The main thing is that you need to consider having that stage done between 6 and 12 weeks, because if not, there's an increased risk of rupture. The reduction in spinal cord injury, it's from 37 to 11%, and there's also a reduction in mortality. In the upper part of your screen or your slide, you can see the percentage, the exponential curve for the predicted risk of spinal cord ischemia with the coverage that you do of the thoracic aorta. And on the right side of your slide, what you're going to see is doing it in a single stage, an unintentional stage, and in 2 stages, the percentage of survival. And it is way different when you stage a procedure, and as you can see in those Kaplan-Meier curves. So the other strategy is to keep the patient hypertensive with high hemoglobin. Discontinue the calcium channel blockers in angiotensin inhibitors for 4 to 6 weeks to keep a systolic blood pressure about 160 millimeters of mercury. Also keep your medium arterial pressure more than 80 for 72 hours. And if you have any neurological changes, get it up until 100 millimeters of mercury. CSF or cerebrospinal fluid drainage is kind of the well-known maneuver or strategy of all time. The protocols on how people use it may vary, and you can use it as a prophylactic strategy, a therapeutic one, with emergent drains. It is very important that the technique remains clear and that the decision of doing it's taken by a group of aorta with a physician that it's capable and that can replicate the way they do this. It also is very important for them to be able to do this not only for elective cases, but for patients who develop these signs and symptoms of spinal cord ischemia, so you can do rescue maneuvers. As I told you before, there are many protocols. The main thing that you have to do is teach not only you or your team, but nursing and ICU staff on how to work with this and how to make it the clean without any risk, because this is not a procedure that it's free of complications. So we had a time where we did this in every patient that had a extension on the thoracic aorta. And nowadays, I think we think about which is the best patient to get in this kind of treatment. There's not only a prophylactic, so when you use a rescue CSF drainage maneuver, you have to be monitoring the patient, and that's how you know that something's not okay. So when you use somatosensory or motor evoke potentials, you need to start draining, increasing the mean arterial pressure to restore the flow. If there are persistent changes, which is a drop on 75% of the amplitude of the recording, then there's something going on with the medulla. If you're using NERS, a decrease in 20% of the recording gets you to make a decision. So you need to do even temporary arterial sac perfusion or iliofemoral conduit, or withdraw the large sheets that occlude the femoral and the hypogastric circulation to make sure that you have collateral circulation through the medulla. This is another strategy that is minimally invasive segmental artery coil embolization. It could be done percutaneous. You could avoid staging with these, and it can relies in the resilience of the spine when you do aortic repair. It's like preconditioning the spine to gain more flow. As I told you before, it could be with local anesthesia, and you embolize the atom cubics in its ostial part to be able to have collateral circulation. And how do you do that? With a 2.7 French microcatheter and with 0.018 coils. 4 to 8 weeks later, you could do your extensive TAA repair with less of a possibility of having symptoms, neurological symptoms. This is another one that's revascularization. We learned this from cardiovascular surgery, open surgery. So when you could do it endovascularly, or you can do an extra anatomic bypass. It happens in patients with fever and BEVAR. This is a retrospective study that it's new. It's been presented last week on Hawaii. 9 patients with endovascular management with 11 arteries, with a directional cuff sewn to a physician's modified stent, and they do the completed connection with Bioban stents or bare stents. 3 of them got extra anatomic bypass with a 83% above all of technical success. 9 patients needed prophylactic spinal drain, and no mortality in the 30 days post-surgical intervention. So to wrap this up, this is a catastrophic complications. You need to have an aortic team to be able to deal with this. Not only surgeons, but anesthesiology and your whole team. This complication is time dependent. You need to fix it fast. So you need to tell that to your trainees and use protocols in practice. You have to have a diagnostic tool to make sure that you see that, to avoid it at all costs, so you know what to do. I hope this is something that works for you nowadays. So this is it, and I wanted to thank you for listening to me in this presentation, and I hope to see you soon.
Okay, this is a pre-record conference, then we cannot do questions to her. Now we will begin with the live case. You will present, Doctora?
Dear colleagues, I will present you the next live case. It will be performed by our highly skilled invasive cardiologist, Professor Ivo Petrov and Docent Zoran Stankov. It will be about thoracic aortic aneurysm repair. The history of the patient, he is a 72-year-old man, and he complains of progressive hoarseness since 4 months ago. At the time of occurrence, he felt chest pain and shortness of breath, but they disappeared spontaneously. He has also a well-known 2-vessel coronary heart disease, like it's written there, but they are not intervened. Okay. By not intervened yet. Review systems of the patients are negative. He has a past medical history related to arterial hypertension, benign prostatic hyperplasia, COPD, and dyslipidemia. No allergies. He's taking a few medications, one of them clopidogrel. He was never a smoker, and he doesn't have any family history. From the physical exam, everything is within the normal limits. The vital signs, the hand, chest, heart, extremities, everything looks completely normal, except a light exacerbation of his COPD. From the diagnostic workup, ACG looks normal in sinus rhythm, repolarization changes are within the normal limits. From echography, everything looks fine. Ejection fraction is preserved, 65%. Systolic and diastolic function normal, and no leaky valves. CBC within the normal limits. We proceed with a X-ray of the patient, and we were able to find mediastinal widening. After that, we proceed with CT aortogram with the dye contrast. We were able to find out 2 saxiform aneurysmal dilations of the aorta. First is in the aortic arch, and the second one is just at the beginning of the descending aorta with the written sizes 58/51 millimeters and 60/54 millimeters. They're separate but following each other, and they're placed on the inferior wall of the aorta. Our plan of treatment is to be totally endovascular with 3 different access points. The first one will be right brachial for brachiocephalic trunk to do a chimney technique. The second one it will be retrograde for left carotid, common artery to place a chimney technique also, and the third one will be femoral for Valiant stent graft implantation. The pre-ordered planned endovascular devices are B-graft, 3 different sizes, is shown in the bottom of the picture. The second one will be Valiant Captivia, and 2 closure devices, Manta 18 French and ProGlide. So from now, we continue live.
Thank you. Yes. Okay.
Apologies for the interruption. Kindly ask everybody to check his back, because there has been a swap of bags like this, and we're looking for the keys of one of the audiences. So please check your bags, and if you find things that are keys that are not yours, give it to me. The question is, where's the money?
Hello, Ivo.
Hello. Yeah.
We are seeing you. We're hearing you. You can.
Yes. We have some job to do here. I will explain.
If you want, well, let the change the position. I'm going to put the stand. You can explain to the auditorium.
It's quite difficult going there.
Yes. It's normal with the big raft.
Put on place. Are they 8 millimeters? It's probably better to put a 7 French.
8.
8.
Yes. Also French, 4 respect.
It's better.
Yes.
Just a second. Very slowly.
Yes.
Very
Сашо,
slowly.
моля те следи ми стента. Super.
Slowly.
Will you change the introducer, Ivo?
Yes. Yes. Exactly. We have discussed. This is one of the chimneys. In fact, of what Dr. Kuzov has read, has presented, there is a small change. I will explain. We have heard the presentation, a very good presentation of Rania.
Yes, I see.
It's probably better to remove together the big raft together with the sheets, and after it outside of the body of the patient.
Yes.
So on place the wire. Let's see the proximal aorta.
The wire is there.
Excellent. Yeah, I will remove it. Yeah.
Okay.
Give it to me. Just place, keep on side the wire.
Okay.
Ready. Remove it. Yeah.
Yes.
If the camera can show, I will explain. It's not very simple. I will explain in a second. You probably see 4 wires and 4 sheets there. By the way, Rania Prevenza just have presented a very, very good the technique about the aortic arch. Of course, branched devices is probably good option, even better option, but we don't have such a expensive tools. And by the way, the experience worldwide with chimneys is quite extensive, and also ours. We have 64 at abdominal level.
73.
73. Dr. Stankov is correcting me.
Pick it up.
Okay, so hello everybody. Please, camera here. Camera here. Here. Okay. Hello everybody. My team, Professor Stankov, Petya, our chief nurse. Petya, come here, say hello. Alexander, the technician. Rossi. Okay, this is my team today. Very experienced team. And okay, let's expand the city. Let's expand the city, and you are going to see 2 aneurysms, quite big, very eccentric. We know from the trials that the eccentric aneurysms are more prone to rupture. And the patient had hoarseness of his voice as one of the main complaints. And you know, the surgery of the aortic arch is quite a complex surgery, very big morbidity and mortality. And what we have decided, in fact, what is different from the explained by Dr. Kuzov, Alex told you that the initial plan was to retrogradely puncture the left carotid and to puncture the axillary artery for the brachiocephalic in order to position two parallel big grafts, chimneys. And in fact, what we have changed, we have changed is that we decided also to chimney the left subclavian artery. Why? Because the vertebral artery is very, very small, and in case we cover the subclavian artery, we can have ischemia of the brain, and also we can have a problem with supplying the left arm. And because of that, we decided to make three chimneys and to put the aortic stent graft. In fact, this is also changing the size of the aortic graft. Why? Because the more chimneys we position, the more oversizing of the graft we have to calculate. What is the rule? The rule, the half of the sum of the diameters of the chimneys has to be the oversizing of the stent graft. We are going to implant a Valiant Captivia. In fact, we are going to implant the biggest, the 46 millimeter Valiant. But before that, we are going to implant to expand the chimneys, the three Bentley grafts, and parallel to them, we are going to implant the Valiant Captivia. Some questions or comments?
Then, Ivo, can you summarize how do you prepare the patient? One introducer in the subclavia, please.
Exactly. I will show you now. Let's switch to the angio. Okay, this is right femoral approach. This is the puncture. I mentioned already that we are in fact putting all wire or the pigtail catheter from the radial approach. We are putting the pigtail catheter into the axillary artery, and we are puncturing in fact the pigtail head. So this is how we do the puncture of the axillary artery absolutely precisely. Go next. This is the puncture of the axilla, and now this is the position of the wire into the left carotid artery, and we are doing the same trick. In fact, we are puncturing retrogradely on the neck. Next, we are with the needle, we puncture the wire that is positioned in the common carotid artery. This success will be utilized. Next. This success will be utilized for the position of the chimney from the left common carotid artery will be positioned into the ascending aorta. Next.
Is this sick French seat in the carotid?
In fact, it depends on the size of the chimneys. In fact, in the carotid we put a 7 French sheet. In the right axillary artery is a 10 centimeter because the brachiocephalic trunk is huge. It's 12 millimeter, and the 12 millimeter Bentley precisely require a higher French size. And you saw probably we couldn't go further from the left brachial artery for the left subclavian chimney, but we already changed. In fact, and we are in position. I think we are in a not bad position.
Let's do angio and see.
We are, and we have positioned, in fact, the three chimneys. You see 3 parallel chimneys on the level of distal ascending aorta. And now, by the pigtail that is into the ascending aorta, we are going to make the first injection in order to take a look at the pathology, in order to take a look at the level of the chimneys. Okay, this is the pigtail.
From where do you introduce the pigtail?
The pigtail is introduced by the left femoral. I'm pointing now from the left femoral. And because in fact the arms are engaged with the chimneys, and we don't want to put parallel catheters and so on in order not to make more complex. And we have just a 5 French from the left groin in order to have a good injection. We are going to proceed with the first injection now. Александър, моля те, не дишай за малко. You probably noticed I have a communication with the patient. He is under conscious sedation. Dishai, he is under conscious sedation, and he is supporting very well the conscious sedation without any problem. Probably, let me see, the left subclavian. Definitely, probably you agree. We agree. From the left carotid and the brachiocephalic trunk, it's completely enough to have 1 and 1 chimney. 1 and 1 here. Okay, and the question is, what do you think we have to add 1 more chimney on the left for the left subclavian artery?
Hi, Ivo. It's hard to tell, Frank, in here. But
yes, Frank.
It seems to me that possibly yes, I would say, although it's a little hard to tell.
Yeah. Okay, let's take a look. Имаме ли го или остана в дезелето?
Се опитам да го извадим.
Не, ще го срежем и ще го извадим. The problem is, you saw when we started. Имаме ли друго? When we started, in fact, there was I'm showing now that, in fact, the chimney, the stent graft stayed inside. You see here? Yeah, okay. In fact, the stent stayed inside the catheter. There is no huge problem. We are going to cut the sheet, we are going to cut the catheter, and we are going to crimp again the stent graft over the balloon. And because of that, when we started the live transmission, in fact, we changed the sheet, the 7 French sheet, with the 8 French sheet from the left brachial. And now we are going to cut under fluoro. Okay. Okay. Okay, I cut it, and we are going to give me a scalpel, and I will continue cutting longitudinally. Is it possible, the camera here on the table? I will continue cutting longitudinally the sheet. It's braided. It's not so easy. It's braided. Do we have one more?
Let's try with dilatator to the put out.
Yeah, I see it. I can see the stent graft inside.
Имаше 2 инструмента.
Пинцета ли инструмент?
2 инструмента ще го... Още едно.
You probably... Is it possible to make a zoom? Zoom? Here.
Can they magnify that picture on our screen?
Zoom. We are zooming. We are trying to zoom.
Yeah, but it's still in a little corner of our screen.
It's blurry. It's blurry.
Трябва да фокусира просто на мърдете.
Yeah, okay. You see, it's already seen. It's protruding 1 millimeter outside.
Yeah, we see that.
We are going. I'm sure the old guys like me, you remember that in the past, we were in fact crimping by ourselves the stents over the balloons.
The old days of the Palma stent, huh?
Yes,
exactly.
All us remember that we lose this stent inside the patient and we try
Yeah.
to fish it.
Okay.
Are you trying to do something like a peel away?
Yeah, I did. You see, I'm extracting now the stent.
Okay.
It's already in my hands. And we are going to crimp it like in the old time.
Maybe better if you use a wire inside.
Absolutely. This is the right behavior. It's a very good trick. Yeah, we, not very often, but it happens sometimes. Yeah, to do this. And, okay. Yes. Okay, the stent is over the balloon already. Do you see it? Yeah, the stent is already here, on the right place, over the balloon. I will inflate half atmosphere in order to have better crimping.
And to be sure that the balloon is not perforated.
No, the balloon in fact is not perforated because it was totally outside. So we retracted the balloon totally without the stent. Because there was, it was very, very tight. Probably it would have been possible, but there was a huge tension. And because of that, I decided to change the, and in fact we saw that the stent is partially outside the balloon, and what we have done, we have extracted all the sheet together with the stent graft, and in fact we on the table outside of the patient we extracted the balloon without the stent graft, and it's already crimped. It's already crimped. It's already crimped, and the beauty is that this will be the second stent. So the first one is already positioned on the level of the arch, and this one will be the additional one. So it will be easier to insert the sheet, within the first stent, and to having the protection of the sheet to put this one that I crimped it, to put it inside the first stent.
Okay.
Okay, we are ready to prepare the main body, and in fact we can even put the stent that I crimped, but let's open the hole. In fact, we can now, I mentioned yesterday that we like sheetless implantations because it's making smaller holes in the artery of the patient, and now we are going to open little. We are going to step up. We are going to step up the size of the femoral orifice. Александър, Сашко, няма да е много приятно това, да че го усетиш. Сега ще бъде за кратичко. Ето сега, в този момент. The patient is supporting this bouge absolutely without any problem, even didn't move anything. We are ready to proceed with the main body. Okay. Probably you saw several times the picture of the ascending aorta, and that all the devices are on site, and we have everything prepared. And after having in position the stent graft, the aortic stent graft, I mean, the so-called endoprosthesis. We are going to inflate the chimneys. Сашко, натискам, Александър. Това беше супер. Държиш се прекрасно. Герой си ти. And we like, дай 40 градуса ляво. We are going LAO slowly over the Lunderquist wire. This is one of the biggest invention in the endovascular medicine. This is the Lunderquist wire. I had any resistance, no resistance at all. So the Lunderquist wire is giving excellent support. In very rare cases, we enter even the left ventricle with the Lunderquist wire, but in this situation, we just sitting over the valve. So it's in this situation, in this patient, in this particular patient is enough. And now, the idea, like mentioned yesterday, the idea is the chimneys, the proximal part of the chimneys, to protrude several millimeters beyond the proximal covered part of the aortic graft. And we probably can do a little more left in order to see where the tips of the chimneys. Okay, you see this one, let's say the problematic one has to be moved a little. Excellent. Like Frank mentioned, definitely we need for this one, this is the left subclavian chimney. Frank, what do you think? I think it's absolutely enough at this level. And always we can inject some contrast.
Maybe carotid a little bit.
Yeah, just a little, the left carotid a little bit. I see now the markers of all the three chimneys and they are quite good, and we can probably push a little. Yeah, like that. We are going to make an angio. Alexander, моля те, не дишай, не дишай.
Не.
Injector not ready. Махни го това, куплира. Моля те, не дишай за секунда, извинявай. Давай. Yeah, probably 1 or 2 millimeters more.
Yes.
More proximal.
Maybe better, more advanced the prosthesis.
Absolutely. Here. And also here. I think it's quite enough. Do you agree?
Yes. The nose is not near the aortic valve, then it's okay.
Yeah. Let's put a little nitro. We are going to reduce slightly, we are going to slightly reduce the pressure. It's not high, but it's better to be a little lower. Of course, it's possible to make rapid pacing or temporary occlusion of the inferior vena cava.
Inside the stent grafts.
Okay. Inflate. Петя, служи едно кръче тук на протест.
Този левия картин ще го раздувам последен, за да има кръвоток. И вие почвате да раздувате. Давайте.
Давай кръвотият. Я го спъдни за малко това крути.
Крутият?
Да. No. Ce можем да прибера. It was very strange opening. Дали има още един такъв?
44.
Take care, don't
Yeah.
push the prosthesis.
Yes, we are going.
Don't pull, push.
Push.
No, it's. We have to implant second one.
Yes.
Inside this one.
Yes.
It was unfortunately full stop of the movement of the delivery system. Okay, we are going to telescope. Okay. Give the second. Now it will be tricky to retract the nose cone. It's inside.
Go.
Yeah.
Go in the fast.
Let's see. Okay. Okay, here we can keep the nose. Надолу да видим малко. Keep the wire.
Петък.
Keep the wire. Да виждам върха на... Ето. Keep the wire. Айде втората. So we have the three chimneys opened and we are going to implant, we are going to proximally telescope second endograft. We are going to telescope the second one. Давай лява, много лява.
Отдат напълня с вода.
Да е нормална графия. I want to film the situation.
I think that stent may have dropped into the big ulcer in there.
Yeah, from the left subclavian.
I mean, the inferior part of the proximal portion of the stent graft.
Yes. It's the proximal. It's probably inside the aneurysm. It's not probably.
Right.
It is inside the aneurysm.
Yes.
But also I see that the proximal part of the left carotid stent is not proximal enough.
Maybe good to test where is the end of the graft of the carotid and
exactly
to have an angio.
In fact, it's not bad. Дай на най-голямото увеличение. No, it's fine.
It's maybe 1 centimeter moving.
Okay.
You see?
Yes.
In the strata of the prosthesis.
Yeah. Okay, let's proceed.
We can try to put with the balloon.
Ivo, maybe
Yes.
good to try to align the markers to avoid the parallax.
Дай надолу също да гледа на това.
To try to,
Yes, yes,
to
yes.
play
I
with
understand.
the arch.
Я дай още малко лява. Окей. Фиксирай ми водач.
Фиксиране.
Дръпни го леко водача.
Значи да видим
Дай
долу.
го, дай го напред леко. Давай да видим как върви.
Окей.
Лекичко, е така, намали едно увеличение. Горе да виждам.
Push pull.
Push pull, yes.
This is with free flow.
Let me see. Пусни маска. Окей, на нормална графия.
Ivo, if you
Yes.
move the arch of the X-ray equipment, trying to put the markers in the same line, the
Yes,
marker
yes.
of the graph, to be sure where you will deploy the second endograph.
Дай леко cool down.
Да.
Probably anterior. Or,
По-малко.
no oblique.
Не, дай пак много лява.
The other movement.
Дай леко краниално.
Cranial.
Cranial, yeah, we are going.
Okay, you are near now.
Окей. Върни малко краниалното. Окей, сега ще направим. We are going to make an angio. Ready?
Yes.
Inject. Yeah, the free flow of the first graph is inside the aneurysm.
Yes.
Yeah.
How long is the cuff that you will use?
How long is what?
The second prosthesis. The cuff.
It's 44 by 200.
Okay, the second one.
The second one, yeah.
Yes, to be sure that it will be opposite in the
Yes.
distance.
Absolutely. Yeah. I think to proceed. Имаме ли осмичка стенграфт?
Мисля, че не.
А какъв имаме? 6. Дай още малко нитро. I will reduce a little more the pressure.
So that portion that is in the aneurysm or the ulcer, as we said, that's a bare stent?
Yeah, this is the free flow.
Right, so it would be good to cover that as soon as possible.
Oh, yeah.
And lower the pressure as much as you can.
Yeah, I did it. It will be soon below 100.
It's quite stable, it's pretty good.
Absolutely.
You're in a better area, yeah.
What's like?
Long one to be sure.
Регистрирах.
Yeah.
We open.
Now let's open the stent grafts.
Makes me feel better.
Yes, now it's okay.
Yeah. Okay, 3 of them are open. We disinflate them, and we are going to retract the nose, push-pull. Go
Let's try here. Okay, enough.
Excellent. Excellent.
It's very important to play with the wire.
Yeah, in order to make distance between the graft and the nose. Okay, so we are going to put the big sheet now and to make a quadruple balloon post-dilation. Сашко, натискаме малко.
If you want to put the second stent in the subclavian and after that to do...
Absolutely. This is excellent remark. Okay.
It's okay.
We'll keep.
I'm going to the...
Как си, момче? Вървиме добре, да знаеш. The patient is excellent. Almost fully conscious without any significant complaint, and we are going to put now the crimped by me stent graft.
But I want to put the distal sheet
inside. Okay, just keep there. I will retract the balloon, and the sheet is inside the stent.
Give me the angio, because some of the wire want to escape.
Okay, so now let's see if I was efficient about crimping. Homemade crimping. Now is the moment of the truth. It seems like it's there.
It's still there.
It's still there. And it doesn't want to enter.
Because the catheter is not enough deep in the first stent.
We can take
balloon.
One new balloon.
Yes.
To anchor it. Yes. Remove.
Yes, let's do this.
Remove the homemade device. Къса петица. Или 6. Okay.
Yes. I looked for that.
6 на 60.
It's outside?
No, it's excellent. It's here.
Oh, great.
It seems like I crimped better the stent graft. Okay, we are going to try to anchor now the sheet inside the balloon from the subclavian. Put the Lunderquist wire on place. Yes. Okay. Stay there. Okay, this is Lunderquist. Можем да го щипнем тук.
In the one in front. But this.
Такива големче. Е тук в гънката. Okay. Надуй го. Стави го. We can put a Lunderquist wire.
Dilatator maybe. Dilatator from the sheet.
Well, we can open slightly more the big route to have funnel-like shape. Дай ми 10 мм къс балон, 10 на 40. We are going to open slightly more the chimney in order to have funnel-like shape, and after it we are going to try to engage the sheet and to put the second chimney. It's quite important the patient is doing well. Давай още едно на едно. Enters easily. Okay, inflate slightly, 2 atmospheres.
Yeah.
Disinflate. Okay, let's try.
Hi, Ivo?
Yes, I'm listening to you.
Yeah, we're still watching you, but
Yeah.
we're just wondering whether while you continue to work and complete the case, we should go for a little coffee break here.
Totally agree.
And then we'll be back in 15 minutes and,
Yes,
and see what
excellent.
you've done. Is that okay?
Yeah, absolutely. Agree.
Okay, great job so far.
Okay, thank you.
So we'll go for a 15-minute coffee break.
Excellent.
Whatever you want to do.
Предишната. Не следващата, предишната. 44, 43, 4... Не, отиваше до сега напред. Давай предишната. Назад, назад, назад.
Ivo?
Yes, I'm
We are
listening to
hearing
you.
you. We are seeing and hearing you.
Okay, we'd like to show you step by step what we have done. So we succeeded to extend the left subclavian stent graft. And we didn't like, this was intermediate projection, you see. We didn't like very much the flow into the left carotid. You see, the left carotid, there is some delay in the feeling.
Yes.
And because of that, we added one more proximal stent in order to open the gate. To open the gate just adjacent, this is the crossing with the second short stent opening the gate. Okay, next. Okay, next. This is opening the gate of the left carotid chimney. Next. And this is the post dilation of the three chimneys without the reliant. And now is with the reliant. Next. So this is the quadruple inflation, balloon inflation, in order to oppose all the chimney grafts and the aortic stent graft 1 to 1. And very gentle inflation also on the level of the compression of the second graft. Next, in order to have good apposition. And this is the final result.
Excellent.
This is the final result. We are going to do one more without the reliant, because the reliant there is making an artifact. Okay, I removed the reliant and we are going to be ready. Александър, свършваме процедурата. Моля те, не дишай, не дишай. Inject. You see all the brachiocephalic vessels flow is excellent, and the aneurysm are totally isolated.
Yes, now the flow in the left carotid is normal.
It's equal. It's
Equal,
absolutely
yes.
equal. And that's it. We are going to proceed with closing. What do you think?
I have something to say.
Yes.
To my crazy friend, you.
Thank you.
I watch cases all around the world, and now post-pandemia in my computer and so on. But I never see a case like this. Only one time, only one. This was the last year here.
Yeah.
You have done a similar case. Then,
but in fact, I have learned everything from you. So I admitting that always, you is my teacher, and I will remember that for my life.
When you were working, do you remember Dr. De La Serna?
Ah, yes, absolutely. I remember him.
Dr. De La Serna were the champion of Palma shot stent loose.
Implanté.
And I was a fisherman at this time.
Yeah. Obviously, I didn't forget to crimp stents.
Do you know because why I was thinking about Dr. De La Serna when you were working?
Why? Yeah. Now I understand. Yes. Okay. Thank you, Hugo. Thank you.
A pleasure, because.
Okay, we continue with closing all the vascular accesses.
Ivo, we can
yes.
go to the next talk because we have a waiting
Definitely.
list.
Definitely. Thank you so much.
Okay, great.
Where are we going now? With Dr. Shaw? So next is Dr. Palmer Shaw, who's been waiting for a long time, with the topic, what's new in radiation protection, advancements and future directions.
Thank you very much, Dr. Criado. I'd like to thank Professor Petrov and all the organizers. It's nice to see you, at least virtually, and we're really happy to be here today to be part of the ISCBS session, particularly related to these amazing cases that Dr. Petrov has shown and the complex cases Dr. Provenza discussed. Radiation protection is clearly very important as we make progress in these fields. I have no disclosures pertinent to this presentation. There's been an increase in radiation exposure over the last 25 years from all sources. And in the United States, the Food and Drug Administration noticed a doubling of radiation exposure. Exposure to ionizing radiation of all sources has gone from 3.6 millisieverts in 1980 to 6.25 millisieverts in 2006. They had initiated an effort to reduce any unnecessary radiation exposure from medical imaging, such that it will not compromise patient care, also hoping to increase patients' awareness. More recently, the radiation safety as such an important topic has been reviewed and recommendations have been made in the European Society for how to manage radiation safety. And this is really an outstanding document, and I recommend it, although I won't review it here. Most of you are familiar with the potential damage related to differing doses of radiation exposure to the patient, which may range from skin erythema or necrosis. And here it depends upon the time and dose that the patient sustains, and patients need to be monitored after these larger doses for many months post-procedurally, as these may present at a later time. Also very concerning is the development of posterior subcapsular cataracts from radiation exposure, which can impact the interventionalists. And I've actually heard of colleagues who've also developed cataracts and mentioned this to me in passing. Ionizing radiation damages the dividing cells in the anterior lens epithelium. Then they form a crystalline protein, and then that will migrate to the posterior pole of the lens. And because the lens is avascular, there's really no mechanism to remove these damaged cells. These cataracts, specific types of cataracts, are associated with decreased visual contrast sensitivity, which will pose a risk to an interventionalist career and may limit your contributions. We recognize that the standard use of shielding includes lead aprons, lead shields, lead hats, glasses, and gloves, and it depends upon the operator what they wish to use, but these are available and important to recognize. This is an example of a triple metal gown. This is made of tungsten, antimony, and bismuth. It's very light compared to the standard non-lead and is better in terms of radiation protection. For example, a 1/4 millimeter thick gown, the wearer would get a 3.7% transmission from a 70 kilovolt beam, and then that transmission would drop if the gown were thicker at 0.355 millimeters to 1.7%, and then even a further reduction if it's a 1/2 millimeter thick at 0.6%. This group demonstrated that even the elevation, a simple maneuver of elevating the patient's arms above their head and using an overhead arm support during FEVAR or BVAR can reduce the radiation exposure by 30% without adding to the complexity of the procedure. Other technological advancements are providing us with alternative imaging modalities that can reduce exposure during complex cases. Fusion imaging is well recognized, but not always available in many centers. The REVAR study looked at this and its ability to reduce radiation exposure in operators who are very seasoned, who also use conjointly the ALARA principles, or as low as reasonably achievable, combining that with the preoperative CTA fusion in a hybrid room. In their multivariable analysis, collimation still remained a very important factor that reduces the dose area product emission of radiation. I think this just highlights the fact that even in your center, if you're unable to have image fusion, just a simple thing like collimation can be helpful and reduce the risk. This is a retrospective review of a prospectively maintained aortic database that was performed to identify all patients who had undergone a FEVAR and all endovascular aneurysm repaired using a SIDAR endovascular intelligent map. With this new technology, a cohort using that was reviewed further to select all the FEVARs performed with this guidance. This platform was implemented in 124 complex endovascular aneurysm repairs, including 69 FEVARs. A comparative analysis was performed of the 53 FEVARs with without that, and 63 using that guidance. Ultimately, the use of the SIDAR endovascular imaging system resulted in a statistically significant decrease in use of iodinated contrast volume, patient radiation exposure based upon dose area product, and the cumulative air kerma levels for these patients. This is technology I'm showing that's from Japan. They use mixed reality visualization that is expected to improve exposure dose management for the interventionalist by depicting invisible radiation exposure in real space. The system uses a wearable mixed reality holographic device that provides a simultaneous localization and mapping algorithm for spatial mapping and detection of the wearer's position during a 3D holographic representation of the digital objects with a full sense of depth. The projection of the patient's skin dose onto the patient's body, and as shown here, and the estimation of the health professional's dose will require accurate tracking of their positions and movements in the room. These researchers are able to actually register images in real time by tracking the relative position and orientation of the real objects using an RGB camera on HoloLens. This positional information was then used to update the transformations within the virtual world for dose projection and estimation. To detect the patient's skin dose distribution and operator's eye dose, they used a Monte Carlo system on an external computer in real time. The average patient dose distribution was estimated within 3 seconds, and the distribution is depicted as colored cubes on the skin, and a color bar in the air will represent the absorbed dose level. And the health professional's eye lens dose rate is updated continuously with numerical values in the air, as you see here on the left. This is an ongoing trial, which is a prospective randomized single-center study looking at using the control rad system device that can be installed on an existing C-arm for use with fluoroscopy that will reduce the radiation exposure without compromising image quality in the region of interest. In Canada, researchers are using a new method to guide endovascular instrumentation into the complex vascular structures that were until now inaccessible to endovascular surgeons. The technique involves moving the patient and the endovascular instrument using a robotic platform within a magnetic belt. An external force will then help pull the catheter through the vasculature, complementing efforts to push the catheter and making this easier to advance it into inaccessible areas. With respect to robotic surgery, the Hansen company has used the Magellan robotic system with catheters that are designed to navigate the peripheral vasculature and provide a conduit for the placement of therapeutic devices. This SensiX robotic system uses 3D catheter controls and 3D visualization to allow an operating surgeon to control its robotically steered catheters to collect electrophysiological data within the heart, for example. This artificial intelligence technology made by Omega is used to establish and control the region of interest during interventional procedure. By monitoring the size of the region of interest, artificial intelligence can automatically optimize a dynamic, high-speed secondary collimation that can dramatically reduce the radiation exposure in the room. It can do this far faster than what is manageable by a human operator, and it adapts to the changes of the ROI of the interventional procedures. AI and secondary collimation will work together to increase the radiation safety to the physician, staff, and the patient. Additionally, use of augmented intelligence maps was evaluated in a retrospective review of patients who had undergone endovascular repair of complex aortic aneurysms. This demonstrated a significant decrease in radiation exposure in the AI group with respect to fluoroscopy time, a decrease in the operative time, and a significant decrease in contrast use. And another study, which was a single-center prospective controlled trial using antioxidant treatment by an investigator in Canada, used a combination of 2 grams of ascorbate, 1.2 grams of N-acetylcysteine, and 600 milligrams of lipoic acid, as well as 30 milligrams of beta-carotene. He would administer this to 5 consecutive participants undergoing clinically indicated technetium-99 methylene diphosphonate bone scans for cancer staging. These participants were then compared with 5 participants who did not have that treatment. The DNA damage was visualized in peripheral blood mononuclear cells before and after the bone scans using 3D microscopy and fluorescently labeled gamma H2AX protein. In those patients undergoing these bone scans, treatment with oral antioxidants before scanning can significantly prevent DNA damage that was identified in the mononuclear cells. Antioxidants may ultimately provide an effective means to protect patients and healthcare professionals from radiation-induced DNA damage during imaging studies, and this investigations are ongoing. When you consider the IOP system, or the intraoperative positioning system, this novel endovascular navigation system will minimizes any requirement for contrast or radiation. This gives you a three-dimensional display in multiple different viewpoints, up to 4. Now, we are using this at our institution. There's a significant cost involved to install this technology. Having used this, the current catheters are really larger profiles, up to 8 French, when you may normally would have used a 5 French or 6 French sheath. And so I think that, and there's also some issues with presence of tacks or other things related to mesh placement that cause some artifacts. So I think there is a useful use for this, but I think the technology needs to be advanced. There is some data supporting that it can allow for reduction in procedural times and radiation for routine cases in certain trials. Now, interestingly, the FORS, or fiber optic real shape 3D technology, enables real-time full shape 3D visualization of different devices with unrestricted viewing angles. And this is they can label this in distinctive colors. For example, yellow you see here is the guide wire, and then a catheter would be represented as blue. And then this will minimize significantly the need for use of X-ray as well as contrast. The objective for this is to enable the operator to see more during device navigation and positioning, ultimately performing procedures faster while reducing radiation. At this time, there's 5 sites in the US and 4 in Western Europe, so its accessibility, although very interesting, is still limited. The good news is that in the future, one will be able to visualize in 3D all compatible conventional catheters using this technology once they're combined with the FORS navigation wire and connected to the FORS 3D hub. So I envision that over time, as this technology improves, by the time it's available to many other centers, we'll have the more updated technology available to us. Now, Andy Schanzer and his group at University of Massachusetts has published his experience with the FORS technology for complex EVAR. He looked at 21 different force-guided procedures and compared to 61 non-force-guided procedures. They attempted cannulation in 87 visceral target arteries and 8 for bifurcation graft selection. They had very good technical success rate, 85%, and they were able to do 15 of these cases were able to be done without the use of live fluoroscopy. So really, I would say in conclusion, we need to still be careful with our current principles of ALAURA, collimation, and all the things that we should be doing every day. There have been improvements in shielding, and we need to try to keep up with the technology to always keep in mind the need for radiation reduction for our own health and the health of our patients. There's progress, as I've shown you, although it's coming down the road in the future, I don't think all readily available, but real-time dosimetry. We need to incorporate the use of the artificial intelligence. I know that's a hot topic, and it's been discussed in this forum, and there's more to be discussed in that in the future. Again, technology like this may not be available to all because of restrictions related to cost or the company release. Again, radiation safety is a great concern, and especially to young trainees, many of whom, some women that are dissuaded from entering the field because of concerns related to radiation in pregnancy and other factors. But I believe that this technology will continue to evolve, and I do predict that we will be able to be doing endovascular interventions in the future, either without radiation at all, robotically, or with very minimal risk. Thank you very much for your attention.
Thanks very much, Palma. That was an excellent review and an update of this very important topic. So we'll let you go, and thank you for waiting so long to give this talk. See you soon.
Thank you.
Thank you.
Not sure what's next.
Hi, good afternoon. For those who don't know me, my name is Ana Otero. I'm a vascular surgeon from Colombia. Right now, I'm the president of the Colombian Association for Vascular Surgery. And I'm going to talk to you about non-A, non-B aortic dissection, options for endovascular and hybrid repair. Right now, I'm the president of the Colombian Association for Vascular Surgery, and I'm also a member of the ISEBS, SBS, and IDF. So I want to thank everyone for inviting me to this talk. My disclosures for the subject is that I've been a speaker for two aortic. Non-A, non-B aortic dissection is a rare condition. It only happens between 3 and 11% of the acute aortic dissections. Because of the location of the aortic arch, those are challenging procedures, and classifications don't do us justice. Why? Because in spite of us using the new SBS, STS classifications, there's still dissections that happen just above the ascending aorta and just before the arch. So there is no classification that can get us into that. The first one who talked about it was von Segeser in 1994. And as we know, is an intimal tear beyond the ascending aorta. Type A, we know, is an emergency with 50% mortality in the first 48 hours. Type B, generally managed as an uncomplicated medical, but there's patients with high risk features that we've already discussed. In complicated type B, we know that it is T-bar, and in type A, we are every time getting into more endovascular, but nowadays it is open. So what happens with a non-A, no-B? So as I was telling you before, classifications don't do us justice. This is the new classification of the SBS STS. And the other one is the classification we use the most, which is the Stanford classification. So there is a place for this pathology that is not described in that kind of situations. And because if it is rare just to find that specific kind of dissection, there's no place to put it in guidelines. And it's not only the location, the epidemiology and the type of patients are different. These are younger than type A, which a median of 59 years old, which they do not do good with medical management. 60% we know that have type B aortic dissection can have a retrograde progression, and with surgery they would have better outcomes. 88% of non-A, non-B are going to be complicated, with 21% with malperfusion syndrome. So in its pathophysiology and its natural history, it's a total different disease of the aorta. In the treatment of aortic dissection, this non-A, non-B, we know that the gold standard is the open surgery. But nowadays we have newer devices, endovascular devices, that we can be using them in difficult cases. So we have T-bar with the proximal landing zone that it's good. We have complex endovascular repair, extrathoracic transposition in 18% of the patients, parallel stent grafting that it's been used in 36%, which do have complications, in situ fenestrations, branched stent grafts, and hybrid procedures like the frozen elephant trunk. Another kind of strategy to solve this problem is doing T-bar with parallel stent grafts. I'm talking about periscopes, chimneys. Sometimes when you do chimneys, you have to do a carotid subclavian bypass and then do a chimney for the left subclavian artery. The thing that is amazing about this is that you can use this as off-shelf devices. You don't have to do fenestrations or modify these sort of devices on table. So although these were thought as definitive procedures, sometimes we went to the other side to think that these only were supposed to be used in emergency settings. But sometimes, because of the complexity of this kind of patients, those are going to have to be made to last for a long time. The idea of this is that you want to gain proximal neck. The first one to describe this was Greenberg. The downside of this is that you can get type 1A endoleaks, and because of the manipulation of the whole arch, the risk of stroke, it is there. The endoleak, you can solve it with a kissing balloon that it's going to diminish the gutter and getting anterior to the arch vessels, maybe 2 centimeters, so that the graft gets very well positioned towards the aortic wall. There's studies that tell you that there's 0% mortality at 30 days with 80% success rate. It is a minimally invasive. You preserve the arch. The midterm outcomes or results are good. So I do not agree that it should be only used as a bailout or emergency cases. I think that nowadays, because we're getting better with custom devices, we get to think that this is only for that, but there's also patients, because of their age and the way the anatomy is, we can offer just this. And for me, this is some of the most exciting technologies. Some of them are not available in the States or Latin America. That's where I work, but they are in Europe. So you have branches and fenestrations. I think that the ones that are doing it like more often are Terumo, which is was Bolton a few years ago. So it's a platform that it's relay MBS with nitinol and polyester. It has a dual sheath, so you can go to zone 0 to 2 with a single, dual, or triple branch. The mortality is 25% with 87.5% of freedom of endoleaks. These stents have a lock mechanism which prevents stent migration. As I told you before, we have it in Europe and Latin America, and we are supported by the results of the RESTORE 1 and 2 for acute and elective aortic aneurysm repair. We also have the quick fenestrated endograft, which is ongoing, and the Mona from Medtronic. Gore has another one also, but these don't have FDA so far. And as I said, the more the merrier, because sometimes some devices are difficult to handle, and you get the feeling of what you're doing. And if we have more designs, I think that we are going to be able to treat more of these patients in a better way. Talking about hybrid aortic repair, this is useful when you have an intimal tear that's proximal to the ascending aorta, but it doesn't involve it. You have to reroute the arch branches to get to a zone 0 TEVAR landing. It's about 21% of surgical cases with a mortality that's 6.7% and a morbidity that's 7.7%. If they don't have a retrograde dissection. You could also consider doing a complete supraortic debranching or a partial debranching with mortalities that go around 4.4% in 30 days. With in-hospital mortalities as high as 11%, technical success 87%, with early endoleaks or late endoleaks. Freedom from reintervention, 91% the first year, 81% second year, and a complete debranching with zone 0 landing. It's a procedure that it's not innocuous, it has a high mortality rate. And last but not least, there is the ascending aorta arch replacement. They have to do an antegrade stent graft of the descending aorta. It's a hybrid procedure with favorable remodeling of the distal aorta. The thing is that you're going to have a stable proximal landing zone. So the possibility of having a type 1 endoleak is none. The disadvantages: surgical trauma, extracorporeal circulation, cardiac arrest, myocardial ischemia. So it's a very large procedure. But when you need it to be done, you can also do it openly with a classical elephant trunk. The advantages of the frozen elephant trunk is that you can have the end of your prosthesis ready for continuation of the procedure. So when you have a concomitant ascending aorta dilation, when the debranching is not good because you don't have a proximal landing zone, when you have a connective tissue disorder and the life expectancy is larger than what you're supposed to. So to finish this talk, I'm going to tell you that non-A, non-B is a small part of the dissections that we treat every day. Because of that, the literature is not huge and the quality of it is not going to be a huge control trial about it. So the classifications that we use right now don't fit this kind of pathology. I think this is a better behaved dissection than a type A, but a worse behaved comparing to a type B. That's why you need a multidisciplinary approach. That's why we do surgery with cardiovascular surgery, cardiovascular anesthesia. The intervention, they do better with surgery compared to medical treatment. And endovascular devices are changing, so I guess in a couple of years we're going to be talking more about this kind of procedures that are new for us. We need prospective studies comparing open and endovascular endovascular procedures, and it has to be tailored to every patient. And again, thank you for inviting me to BEC. I would love to be there in person in Sofia. See you later.
Okay, Dr. Petrov will give us his conference from the hospital. And I think that he will talk about, let me see. Chimney in the arch, practical approach for success, maybe about this.
Dr. Lundero.
Yes, I am
Dr.
here.
Criado. Unfortunately, there is a problem about uploading. It's better, Frank, to give his lecture, and in the meantime, I will try to reach you and to give the lecture after that.
Okay, no problem.
Yeah, this is the best way. Yeah, okay, I'm coming.
Oh, well, Dr. Criado will talk about the continuing problems with AAA management, how to measure, when to treat.
Okay, thank you. I thought the time would never come. So we're going to change gears a little bit here with this topic. I don't have any disclosures to make, by the way. When we think of the risk and the dangers of an aortic aneurysm, specifically an abdominal aortic aneurysm, many vascular surgeons today and other vascular specialists think of these numbers because we kind of grew up with them, literally. But they are all figures. Look at that, the correlation of annual risk of rupture with diameter. 4 to 5, 0.5 to 5%, 5 to 6, 3 to 15%, blah, blah, blah. You can see it there. But look at the bottom of that publication that is a foundation for that chart was 20 years ago. Current rupture estimates are quite different, reflecting mainly three things: a closer scrutiny of contemporary series of patients, mainly a systematic review, more than one, of medically unfit patients with large, untreated aneurysms that have revealed a lower than expected, surprising really, rupture rate and mortality, beginning, of course, with the EVAR-2 UK trial. And underlying to all of that is an apparent global ongoing decrease in both AAA rupture rates and AAA prevalence all over the world, especially in the Western world, but it's happening everywhere. And it is suspected that it's largely related to the decrease in smoking habits. So the new contemporary figures that have emerged indicating a much more realistic annual risk of AAA rupture that we should begin to learn and keep in mind. That is not to say that aneurysms are not dangerous, but they are not the time bombs that we keep talking about and scaring patients with. Look at that, less than 5.5%, 1% or less per year. 5.5 to 6, 3.5%, and on. Larger than 7 centimeters, 6% and higher, depending on the diameter. Now, I remind you that this is annual risk cumulatively. So for instance, if you have an aneurysm in the 5.5 to 6 centimeter range, the annual risk is 3.5%, but over 10 years, on a patient who is likely to live a long time, like many do today, over 10 years, it will be 35%. So still quite a dangerous lesion and one that deserves treatment. But generally, to talk about the ticking time bomb concept or the unexploded grenade is really counterproductive because it is unnecessary to inject such excessive fear in the minds of patients and the population at large, and unhappiness. People become unhappy, said, I have this ticking time bomb inside of me. Who wants to have that? And the result could be a rushed, not thoughtful, faulty decision-making vis-a-vis treatment and intervention. However, this hasn't changed. If you have a big aneurysm like this, it is going to kill you, and soon. So that needs to be treated urgently, if not emergently. That has not and will never change. Now, where did this 5.5 centimeter diameter that we have been married to for so many years, and we keep talking about like a religion, came from? Well, you might be surprised, some of you may know, but I suspect not too many. It is a largely arbitrary number, especially surrounding the UK aneurysm trials organized in the late 80s and early 90s, quite a long time ago, more than 30 years ago now, where some were voting for 5 centimeters because that was the gold surgical standard for decades, 5 centimeters. Others say 6, and they couldn't get an agreement, so somebody said, let's just make it 5.5. Done. Deal. And it was 5.5, and it continues to be 5.5 today. It's not a bad number, but it is quite arbitrary. There's nothing religious about it. Now, what about surgery versus observation alone, or surveillance, as it is called? Well, there are 2 trials that we all are aware of, although have forgotten because they were done quite a few years ago. The UK SAT, United Kingdom Small Aneurysm Trial, enrolled more than 1,000 patients, the first recruited in 1991, and the ADAM trial, with 1,100 patients, the first recruited in 1992. Both these trials reported early on in 1998 and 2002 respectively, and both show that surveillance of small aneurysms, meaning less than 5.5, is safe and better than elective early surgery. But what about EVAR? When EVAR came along, a less invasive intervention, wouldn't that do better? Maybe it makes sense to treat them smaller, since now we have a safer intervention. Well, further trials were done, especially these 2, the pivotal and the CESAR trials in the early part of the first decade of the new century. Both studies concluded the same thing. The surveillance was really better. There was no need to treat whether it's open surgery or EVAR if the aneurysm is small, meaning less than 5.5 cm. Something else that I think is quite useful to have an old guy like me remind you of is that the current 5.c diameter standard threshold, the arbitrary number we talked about, was arrived at in those studies that used ultrasound measurements and imaging with inner-to-inner ITI aneurysm measurements. Remember, when you include the aortic wall, you add a minimum of 4 to 5 millimeters. And remember that today, we really don't use ultrasound except for surveillance. We use CT, right? And CT is OTO, is outer to outer. So you cannot use them interchangeably, although most doctors do, most specialists do. And they are not the same thing. All right? So we have to keep that in mind, and there is ample published evidence about the validity of what I just said. The Laplace law has been and continues to be applied to the risk of aneurysm rupture. The law of Laplace states that there is a linear relationship between diameter and wall stress, often applied to AAAs and other such lesions, to calculate the mechanical stress on the wall. However, Laplace did not have an aneurysm in mind when he was thinking about this stuff. It applies really to cylindrical geometries like that balloon. It applies perfectly well to that. Aneurysms are complex, non-cylindrical, non-homogeneous structures, and you cannot expect this law to apply very effectively to such a lesion. Now, what is wrong with using diameter alone? Because I'm going to be critical of that, as we have been using for a long time. Well, there is variability, inconsistency, and I have mentioned a few of them already. There is a CT versus ultrasound, as I said. We know now that small aneurysms can rupture, and large ones can remain stable, unexpectedly. Diameter alone fails to take into account geometry and aortic wall stress and strength that at the end of the day is what really determines the rupture risk of an aneurysm. A rupture is not a global aneurysm phenomenon. It's a focal, pinpoint phenomenon circumscribed to one small area where the strength is low and the stress is high. So that's what matters the most. That's why for 20 years or more now, there has been an increasing effort in finding better parameters, better ways of looking at this and assessing rupture risk, wall stress, vessel asymmetry, FEA, fine element analysis, rupture potential, other things that you have there, including the thrombus, the amount of thrombus and the shape of the thrombus in relationship to the lumen. That, as it turns out, is quite important. There is this thrombus deposition index that when it is asymmetrical, it can really cause problems, and I'm not going to dissect that out, but this is quite intriguing, and apparently it's going to be one of the main things we do in the future, or we have available to us, to assess risk of an aneurysm. Several of these new approaches to rupture risk rely, therefore, on biomechanics and numeric mathematical models to quantify the threat of rupture. Overall, AAA wall stress in the aneurysm has been shown to be independent of maximum diameter. Isn't that interesting? Hence, the general understanding that more than size alone should be considered in rupture risk evaluation. And I'll present to you at the end a case from this very important publication from almost 10 years ago of an 88-year-old man with a 6-centimeter aneurysm. He was offered elective repair, but he declined for personal reasons. As we all know, that happens. Some people just don't want to be treated. He had, however, a complete CT with all this sophisticated evaluation determining the areas of wall stress that you see in red or orange color on the left-hand side and posteriorly in the sac. 4 months later, the AAA ruptured. The patient became hypotensive and critically ill. He was on his way out to death. The aneurysm had expanded to 6.5 cm. However, unfortunately, they operated on him and he recovered. Biomechanical analysis performed showed that the preoperative study 4 months later, as I showed you, could have predicted the exact site of rupture, where the patient eventually ruptured, as you can see there. So this is a kind of thing that everybody says we are going to have more available, not just to research centers around the world, in order to refine our indications. Finally, it must be seen clearly, very clearly, that most of what I just said to you applies to men. Women are different, don't we know it? The prevalence of AAA is 3 to 4 times higher than in men, and yet about 1/3 of all rupture aneurysms occur in women. In women, the aneurysm growth rate is faster, the rupture is 4 times as likely during surveillance, and the risk of fatal rupture is 3 times higher. And once rupture occurs, women face worse than men. So we ought to be, should be, must be more aggressive in the management of aneurysms in women. Thank you very much.
Пускай го, не, няма значение, пускай го, няма какво да видя, пускай го. Няма значение.
I have a presentation related aortic arching. It's very much related to what we have done. Okay. Веднага след.
Okay.
Yeah. By the way, such a triple chimney arch is not an easy task. It's not. Yeah, it's not an easy task. And yeah, probably the most important is the oversizing, because otherwise there is a possibility of gutters that will allow the flow and the pressure to enter the anus. Exactly, yeah. And the rule is half of the sum of the diameters of the chimneys. This has to be in millimeters, the oversizing of the aortic graft, in order to accommodate.
Sacular or saxiform aneurysms is good.
Yeah.
Fusiform aneurysms are more difficult to seal.
Absolutely, yeah. And the sealing was practically immediate. In fact, you probably saw that the aortic graft, because it's extremely oversized, it's in fact entered, and like it was a coverage of the wall of the aneurysm, because it was an indentation inside the aneurysm. And it's in fact improving the sealing. It's improving the sealing.
Use the microphone.
Yeah.
We are in family
Okay. Last enthusiast, thank you. Thank you for staying. Thank you for staying with us on Sunday evening. Okay, chimney technique for dealing with total arch lesions. In fact, my presentation is related to even more complex by clinical point of view the scenarios. These are the so-called redissection or residual dissection. Unfortunately, the so-called proximal surgical intervention, proximal sealing, in most of the cases is not sufficient to resolve the problem of the aortic dissection. And unfortunately, in case of a need for redo procedures, even in the most experienced American and also Argentinian the surgical teams, in fact, the morbidity and mortality of a redo procedure is quite high. So such technique, as shown here, the branching of the brachiocephalic vessels plus aortic stent graft is absolutely possible, but in fact it's again surgery. So it, in case of a redissection, even the hybrid approach is quite risky. There are several meta-analyses comparing surgical versus hybrid versus totally endovascular. And totally endovascular risk is definitely not zero, but it's relatively lower compared to the hybrid. And in this publication, namely, is mentioned the chimneys technique as one of the options. This is another meta-analysis showing quite good results regarding the chimney technique for the residual aortic dissection. And in the guideline of the European Heart Journal, the advice is endovascular stenting instead of surgery if anatomy is suitable in case redo procedures are needed. Of course, the arch is quite challenging landing zone. So how to expand the landing zone more proximal? In fact, it's possible to expand with branched grafts like Nexus. Unfortunately, it's not available in Bulgaria, and it's extremely expensive for us, for our healthcare system. So different kind of chimneys, snorkels, and parallel grafts and so on are possible in such a situation. And what we have shown, the 3 chimneys parallel to the aortic graft, it's one of the most complex procedure. This is our local, my team, growing experience with aortic interventions. We published our chimney technique with predominant way of treatment for acute redo procedure of aortic dissection. I'm just showing 2 cases, and we'll finish. A 57-year-old male with a chest pain and dizziness during systolic pressure above 140. He had a history of open ascending aorta surgery because of type A aortic dissection. Unfortunately, because of this clinical scenario, there was a CTA evidence of redissection. So just above, just beyond the surgical graft that was implanted in the, it's very well seen, the surgical graft, and just above the surgical graft, on the edge of the surgical graft, there is a dissection again. And unfortunately, the dissection was compressing the true lumen into the carotid arteries, and because of that, during high pressure, he had dizziness because of the compression of the false lumen to the true lumen. What to do in this situation? We commented already that both surgical and hybrid are quite risky, And it was, I think, 4 or 5 years ago, we decided to do totally percutaneous approach. It's seeing the sternal wires after the previous surgery. So right brachial approach for the brachiocephalic trunk, conscious sedation, retrograde puncture for the left common carotid, femoral access closed with manta, and carotid access closed with a ProGlide vascular closure device. And this is, in fact, the puncture of the carotid and the puncture site after putting the stitch-based closure device after the procedure. So it was very similar to what we have done, with the difference that in this case we didn't put a left subclavian artery chimney because there was no need. Which, it's very important in such a situation to take a look on the CT angio, the communication and the size of both vertebral arteries and how good is the connection between them on the level of the basilar artery. And in this situation, we have covered more than 300 left subclavian arteries without any clinical problem. In most of the cases, there is a reduction of the left arm pressure between 40 and 60 millimeters of mercury. That is nothing dramatic regarding the left arm the situation. And in fact, what I was showing here, it was the position of the aortic graft parallel to the two chimneys, the left carotid chimney and the brachiocephalic trunk chimney. And this is the final. You see that the true lumen is very, very well expanded, and practically the false lumen disappeared both on the level of the carotid and on the level of the distant aorta. And this is the CT angio control after the implantation. The second case is a 69-year-old, again male, with enlargement of the false lumen aortic aneurysm. Actual size, you see, more than 10 centimeters. It's a very complex case. He was, again, operated a long time ago, more than 10 years ago. After the operation, we have implanted, as a part of a trial, multi-layer flow modulation cardiatis into the true lumen because of this huge compression of the true lumen. And he was in a critical condition in that time with visceral ischemia, ileus, critical ischemia of the lower legs, and in fact the MFM cardiatis implantation saved his life. Unfortunately, on the level of the arch, you see that the evolution, I would say the bad evolution of the false lumen continued, and he had 10 centimeters false lumen compressing the true lumen in the arch. And on a similar way, we decided to make a chimney style intervention, again puncturing the common carotid, left common carotid retrogradely, and putting the chimney from the right arm into the brachiocephalic trunk. And also in this situation, we pay attention also to the left subclavian artery, and you see how big is the false lumen. It's a huge aneurysm of the false lumen. And this is the stent graft coming from below, and it was telescoped toward the MFM and the graft that was implanted in the past several years before this procedure. There was consecutively MFM, and after that Valiant Captivia implanted just below the subclavian artery. This is again the ballooning of aortic graft and the chimneys in order to have a good apposition, and this is the ProGlide closure device closing the left carotid artery like we did today. And this is in fact, in this situation, our colleagues from vascular surgery, they have done carotid to carotid bypass that was absolutely patent. And as a conclusion, the open surgery remains the gold standard for the treatment of acute thoracic aortic dissection. Endovascular options are emerging as viable option in treatment of complex cases of aortic dissection type A. Chimney technique with total endovascular approach and conscious sedation resulted safe and efficient in patients with type A re-dissection considered high surgical risk, and new promising technologies like branch grafts, fenestrated grafts are appearing on the market. Thank you very much for your attention. Thank you. Questions, comments, some proposals to improve something? Okay.
I think that a very important rule is the rule to select the diameter of the graft. Can you repeat it?
Sealing. This is excellent point. This is the most important to have very precise calculating of the size of the chimneys and also the aortic graft. It's very important because in more chimneys we implant, more oversizing we need in order to have invagination enough of the tip of the graft in order to accommodate in this invagination with good sealing the chimney graft. Otherwise, there is the possibility of gutter around the chimney that will continue filling the dissection or the aneurysm. So this is crucial to have good sealing.
The rule is half of the diameter of the chimney?
Half of the sum of all the chimneys. This is the number that we have to add to the diameter of the aortic stent graft. So this is the oversizing.
The estimated diameter of the aorta.
Of the aorta. Yes,
the
exactly.
diameter of the arch.
Of the proximal landing zone. Yeah, this is the rule. To have tissue, sufficient tissue to accommodate, to surround the chimney in order to have good sealing.
2 weeks ago, I did a T-branch in an thoracoabdominal aneurysm, and I put a cover stent to connect the branch in the mesenteric superior artery, but I need to put another stent, but I lose the position with the sheet. I tried to re-enter the sheet assisted with an anchoring balloon, and I couldn't, but I did another maneuver that is very important to do with dilatator.
Exactly. We are doing many times.
The bias, but I couldn't. I do many maneuvers, but I put 3 wires, 018 wires, and I leave the sheet outside, but in the proximal part of the first stent, and the other stent goes down.
Yeah, body wires.
Triple wires.
Body wires. Yeah, it's one of the tricks that can be applied. I see Professor Stankov is here. It means that everything is good with the patient. Yeah, excellent. Not in the ICU, but in his room. Yeah, in the ward, in the ward. In fact, we don't have the practice to send the patient to ICU. After conscious sedation, in case the hemodynamic is fine, the consciousness is fine, the patient is sent direct to the ward. Axillar, we punctured the head of the pigtail that was introduced by the radio. We punctured the head of the pigtail. And this one was 8 French? 10 French was the carotid. And we closed it with angiosio. And angiosio, yeah. Femoral with manta. But like I have shown in the presentation, ProgLite is fine. ProgLite is excellent. It's possible both. Both is possible.
I have something to say related on this complex procedure. We have here a very interesting talk about radiation. About radiation protection. After 60 years working in the cath lab, I have activated hyperplasia in the hands, in the arms, in the legs, in my head, in my face. I have had vasocellular cancer in the leg. I have not my thyroid gland. And then, please, protect yourself during the procedure.
Unfortunately, we don't protect too much.
When you done this procedure, it is not important to protect. You have not any sensation.
Totally
But
agree.
years after that, you will have problems.
Totally agree. Totally agree.
Then protect yourself.
Yeah. Okay. Thank you. Ah, yes. Yeah, fusion with the CT is a very nice tool. Yeah, very nice tool. It's to overlap the CT angio over the angio screen. Okay, we probably have to proceed with the Medtronic. Is it possible to have national TAVI registry? In fact, we are trying. We had a very nice meeting yesterday regarding with the MedTech Europe. It's in fact a very important institution on European level, stimulating the application of new technology on time, digitalization of the healthcare. So all these features that are quite difficult to happen in Bulgaria, but our endovascular society, with the support of Medtronic, we are in the beginning of our way to have a TAVI registry, and the plan is the TAVI registry to grow with aortic registry, and after that to grow with carotid artery registry. So this is the first stage, like I'm putting here on the slide. And my young colleagues Hristo Angelov and Petar Polomsky will help me to explain more about the registry. In fact, we have helped a company, a software company, to elaborate a national TAVI registry. We know that the European TAVI registry is almost prepared as well. So, but it depends on the policy what kind of registry we are going to fill. But our dream is the TAVI registry to be completed and to be filled by all the teams dealing with TAVI implantations, in order to have data, in order to have more data regarding the implantation and also the follow-up. And the project goal is exactly that, to have on a nationwide more data regarding the practice of endovascular intervention, starting with the TAVI, with the implantation of transcatheter aortic valve, and to have the possibility to extract the statistics data and to have conclusions after the filling of the data. In fact, the integration with the hospital information system is one of the biggest challenges. We have elaborated a task for the company doing the registry to have the personal data by the hospital information system to enter automatically into the TAVI registry, in order not to have to fill the data since the beginning, and to be easier for the team doing the registry filling data, because the motivation of the physicians is not very high. In fact, to have additional job. We, the doctors, we don't like too much to write, so we prefer to do the things and not to write them. And implementation of the entire process and workflow of the performing medical procedures with the participation of patient, doctors, state institution. This is very important, to receive the support from the institutions of our professional effort. So hopefully this effort will meet, let's say, the approval of the institutions, in order to have really the final good result. And I would like to ask Dr. Polomsky and Dr. Angelov to show us how the TAVI registry is working, that in fact it's already done. We can switch to the laptop.
So, dear college, this is how TAVI registry looks like now in real practice.
every physician can log in with his own credentials. So after login is done already, he is able to see all the patients performed before. I will just try to set up the English to the language to English. Okay, it's English right now. So every physician can log in with his own credential and can see what is already done in his institution. Here are the patient, for example, for our institution, and now we use the first patient, which is not real patient, it's only a test patient, in order to show you how a new procedure can be created. Here is the button. The physician choose the date and the number of hospitalization, which are mandatory things, and after that he is able to fulfill some fields according the patient. The first part is patient general info, which is already fulfilled directly from the database. After that, the physician must fulfill the general clinical data from the hospitalization, also data about the previous procedures about the patient, the diagnostic of the procedure, most of the things like ECG, baseline echocardiography, etc. Only the crucial fields such as rhythm of the patient, mean gradient through the valve before the procedure, aortic regurg, etc. are marked as mandatory. You can see the red star on the upper line. So because of that, the physician must actually choose if he won't or if he wouldn't put the additional information that is not crucial, for example, about the mitral regurg or some laboratory tests. Also, in some patients, such information is not available. So this is why this option is already chosen. Not every field to be mandatory about the patient. Here is the information about the procedure itself that the physician must done, and next is the information during the discharge of the patient. So that's.
I just want to add that the data that we collect now, we can do it really fast, especially if you're doing it in the same day during the procedure. My time for filling a patient is 5 minutes. As far as I know, your time is similar.
Yes, 5 to 10 minutes. Regarding to
absolutely. How many information are you going to add? And if we go straight only for the mandatory data, it's really fast, and it's something that it's not going to be such a burden as all of the data that we used to add in our own registries, because every hospital has its own registry that we follow up our patients with. With that registry, we try to make it as simple as possible, so it could be easy, and not only the doctor should perform it, but even if a nurse or a Röntgen laborant wants to participate, again, it's going to be possible for him. Also, we are going to add here, it's not still visible, but we will have additional labels for the follow-up of the patient, not only at the discharge, but we are going to add for 6 months, 1 year, and so on for the hospitalization, echo criteria, and if everything goes smooth with the patient. Also, it's possible to download all of the data that it's generated inside the register, so we can perform analysis later and get our own statistics. Also, if it's needed in future, and if you want to add our data to the European registry, we can pull the data easily, because all of the data that we decided to add is part of the data that it's going to be mandatory for the TAVI registry for Europe. So we can be one, we can have our own registry, which can be part from the common registry for Europe.
Well, we are finishing this long session. I can say that the case that Dr. Petrov has done was incredible, but the patience of the audience was unbelievable. Then thank you a lot.
Okay, dear colleagues and friends, thank you once again for being so patient, and thank you for your interest. And at least at that moment, I have received quite a positive feedback about the conference with several colleagues from abroad willing to bring more people from abroad, not only from Bulgaria, and presenters from all over the world, but also participants from the surrounding countries. Vasco?
It was amazing but exhaustive 2 days. So thank you, everyone, and safe trip home. It's our wish, and to reappear again here.
In 1 year.
In 1 year. Thank you.
So see you, all of you, in 1 year. And Hilton not anymore in construction.